Okay. So, good afternoon, everyone. Welcome to the day two's classes. So, we'll be continuing with topics from hematology, which we had started yesterday. So, we will be continuing with the next topic that is heparin-induced thrombocytopenia and thrombosis. This is one of the questions they quite commonly ask. Okay. So, coming to the outline of the topic, I'll be discussing under the following headings: it's definition, pathophysiology, clinical features, diagnosis, management, and new modalities. Okay. So the most of the illustrations that I've used in this presentation is directly from an article from ISTH. Okay. So I will be sharing the details of the article in the end of the slide, so you guys also can go and download that article and read. Okay. So, heparin-induced thrombocytopenia and thrombosis is defined as an immune-mediated adverse drug reaction, which is an event occurring after an exposure to heparin that results in thrombocytopenia and potentially catastrophic thrombosis. Okay, so it is nothing but an immune-mediated adverse drug reaction that causes thrombocytopenia, catastrophic thrombosis. The incidence usually it is majorly seen in cardiac surgeries where the use of heparin is very high. Okay, major cardiac surgeries, and it is seen in 1,500 hospitalizations. And from the US data, it is seen both in unfractionated as well as low molecular weight heparin. Having said that, the proportionality of incidence is higher in unfractionated heparin as compared to low molecular weight heparin. What they have found out is if the exposure of heparin is usually a shorter period, then the possibility of development of HIT is also lesser. Okay. So coming to pathophysiology of heparin-induced thrombocytopenia and thrombosis, we all know heparin, either it is unfractionated or low molecular weight heparin, both are negatively charged polysaccharide chain, which has an anticoagulant property. When this merges with the platelet factor 4, which has been released from the alpha granules of an activated platelet, they form a neoantigen because this platelet factor 4 is a positively charged chemokine. Okay, so a negatively charged heparin, a positively charged chemokine like PF4, they combine together by electrostatic interactions to form a neoantigen, which is called as the HIT antigen. And we all know whenever there's an antigen, the immune system gets activated and an antibody is formed. Okay, so the antibody which is formed to this neoantigen, that is your HIT antigen, is called the anti-PF4 heparin antibody. Okay, and this causes all the catastrophic events. Okay, this is the immune mediated adverse drug reaction to heparin. Okay, so this is the baseline or the initial trigger event for heparin induced thrombocytopenia thrombosis. So once this antibody forms, how does it cause thrombosis and thrombocytopenia? So we will know about that in the further slides. So we all have to know HIT is an immune mediated reaction which usually occurs from 5 to 10 days after the exposure of heparin. It is triggered because this neoantigen is formed by heparin and platelet factor 4, and it causes release of platelets and it makes them activated platelets. Okay. So usually the type of antibodies which are produced against the neoantigen, that is the heparin PF4 complex, is an IgG type of antibody, and these are the culprit antibodies. Okay, compared to the other type of antibodies like IgA, etc. Okay. So IgG antibodies usually form immune complexes along with heparin and PF4 complex. Okay. So how do they form that? These immune complexes bind to the Fc gamma 2A receptors on the platelets. Okay. So the Fc gamma 2A receptor is present on a platelet, and this platelet would be converted to an activated platelet. And what does happen when we have activated platelets? It is definitely going to cause procoagulation. Correct? How does it do? It will release more factors, granules, aggregations, etc. Correct? So this causes a self-amplifying loop. Okay. So how does it cause thrombosis? It causes it by widespread activation, aggregation, and consumption. And because there is consumption of platelets, there will be thrombocytopenia. And because the platelet granules are releasing a lot of chemokines, it turns it into a procoagulant state. Okay, the tissue factor, etc. All of this would get activated. And because there is a procoagulant state which has been triggered by this immune response, it causes thrombosis both in the venous as well as the arterial system. Okay, and this thrombosis occurs despite a falling platelet count. Okay, so the next part of this is, with all this immune mediated reaction happening, a lot of endothelial damage being present, it just triggers a vicious cycle, and this contributes to a lot widespread multi-organ dysfunction. Okay, the paradox of HIT, that is heparin induced thrombocytopenia and thrombosis, is there is thrombosis and not bleeding despite the platelet counts being low in cases who have developed this adverse drug reaction. Okay, and the main important thing is you need to stop heparin because that is the driver of all this thrombogenic cascade. Otherwise, this patient can have risk to limb or even life. The next important question is, earlier I told you the neoantigen produces antibodies, and most of the times IgG type of antibody is what is produced majorly, and this goes and activates the FC2 gamma receptors on the platelets, correct? So do all types of antibodies do it? No. Okay, usually the IgG type is the one which causes the uh, immune response. Okay, other things like other immunoglobulins like IgM and IgA rarely cause hit. Okay, so if someone asks you in a practice what type of it is it, usually you have to mention it is the IgG type. Okay, IgA, IgM do not cause it. And why do we talk about IgG? Because usually they are ultra large molecular complexes, and these are the ones which have the higher propensity to cause immunogenic reactions. Okay, so this is one practical question that I want you to remember. Okay, so this is about pathophysiology of heparin-induced thrombocytopenia and thrombosis. Coming to the clinical manifestations and outcome, we all know thrombosis is usually the major manifestation of HIT, and it is one of the important criteria for the diagnosis as well. Okay, so usually whenever you have a patient who has undergone a major surgery or has been exposed to heparin for any reason, and then you see a drop in platelet count, then you have to look in all these manifestations. Okay, if you've looked into the patient's details history, okay, and then you examine the patient and look at the laboratory parameters, if they are correlating, then you have to have a suspicion. So in clinical examination, what do you find? Thrombosis, majorly arterial or venous, both are present. Okay, so venous is predominant as compared to arterial most of the times, but both can be present, and the risk of development of thrombosis is as high as 60%. Some patients can have bleeding. Limb loss would also be there, usually because of a thrombotic event. Okay, unexplained loss. Then on evaluation, we would know that. Worst case scenarios, the patient can have increased mortality and length of stay in the hospital. Okay, rarely these heparin-induced thrombocytopenia and thrombosis can mimic DIC or necrotizing fasciitis like lesions. Okay, so few anaphylactide reactions can also mimic HITT. Okay, so these are the DDs that we need to remember in the initial phases when we are working up for HIT. Okay, so ideally look for history, exposure, duration, then these clinical manifestations. Okay, so coming to the diagnosis, there are two prerequisites which are required for diagnosis of HIT. Okay, one, the patient must exhibit a clinical picture consistent with HITT. Okay, along with this, the patient should have heparin dependent antibodies, and that antibodies must be platelet activating. Okay, sometimes they might have drug reactions. Okay, so that should not be always attributed to HIT. Okay, it should be platelet activating, so much so that this causes some amount of thrombosis or an immune inflammatory reaction. Okay, so this is when we come to a diagnosis that this patient has developed HITT. Okay, so how do we approach? So always we have a clinical suspicion followed by an objective assessment, and the objective tool that we use for HITT is the 4T score. So what are the components of 4T score? We all know it's thrombocytopenia, timing of platelet count fall, thrombosis, and we have to primarily rule out all the other causes of thrombocytopenia. So usually all these constitute the 4T score. Coming to the individual parameter, how do we score them? Usually 0, 1, and 2 is what the scoring is. 2 is the highest and 0 being the lowest. So whenever there is a platelet fall of more than 50% or the platelet nadir drops for more than 20,000 cells per liter, then the patient is scored as 2. If the drop is between 30 to 50% or the nadir is less than 20,000, then the score is 1. And if the platelet fall is less than 30%, then probably it is unlikely. So that gives the score of 0. Coming to the second component of the 40 score, that is the timing. Always remember the fall, especially when we are suspecting HITT, usually is between 5th to 10th day. Okay. Here, if the patient has developed thrombocytopenia after 5 days of exposure to heparin, then you can score this patient as 2. Or else, if the patient has a sudden drop on admission itself, please look into history of exposure to heparin within the last 30 days. Okay. Even in such cases, this patient can develop heparin induced thrombocytopenia thrombosis. So most of the times we try to omit this part. Okay. Always look into it. Thrombocytopenia, we have to keep it in our mind. Okay. You have to rule out all the other causes definitely, but yes, always ask for heparin exposure also whenever you feel this patient has thrombocytopenia, which is not usually due to any other cause like sepsis, etc. Okay, or any other cause of hematological diseases. The next point is if the platelet fall is less than 5 to 10 days, okay, or else it's after 10 days, or it is between 30 to 100 days of exposure, then the patient gets a score of 1. If at all it is less than 4 days, definitely it is unlikely to be HITT. Remember, 5 to 10 days or less than 1 day with the prior exposure to heparin within 30 days is 2 points. Okay. Coming to the next point, that is thrombosis or other sequelae. New thrombosis, be it skin necrosis, systemic reaction, okay, post IV fluids, sometimes even places with old CVC sites, okay. So even those places also, if there are skin lesions that you see, they can be the harbinger for event, and they can give you a pointer towards the diagnosis of HITT, okay. So always rule out all these things and always ask for history. Okay. So thrombosis is one of the important criteria for the diagnosis of heparin-induced thrombocytopenia thrombosis. Okay. Obviously, other causes of thrombocytopenia have to be ruled out, and when there are none available, then we can give this patient a score of 2. Okay. And if you find there is a definite possibility of thrombocytopenia for some other reason, then they get a score of 0. Okay. So this is the 4T score. Okay. So coming to the total, a probability of HITT is calculated by the use of 4T score. If the score is more than or equal to 6, there is a higher probability, that is roughly around 64%. If it is between 4 to 5, it is intermediate. If it is less than or equal to 3, it is a low probability. Okay. So we know if it is low, we have no issues. What do we do for intermediate and high is what the next question is. Correct? How do we treat this patient? Intermediate group of patients and high risk patients. Is 40 score the only score? No. Okay. So there is another score called as the HEP probability score, that is the HIT expert probability score. Again, here also more than 3 and less than 3 is what is considered. If it's less than 3, unlikely. More than 3, it is intermediate. More than 6 is again definite HITT. Okay. So can we label any patient with a score of more than 4 is equal to HITT? Unlikely. Okay. So you have to rule out all the other criterias. Okay, individually you have to look into the thing. Okay, and check for heparin exposure, and after doing the 40 score, do a confirmatory test. If it is between 4 to 5, it's always a plus minus. Okay, so this is always supposed to be followed up with a confirmatory diagnostic test. More than 6, it's high probability. Okay, if you do or you don't do, definitely we will come to a diagnosis of it. Okay, but in the intermediate group, usually in our clinical scenarios, we end up using this kind of patients. Correct. So in these patients is where we have to do the confirmatory tests. Okay. So if the patient has one of this, you need to look for HIT antibodies, and if HIT antibodies are present, then you can diagnose this patient as having HITT. Okay. So what are the confirmatory tests and how do we go about them? So we know we need to find out the antibodies to the heparin platelet factor 4 complex, correct? So there are two types of lab diagnosis which helps us come to a diagnosis, which is a confirmatory test. Okay, we have the immunoassays, we have the functional assays. Immunoassay is one of the earlier tests that we need to do. Okay, it is a test which is done to determine if anti-platelet factor 4 heparin antibodies are present. And if it is present, based on the optical density, how much is the abundance of it? That is how it is going to be done. Okay. Remember, immunoassay is first, it will let us know if there is an antibody present or not. And if it is present, how much is present. Okay. So these two things can be understood by the use of enzyme immunoassay, and by then we can also confirm that this patient has antiplatelet 4 heparin antibody. There are other tests that we usually can do. Okay, what are the other tests in enzyme immunoassays? Particle gel immunoassay, IgG specific chemiluminescence assay, lateral flow assay, and lateral turbidometric assay. You need not remember all the things that are present in the slide. Just remember the names of it. It's more than enough. Okay. So you just have to know what are the tests which are usually sent. Okay. So the tests usually majorly, you see, they all detect IgG type of antibodies. Okay. So this is the reason that I have told you. Okay. So, what is the conclusion of doing an immunoassay? If enzyme immunoassay is positive, you can proceed with a functional assay, okay, and then give the confirmation that this patient has HITT. If the EIA is negative, it essentially rules out that this patient has HITT. How does it rule out? Because it is directly telling you that there are no heparin-induced antibodies which are present with the patient. Okay, so this is the first step in confirmation of HITT. That is your enzyme immunoassay. So coming to summarizing till now, we looked at the definition, pathophysiology, and then we looked at the clinical features. After the clinical features, we wanted to do the objective assessment. Based on objective assessment, we use the 40 score, and then we have a score 4 to 5 and more than 6. 4 to 5 is intermediate, more than 6 is almost definite. 4 to 5 is where we have this trouble, right? Whether the patient has or no. Then in that case, we have to get a confirmation. In confirmation, we do two tests. One is a functional assay and an immunoassay. Immunoassay is the first step in that. Okay, so immunoassay will tell us if there are antibodies present or absent, and based on that, the next test is if the antibody is present, whether it will trigger the platelet is what will be told by the serotonin release assay. Remember earlier I told you HIT is only diagnosed once this antibodies are present, and this antibodies should trigger the platelet activation, causing all the thrombotic cascade. Okay, so that is the whole idea and understanding of HITT. So coming to the next step in laboratory diagnosis, that is the functional assay. So we have the serotonin release assay, that is your carbon 14 serotonin release assay. This is the gold standard functional assay. So what do we mean by functional assay? Here, it will help us determine whether the anti-PF4 heparin antibodies are pathogenic. That is, whether they activate the platelet or not. Okay. So this is step 2 in confirmation of the HITT. Okay. So there are other functional assays which are present apart from the serotonin release assay. But if they ask you what is a gold standard test for HITT, then you have to tell it as serotonin release assay. Okay, so which are the other functional assays? Heparin-induced platelet activation assay and P-selectin expression assay. Okay, remember two words: immunoassays, functional assays. Functional assay is serotonin release assay. So why does it become necessary? That will be helpful for you in this slide. Okay. So if you are having a patient with, a score between 4 to 5 and 6 to 8, you see what happens to the probability of diagnosis. If you see the right hand side, you see that majorly the diagnosis does not change. The sensitivity more or less is good enough. A patient who has a 40 score of more than 6. But 4 to 5, with the use of immunoassay and optical density, as the optical density becomes more and more, the probability of diagnosing HITT becomes better. So this is how enzyme immunoassay helps us come closer to a diagnosis of HITT. So summarizing the whole thing, clinical suspicion, 40 score, categorize the score, okay, low, intermediate or high, you can go ahead. First step, whenever you have a 40 score between 4 to 5, the first step, stop heparin if the patient is on heparin, okay? And also think about using an alternate anticoagulation strategy for that patient if at all it is necessary. Okay, so that is the first and foremost step whenever you are thinking of HITT and you have come to a score of probably between 4 and above. Okay, so intermediate to high. The first step is stop the inciting factor. After doing that, go ahead with your screening test, then come get your confirmatory test to come to a diagnosis of HITT. Okay, how do we manage these patients? So first thing I already told you, stop the inciting trigger, that is your heparin, and if at all the patient needs anticoagulation, use an alternate strategy. Okay, why is it necessary? Why is it like any other drug reaction? If it is immunogenic also, if we stop the drug, we should be all right, right? So why do we have to do this? The major reason is because even after we stop heparin, there's always a risk of this cascading effect, that is the thrombogenic foci, which is being present in the body to continue for a longer period of time. Roughly what they say is it's up to 4 to 6 months and above. Okay, so because there is always a risk of thrombosis which can occur despite cessation of the drug, that is the reason we need to start this patient on anticoagulation strategies. Usually, what happens is monocytes bind to the platelet factor 4, wherein they start the prothrombotic cascade. Okay, so the two key principles in head management: first, avoid heparin; two is anticoagulation strategy. Okay, so now you have understood why we do it and what are the things that we have to do. Okay, so the use of non-heparin anticoagulation is what we are looking forward. Okay, so where do we need them? Okay, and how long do we need them? Okay, so this is the next algorithm that you need to look into. Okay, if a patient has clinical thrombosis, okay, which is present, be it in limbs or anywhere else, be it in the venous system or in the arterial system, definitely this patient needs an anticoagulation for 3 to 6 months. If there is no clinically apparent thrombosis, then you have to do certain other tests like your compression ultrasound, DVT scan, etc. And also look in for sites of venous access like your cannulas, CVCs, okay, and arterial lines, etc. All of this accesses also have to be looked into. If a patient has received any such access in the last 5 to 10 days or even a month, look at all these accesses and rule out potentially any thrombus which is present there. Okay, if at all nothing is present at that time, you have to continue anticoagulation until platelet recovery. Okay, so first thing, stop heparin. Second thing, start anticoagulation which is not heparin based. And how long, it depends on presence or absence of thrombosis. If there is thrombosis, 3 to 6 months. If there is no thrombosis, then continue until platelet becomes normal. Okay, so that gets categorized as HIT, subacute HIT A. Okay, I'll show you the next slides where you will understand what are the categories. Okay, so this is basically what you need to write about management of heparin-induced thrombocytopenia and thrombosis per se. Okay, so do all these patients require, so you're still testing, you have not got your serotonin release assay, you have not got your enzyme immunoassay. Usually all of them have a very short turnaround time, but still, so whom do you think that these patient needs closer follow-up in? If platelets are dropping, okay, and you feel that the patients are at a low risk category, probably you need not repeat doing it. Okay, if the patient falls in the 40 score between intermediate to high risk, probably you have to repeat a platelet count as the frequency is mentioned. In intermediate groups, roughly every 2 days. In a high risk group, you have to consider doing platelet count every day. Okay. So along with this, the table below gives you alternates for unfractionated heparin, because I told you earlier, unfractionated heparin has a higher probability of developing HIT, right? So in each particular scenario, what can be used is what they're telling. So what they say is use of fondaparinux is unlikely to cause heparin-induced thrombocytopenia and thrombosis. Okay, again, if you see unfractionated heparin, definitely it can cause. Based on medical and surgical patients, you need to switch between LMWH and fondaparinux. Coming to HIT phases and management. Okay, so I told you earlier, right? In management, there are two things. Okay, how long we have to give anticoagulation. So thrombosis is there, 6 months for sure. If thrombosis is not there, until platelet recovery. And I told you there is subacute hit A type of patients. So how do we categorize them, and how do we categorize the phases of hit? Okay, so initially, when the patient is suspected to have hit, the only thing that we know here is the platelet count is low. We do not know about the functional assay, enzyme immunoassay, and we don't know the thrombosis risk as well. As and when we start getting the tests, we categorize the patient as development into acute hit. In acute hit, we know there is low platelet count, functional assay is present, and enzyme immunoassay is also present. Okay, so it's not particularly in that order, but it should be enzyme immunoassay and functional assay. And because of both of them being present, there's an increased risk of thrombosis. And these group of patients fall under acute hit. So as soon as you get the diagnosis of acute hit, first thing stop heparin, second start anticoagulation, which is not heparin based. Okay. And then once the patient starts becoming better, the platelet starts improving, then the patient reaches a baseline platelet count of more than 1 lakh, they get categorized as subacute hit A. Okay. In subacute hit A, if you still do a functional assay or an enzyme immunoassay, you might still see some antibodies being present. Okay. Slowly, as time progresses, they get converted into subacute hit B and remote hit. Okay. Roughly, it takes up to 1 month for things to come to baseline. Okay, so this is the phases of hit. Okay, if you don't remember, it's okay. All that I want you to remember is the slide here. Okay, so this is basically about why I had to mention about subacute hit A there. Okay, so remember, with thrombosis, without thrombosis, what you do. That's more than enough. Coming to choosing the anticoagulant. So I kept telling you stop heparin, start something other than that, right? So what are the options that we have? We have oral 10A inhibitors, vitamin K antagonists, argatroban, bivalirudin, danaperoid, and fondaparinux. Okay, and the route of administration is also given. Okay, so how do we choose the anticoagulation which is non-heparin based? Is depending on the liver dysfunction, renal dysfunction, and the clinical stability of the patient. Okay, one glaring thing that we look here is vitamin K antagonist. Okay, despite it being a non-heparin anticoagulation, there is no indication that this agent is not recommended because vitamin K itself in this particular phase of hit can cause thrombosis. Okay, so that is the reason there is no role for warfarin in HITT. Okay, I'll be discussing about this in the further slides. Okay. So coming to individual drug, I told you how do we choose them based on clinical stability, life or limb-threatening ischemia, hepatic dysfunction or liver dysfunction. Okay, so we all know if there is renal dysfunction, we can use argatroban. If there is liver dysfunction, we can use bivalirudin. Okay, so these are the two IV anticoagulation strategies that we can use, especially with patients with renal dysfunction and liver dysfunction. Okay, so just keep that in mind. Remember, few of the anticoagulations are oral, few have to be given as IV infusions, and fondaparinux is given as subcutaneous injection. Most of the times, you might have to start this patient on an IV infusion. Probably you have to start this patient on argatroban or bivalirudin. As time progresses, you can discharge the patient on oral anticoagulation or a subcutaneous injection. Okay. So when we do that, I'll discuss in the further slides. But firstly, what are the advantages and disadvantages over the other is one thing you have to know. Okay. So IV infusion always it requires a monitoring. Okay. Otherwise, there will be a probability of overshooting, right? So that is one thing that we need to keep in mind. Okay. So most of the times we start with bivalirudin or argatroban, and the dose for bivalirudin, if organ functions are normal, okay, even if there is hepatic dysfunction, you can use this. Okay, it's around 1.15 milligrams per kg per hour, and argatroban, the dose is around 2 microgram per kg per minute. Okay, and this has to be adjusted based on organ dysfunctions. So once the patient starts improving, then you can switch over to oral. What are the oral drugs which are available? Rivaroxaban, apixaban, and dabigatran. Rivaroxaban or apixaban, the dosing you have to remember again in acute phase up to 1 month. Rivaroxaban, it's 15 mg twice daily for 3 weeks, and then you reduce it to 20 mg once daily. If it is without thrombosis, that is isolated hit, you give 15 mg twice daily until platelet recovery. Okay, so remember, with thrombosis, I told you up to 6 months, right? So it has to go till there. If it is isolated, only till platelet recovery. So in both the places, you have to remember the dosing. Okay, if you can recall, well and good. Otherwise, just mention the name of the drugs. Okay, don't get scared. It's ideally that we need to know it, but yeah, it's hard to remember. Okay. Similarly, remember one drug, that is more than enough. Either remember rivaroxaban or apixaban. Okay, and then you have to remember where it cannot be used. So apixaban, on the other hand, whenever there is hit with thrombosis, it starts with 10 mg twice daily for 1 week, then followed by 5 mg twice daily till 6 months if there is thrombosis. If it is isolated hit, 5 mg twice daily until platelet recovery. Okay, remember one of these two things. Okay, so I feel apixaban is easy, 10 mg twice daily for 1 week, followed by 5 mg twice daily with thrombosis. If it's isolated, 5 mg twice daily till platelet recovery. So, what are the precautions that we have to know? Obviously, rivaroxaban, apixaban, and dabigatran cannot be used in pregnancy. The alternatives we have is fondaparinux in this case. Okay, remember that. Why can't we use this? Because this causes the placental transfer of the drugs and can cause fetal hemorrhages. Okay, that's the reason we cannot use these three drugs in pregnancy. Along with this, we cannot use rivaroxaban, apixaban, and dabigatran also in patients with mechanical heart valves and liver dysfunction or hepatic dysfunction. So, I told you earlier why we can't use vitamin K antagonist, correct? Usually, we know in HIT we need the anticoagulation at the earliest, and heparin seems to be the culprit causing thrombosis there. So, already there is a prothrombotic state, and then at that particular time, if you initiate warfarin, that would cause worsening of thrombosis, and that's the reason we do not give it. Okay. On the same way, when we are talking about transitioning from an IV to oral, okay, so we have to be very careful, or else when we're transitioning between bivalirudin to ergotamine also, we should be careful. Okay. Usually these drugs are known to cause PT prolongation and they in turn can cause bleeding. Okay. So this is one thing that we need to remember. Coming to screening of asymptomatic DVT, this is where we need to think about long-term requirement. Okay. Initially, we might have looked in all of this, and then when the patient on screening at the time of admission would not have any thrombosis, but when you remove this patient's CVC and then you're sending them home for some other reason, they might require and they might develop a DVT at that time, or a thrombus at any of these sites. So always screen these patients, check for development of new thrombosis. Okay, and if at all it is present, probably this patients have to be continued with non-heparin anticoagulation up to 6 months. So when do we transit to oral anticoagulation? A transition is always done when platelet count is recovered. Okay, so when you see that the platelet count is recovering, only then you can switch from IV to oral anticoagulant. Okay, another thing is when patient does not require any urgent procedures, even then you can think about transitioning from IV to oral. So duration, I've already told you, 6 months with thrombosis isolated, it is up to the point of platelet recovery. Most of the places, what they say is, despite giving these guidelines, both the British Society of Hematology and American Society of Hematology say at least till 1 month, definitely you have to do it in isolated HITT. Okay. What do we do in certain case specific scenarios like patients on cardiopulmonary bypass, etc.? All these patients again can develop, right? These cases, what they have told us, the alternative that can be used is bivalirudin. Okay, so if at all the patient has progressed towards remote hit or hit B, you can still think of using heparin in patients wherein we do not have any other alternatives available, but you should always be ready to diagnose it and treat it. Okay, so cardiovascular intervention is one tricky scenario wherein we have to keep a very close watch. Okay, so usually after 100 days, if everything is okay, nothing should happen. But if at all emergency arises, then we need to look at the case and go ahead by case scenario. The only thing, if it is happening between less than 100 days, where the probability of development of it is very high, the alternative is bivalirudin. What do we do in CRRT? Again, non-heparin anticoagulations like argatroban, danaparod, this can come into use. For the machine per se, you can think about using regional citrate anticoagulation. What is the role of IVIG? We all discussed that it is an immune mediated drug reaction, right? As of now, the evidence for IVIG is just based on case reports, okay? So, again, what is it focused on? It is hypothesized by saturation of platelet FC gamma 2A receptors, okay? And here is where it blocks these receptors and inhibits the platelet activation and thereby stopping the thrombogenic cascade. Okay, so again, this has been used in patients with refractory HITT only. Okay, again, along with this, any patient who requires emergency surgical intervention, even there, those patients, you can neutralize the antibodies using IVIG. The effectiveness is still questionable, but yes, in urgent surgical intervention, whenever you suspect HITT, give IVIG and probably then go ahead and do the intervention. Okay, so what are the differential diagnoses you have to remember for thrombocytopenia? That is bacterial sepsis, DIC, other drugs which cause thrombocytopenia like antibiotics, etc., hemolytic uremic syndrome, ITP, TTP, transfusion reactions, etc. Okay, so this is putting it all together. Suspect hit, calculate 40, get the intermediate or high probability. Go ahead, do a immune assay, functional assay, and check for thrombosis, no thrombosis. Thrombosis, 6 months of non-apparent anticoagulation, isolated hit, at least till platelet count recovers to normalcy. Okay. Remember when you're choosing your drugs, IV oral, no role for warfarin. Okay, switch from IV to oral when platelet count is recovering. Okay, always keep in mind the adverse drug reactions. Okay, so oral anticoagulations in pregnancy is a big no-no. Okay, so this is majorly about HITT, and this is the article that I was talking to you guys about. Okay, so you can take a screenshot of this and go. It was published in 2023. It's a very good review. Thank you. Any doubts? Topic. Okay. So catastrophic vasculitic disorders, and off lately, post pandemic, we are seeing a lot of disorders. Okay. So coming to the definition of catastrophic APLA, it is a rare, life threatening form of antiphospholipid syndrome defined by a rapid onset of large and small vessel thrombosis, which occurs simultaneously at multiple sites, causing multi organ dysfunction. Okay, so because it is involving multiple sites and causing multi organ microthrombosis and damage, it is called as catastrophic. Okay, so it's very straightforward. Thrombus present in multiple organs is catastrophic APLA. Okay, just remember it straightforward. Okay, so rare life-threatening form of antiphospholipid syndrome characterized by onset of large and small vessel thrombosis at multiple sites leading to multi-organ dysfunction. What is the pathophysiology? As the name suggests, antiphospholipid antibodies are produced, which causes thrombotic microangiopathy, both in large vessels and small vessels. How do they form that? Usually, there will be complement activation, which is enhanced by the antiphospholipid antibodies. This causes endothelial dysfunction and damage, and this again triggers a clotting cascade. Okay, because there is a clotting cascade which is activated, it leads to a prothrombotic state, and because of prothrombotic state and the clotting cascade activation, there will be an inflammatory response. Okay, that is by cytokines, tissue factors, etc., and this causes thrombus. Okay, it can be large vessel or small vessel. Okay, so this is the pathophysiology of catastrophic APLA. It's very straightforward. Okay, phospholipids are usually present in all the cells. Okay, so anywhere there is an antibody which can go and address to this, it gets attached to it. It starts the complement activation, endothelial dysfunction, coagulation cascade activation, and inflammatory response. Okay, just remember these headings for pathophysiology of catastrophic APLA. It's more than enough if you write it under these headings. Okay, coming to the diagnosis, coming to clinical features, usually patients come with symptoms like shortness of breath, pain in the limb, etc. Okay, sometimes they can also present with stroke, seizures, bleed, etc. Okay, so all of this is possible. The major issue is it's a multi-system involvement, and whenever you have multi-system involvement and there is possibility of vasculitic etiology which is present, especially when you feel that no other cause is correlating, then think about this patient having APLA. Okay, so always do your screening like your ANA profile and screening, and then follow it up with your specific antibodies, that your APS antibodies, which I'll be discussing later on. So diagnosis of CAPS involves identifying clinical manifestations, like I mentioned earlier, including rapid organ involvement and small vessel occlusions, which is confirmed by histopathology and high antiphospholipid antibody levels. Okay, so usually you'll have multiple issues which are happening at the same time. Okay, so we all know, right? Whenever we have a patient with a CVT, etc., who comes to us, a patient developing seizures in pregnancy, or patients who come to us for unexplained stroke, we all go ahead and do these prothrombotic workups. So it's one of those prothrombotic workups that we need to remember. Okay. So what is the classification and how do we come to a definitive diagnosis of catastrophic APLA? Okay. You have something called as the assurance criteria for diagnosis of catastrophic APLA. So there are two ways that we can, come to a diagnosis of catastrophic APLA or CAPS. One is definite, wherein it requires all the four criteria, and other one is probable. Probable is where the definite criteria are not met. Okay, so what are the definite criteria for CAPS? There should be evidence of involvement of three or more organ systems, development of manifestations, simultaneously, which happens within a week's period, confirmation by histopathology of small vessel occlusion, or laboratory confirmation of antiphospholipid antibodies. Okay, majorly all the four should be present. Okay, so histopathology need not be present. If you have any other radiological evidence, also it should be fine enough. Okay, large vessel histopathology is only focusing at small vessel occlusion. So what is probable CAPS on the other hand, wherein all major criteria, like the earlier criteria, are not met, but two or more organ systems, when they get involved, they fall under probable CAPS. Okay, so again, timeline cannot be met. Okay, one of the four criteria will be met. All of them fall under probable CAPS. Coming to laboratory tests which are supposed to be sent for the diagnosis of CAPS, we have antiphospholipid antibodies, which are they? Lupus anticoagulant, anticardiolipin antibody, anti-beta 2 glycoprotein 1 antibodies. The other ones are your routine tests like your CBC, coagulation studies, peripheral smear, organ function tests like renal function tests, liver function tests. Okay, sometimes you might have to do your cardiac markers to rule out probability of a STEMI or an NSTEMI. You should also look for complement levels in catastrophic APLA. Usually, I told you earlier in the pathophysiology, there is an activation of clotting cascade because of complement activation. And because there is complement activation, there's obviously a decrease in C3 and C4 levels. It is the complement level. How do we manage catastrophic APLA? Usually, the acute treatment, the pillars of the treatment are giving the patient steroids. Okay, you have to give them pulse steroids, high dose, therapeutic plasma exchange, or the use of IVIG, and then follow it up with anticoagulation. So it is called as triple therapy with anticoagulation. Okay, so this is what we have to remember about management of catastrophic APLA. Okay, so first line therapy, anticoagulation. Start with heparin, then you can bridge to warfarin and target the INR between 2 to 3. Steroids, high dose methylprednisolone, usually 1 to 2 milligrams per kg per day. Plasma exchange, you can do daily session. Because this patient has a high clot burden, we have to do it as a daily session. Okay, so usually up to 7 days is what they recommend. If you're using IVIG over plasma exchange, then it is 0.4 grams per kg per day for 5 days. Okay, usually sometimes APLA can be existing with patient already with SLE. Okay, if these patients are coming with severe catastrophic APLA, there is recommendation for cyclophosphamide. The second line drugs which are used in the treatment of CAPS are rituximab and eculizumab. Okay, like most of the cases with autoimmune disorders or vasculitic disorders. Okay, What are the additional measures that we need to do? Organ support. If the patient ends up with acute kidney injury with for any classical signs, probably this patient needs dialysis, ventilation, inotropes, etc. Okay. Always rule out other issues are also associated with this. There might be infections. There might be clots which cause some organ dysfunction. Sometimes bowel ischemia, etc. They might require surgery. Okay, you might have to alter some medications. Okay, which is going to increase bleeding tendencies in these patients. So all of this have to be looked into and addressed. These patients require anticoagulation, DVT prophylaxis, and stress ulcer prophylaxis also have to continue. What are the sequelae of APLA? There are two major headings that I want you to understand and write this in the exam. Categorize them as acute complications and chronic sequelae. Acute complications are multi-organ failure, right? You have your multi-system disorder, I told you earlier. It can be renal, respiratory, cardiac, or neurological. Thrombotic microangiopathy leading to end organ damage, hemorrhagic complications. It can be because of anticoagulation therapy itself, okay, and infectious complications because this patient is in an altered immunological state. Chronic sequelae is this patient develops CKD, pulmonary hypertension because of, if at all the patient develops a pulmonary embolism, neurological deficits because of stroke, MI, okay, or else some peripheral limb issues. Okay, all of these are chronic sequelae. Okay, so if you categorize them like acute and chronic, it will be helpful for recalling and writing all the answers. What you write in the acute complications, just imagine that this patient has developed all those complications and survived. So if at all they have survived, what is the worst case that can they have? What is the morbidity with the acute events they have is what is chronic sequelae. Okay. So coming to the mortality rate, the prognosis is very bad with catastrophic APLA because it has a higher mortality rate up to 50% where the patients don't make it. Patients who recover usually have a morbid life. Okay, so they have a lot of residual organ dysfunction. And whenever there is one incidence of APLA becoming catastrophic, there's always a higher probability that these patients can have a worsening event later on. Okay, so they have to be under close watch. So the take-home points for this patient case would be it's a medical emergency with a high mortality rate. When there is unexplained events on your admission, and wherein you think that this patient has an immunological event, think about this patient having developed catastrophic APLA. The classic triad which the patient presents with is thrombocytopenia, hemolytic anemia, multi-organ thrombosis. Okay, so remember this classic triad. Okay, earlier on I forgot to mention about this triad. Okay, but please remember the classic triad is the one which will start triggering you to look for these things. Okay, that is thrombocytopenia, hemolytic anemia, multi-organ thrombosis. Rule of threes is one thing that you have to remember. Usually, three or more organs which is involved less than 1 week. Okay, and triple therapy. Okay, when you're talking about it. So if you have all of this, probably you can write the answer. Okay, so triple therapy. Remember, high dose corticosteroids first thing you have to give, followed by anticoagulation. Either choose plasma exchange or IVIG. Okay, so you have to continue anticoagulation once until the patient recovers, and probably they might require lifelong anticoagulation. Okay, that is one thing that has to be stressed to these patients. Refractory cases, you can use second line drugs like cyclophosphamide, rituximab, or eculizumab. Okay, you have to remember the sequelae. Okay, and then also prime these patients for further issues. Like if it's a female patient, tell them that if they ever get pregnant, they're at a higher risk of developing catastrophic APLA at the time of pregnancy. Okay, always catastrophic APLA mimics TTP-HUS. Okay, only thing is TTP-HUS you have patients having the ADAMTS levels being very low. Okay, here in this we don't have any such issues. Okay, more likely the problem here is the patient has autoantibodies for antiphospholipids and a multi-organ involvement as compared to TTP. Okay, TTP usually neurological symptoms predominate, but here it can be any organ. Okay, so there are certain differences. The major difference being the ADAMTS level between TTP and HUS. Okay, so always look at the precipitating factor which caused this. Usually there will be a precipitating factor. Don't think that APLA just happens on its own. There will be an inciting factor like what we see in diabetic ketoacidosis. Okay, look at that, treat that. Okay, thank you. Any questions? Okay. One question is it? Okay. Okay. I think so. Niharika ma'am will start the next.
Yeah, Darshan, thank you.
Thank you.
So now we finished hematology, so we'll go to some miscellaneous topics which are very important, might be asked for exam. Some are new topics, some are already known topics. Okay, so the first topic here would be the green ICU. So a lot of conferences, CMEs are speaking about this green ICU. So we'll just go about it. They might ask it for around 5 marks. So what is green ICU? The green stands for greater environment. Okay, so green ICU is greater environmental sustainability in ICU. So it is basically a multidisciplinary initiative to design an evidence-based guide in order to reduce the environmental footprint of ICU. What does this mean? So whatever the waste that is produced by the ICU is causing environmental pollution, leading to bad effects on the health. Okay, so how to minimize this is the green initiative or the green ICU. Okay, so ICUs are among the most resource intensive departments in the hospital. Why? Because they consume large amounts of energy, they generate huge quantities of waste products, and we all rely on a single use devices. Yes, because of the infection. So single use devices and equipments, and most of our patients require large amount of drugs for their treatment, okay, which might indirectly cause environmental pollution. So the impact of the climate change on the health, it emphasizes the need for environmental sustainability in healthcare. So basically it is a vicious cycle. We are producing some waste, it's going into the environment, then patients are getting, or we are all getting infected and coming back to the hospital. So it is basically a vicious cycle. So before going to the topic actual, so we need to know how is the climatic change causing problems for the ICU, and second, how the ICU is causing a problem in the environment. Okay, so first, climate change and the ICU. So the consequences of the climate crisis, which could be anything which I'm going to mention now, it creates a need for more intensive care beds and affect the type of patients admitted due to. The first one is, okay, because of the green, uh, a lot of carbon dioxide that is released into the environment, there is a lot of climatic fluctuations. So there is increase in heat related admissions from heat stroke, collapses, and acute deterioration of any chronic illness. Second, because there are lots of natural disasters which has been happening nowadays, such as floods, hurricanes, fires, all these natural disasters can also damage your hospital infrastructure, cut off the water, electricity, or gas supply. It might disrupt travel and impede the transport of medicines, food, and clinical supplies. Third, because of the climatic changes, there is a change in the microbiological patterns. So all the most of the pathogens are being adapted to the climatic change, and this might exacerbate our most important problem, that is the antimicrobial resistance. And because of the climatic change, there is changes in high risk behaviors leading to increased number of accidents and traumas. And lastly, it is also held it is also affecting our mental health. Okay, so climate changes are associated with physical illnesses and injuries which negatively impact people's mental health, especially those most marginalized. So these are the effects of the climate changes on the ICU as well as the general people. Now coming to the environmental impact of the ICU, right? So as I told, ICU creates a proportionately high ecological footprints because it uses large volumes of clinical supplies, water, and energy. Okay. So why large volumes of clinical supplies? Because we rely on single-use items. Second, coming to the energy consumption. So most of the energy consumption in the ICU is because of your HVAC, that is your heating, ventilation, and cooling devices. Okay, and the resulting carbon dioxide which is emitted, they have seen that it is 178 kg per patient per day, which is in USA. Okay, and this energy consumption for one patient who are receiving lung and kidney organ transport, means ventilator or RRT, it is around 15 kilowatts per day. Okay, which is about 1.5 times the consumption of an average European household. One patient is equal to an family. Okay, so that much of energy is utilized. So a lot of energy is wasted, and when the energy is utilized, carbon dioxide is released. So we have the greenhouse effect. This is about the energy. Now last comes your water. Okay, so we give from patient care. Okay, the patient care which we usually give. So the bathing or the cleaning process. So from the routine patient care to specialized procedures like your dialysis, hospital utilize vast quantities of water, okay, which includes your hand washing, air conditioning, sterilization, everything. Okay, so a lot of water is also wasted in form of all these procedures. So this is how ICUs are actually affecting the environment. Now, how to approach a green clinical care? Okay, so there are around 5 steps. Okay, don't need not to remember everything, just remember the headings of the approaches. So first step is to align green ICU plans with the existing hospital initiatives. So whatever hospital initiatives are there, try to implement some of the changes so that you can get a green ICU. Okay, so for that we need to review what are the policies and plans that are present now. Okay, we need to engage the hospital staff, okay, to make certain plans so that we can change that into a green ICU. And we should ensure that this ICU specific actions are complementary and these are integrated even within the hospital. Okay, so the first one would be you need to align the green ICU plans with existing hospital initiative. The second would be you need to evaluate the current state of the ICU. So how to evaluate it? There are a lot of methods of evaluating the state of the ICU. The first one is material flow analysis. So what is this? So this assessment, this basically assesses the types and quantities of materials which are used to provide an insight into your resource efficiency, and it identifies areas for reducing unnecessary resource use. Okay, so what type of material is being used in, suppose if it is an endotracheal tube, what type of material is used? Okay, how many times we are using that? Whether it is reusable or not reusable. Okay, so taking into one instrument or any other thing, so how is it flowing? Okay, how many times we are using, everything has to be noted down. Second important thing is a waste audit has to be done whenever possible. Third, life cycle assessment. So this is nothing but it identifies the environmental impact of products and services throughout their complete life cycle from the production to the disposal. So whatever it is, you should do a life cycle assessment. Third, you have to procure the data. And the fourth one is you should identify low value clinical practices in the intensive care medicine that are potential candidates for de-adoption. So you have adopted a plan, but there are many factors where you might go for a de-adoption of the same plan. So this is how you evaluate your current state of the ICU. So first is the realignment. Second is the evaluation of the current status of the ICU. Then you need to form a green ICU team. So without team, ICU is a teamwork. So even for achieving a green ICU, you need to have a team. So basically it is a multidisciplinary team. So if you see This is the ESICM which has provided this ICU green team. So from nurses, physicians to your legal advisor, IT specialist, dietitians, financial officers, human resource representatives, everyone is involved in this. Okay, so you need to form one team. So the next step is you have to set the goal. Okay, goal setting and planning. And how to set a goal? Your goals should be smart enough. You have to set smart goals. What do you mean by smart goals? Specific, measurable, achievable, it should be relevant, and it should be time bound. Okay, so you need to set some smart goals. And fifth one is you need to secure some leadership support to implement this plan. So these are the 5 steps in implementing a green ICU plan in the ICU. Okay. Now, there is an approach which is given by ESICM. This is a 3-tier approach to increase environmental sustainabilities in ICU. Okay, so tier 1 contains basic actions. What are there? First, you need to establish an ICU team. Second, you need to implement some energy saving measures like turning off some unused equipment and light. You need to promote the use of reusable items over a single-use items where possible. And the fourth one is you need to conduct regular training sessions for the staff on the importance of environmental sustainability, right? All these are very basic actions. Okay, so this belongs to tier 1. So this, as an intensivist, we all need to do. So we should do ourselves and tell our colleagues, nurses, okay, to follow these basic actions. Now comes your tier 2, which is an intermediate actions. So what are these? You need to develop and implement a comprehensive sustainability strategy for the ICU with clear goals and metrics. So this has to be done by involving the hospital, the entire hospital. So reduce paper use by implementing digital records and communications. I think most of the hospitals are actually following this digital records and communications. Next, optimize the use of heating, ventilation, and air conditioning system to reduce energy consumptions. So do some involvement of some electrical engineer and do some recent advances which are present, and upgrade to energy efficient lighting and equipments. Okay, so intermediate actions can also be done. Okay, so I think some of the hospitals have already been doing it and some are not. Then the third is your tier 3 would be some advanced actions. So what are those? You need to use some life cycle analysis to guide the selection of equipment to be used in the ICUs. Second, you should install some motor sensor faucets and efficient fixtures to reduce water consumption. So your modular or some hi-fi ICUs these are. Okay, so you should build some retrofit buildings to meet some green certification standards, and you need to prioritize some renewable energy sources to supply the ICU. Okay, so tier 3 would be difficult, but at least we need to try achieving tier 1 and tier 2. So these are the 3-tier approach to increase the environmental sustainability in the ICU. So this was all the ESICM guidelines. So the steps and the 3-tier approach. Now, this is one article which has been recently published in 2024. So they have one more approach of green ICU. So a lot of approaches. So I think most of the examiners are actually speaking about this 4 Ps. Okay, so in the exam, you can write the steps, just mention the steps, write about the 3-tier and write about this 4 Ps for the green ICU. Definition, and if you write all this, that's more than enough. So 4 P's may, the first P is people, second is your products, third is the processes, and fourth is your planet. So what does all these 4 P's mean? Okay. So coming to the products, we have already discussed. So use less raw materials. If possible, reuse the materials. Okay. Lesser utilization of energy from the material. Okay. So these are all about the products. Now processes. So achieve more with less digitalization. So digitalization is one important thing. Interconnection of health systems. Okay, individualization of monitoring and diagnostic tests. Okay, don't do the same tests for everyone. Try to minimize as much as possible. So that is about your processes. Now coming to the people. So people, you need to form a team. Okay, so each team or each member has to be given certain responsibility and they have to fulfill those responsibility. And then comes your planet. Okay, so if you do all these things, then your planet indirectly or directly will help you in having a better ICU. Okay, so products, processes, people, and the planet. So these are the 4 P's of your green ICU. Okay, so this completes the green ICU topic. Now, next comes one more important topic, the hot topic, AI in critical care medicine. So when I was going through AI in critical care medicine, I mean, there are some 7 to 8 articles, and each article was giving about a different concept of AI in ICU. Okay. Some article is talking about how to do AI in, I mean, how to set up AI in ICU. Some has spoken about the advantages of setting an AI in ICU. Okay, so each article says a different thing. So I just collected some gist, and for your 5 mark questions, how much ever you what you have to write, I've just given here. Okay, so AI is rapidly transforming the landscape of critical care, offering opportunities for enhanced diagnostic precision and personalized patient management. These two important things it is actually targeting. One is diagnostic precision and personalized patient management. So, what are the advantages of using AI in your critical care medicine? First, as I told, it enhances diagnostic accuracy. Second, it predicts the critical events even before you identify it. So, it predicts critical events such as sepsis or cardiac deterioration before you clinically identify it. Third, it improves the workflow efficiency and reduces the clinician workload. And fourth, there are the studies, the articles which have been published have shown that it has optimized patient outcomes, it has reduced ICU stays, and even in some articles, they have shown that it reduces the mortality rates. So these are the advantages of using AI in critical care medicine. Okay, so you need to write about the advantages when they ask. Now coming to the applications of AI in critical care. So the first one is predictive analytics. So what is predictive analytics? Analytics means basically it is analyzing the data which is present, and using this data, it is predicting what is happening. So that is your predictive analytics. So predictive analysis offers advanced methods to forecast patient deterioration, to see if the patient is developing sepsis or any cardiac events. Okay, so example for sepsis. So we have the early warning score for that. So you have the Q-SOFA score or the SOFA score to see whether the patient has sepsis, right? So these are all the traditional tools. Okay, so relying on these traditional tools will often lead to delay in identification of certain critical conditions. So, AI driven models, in contrast, have dynamically analyzed the complex data sheets. It identifies any subtle trends that has happening, any change in trends or patterns that precede your clinical deterioration. Okay, suppose if there is some drop in BP, okay, which you might actually see 3 to 4 hours later, your AI can actually detect it at that time. Okay, so this is the advantages of the AI. So these models, they provide actionable insights with significantly faster response time. So example for this predictive analysis is, so this is the disease severity, this is the time. For us, the time is important. Okay, so this is the health state, the blue one, the pink one is your distress. Okay, and this is, so what's happening? if you are clinically diagnosing or if you are using any traditional methods like your SOFA score, you will be identifying the patient at this level. Okay, so you're detecting it at this level. But if you're using AI, then you will be actually detecting the any deterioration or any disease or any complication earlier. Okay, so that is the advantage of using AI. And studies demonstrated that AI based systems have 20 to 40% improvement in sensitivity for early sepsis detection compared to your traditional methods like SOFA. So you're actually reducing mortality by around 15%. Okay. So this is one of the study which had shown that your Muse and SOFA score, the sensitivity is around 7 to 75%. But if you're using AI solutions, the sensitivity is increased to 85 to 92%. Similarly, your specificity also. And your response time would be lagging behind 2 to 4 hours. Whereas here you have a real time. Within minutes, you're going to diagnose or identify the complication. Okay, so this is about the first one is your predictive analysis. Second, it helps in real time monitoring and gives you some alerts, right? So your monitor will be, you all know most of them are actually using also this one. So your monitor will be actually popping up if there is any problem that is there. So it alerts you immediately. Okay, so this real-time monitoring actually enhances the detection of critical illnesses by continuously analyzing your EHR sheet. Okay, so these systems, they integrate diverse data streams, including your vital signs, lab investigations, what are the medications that you're giving to the patient. So everything it takes into care, and it usually generate early warnings for conditions like respiratory failure and sepsis. So unlike your traditional monitoring system, which rely on some predefined alarms, which may be prone for false positives, AI-enabled systems, it adapts to individual patient baselines, improving the alarm precisions also. So for instance, they have seen that in AI-based sepsis monitoring, it reduced false alarms by 30% while increasing the detection rates. So early diagnosis of sepsis can be done by using your AI. Okay, so if any TBI patient has come, so developing sepsis, so you can actually identify them early by using your AI, because it takes care. See, sometimes you'll be seeing vitals, you might miss your labs, you might miss the total counts, you might miss your procalcitonin. Okay, but AI, when everything it puts together and identifies it, so it is slightly better in identifying uh, the early complications. Okay. So this is the AI enabled real time monitoring system. So it has three things. One is the input. So input, everything will be in the system. Okay. So your labs, your vitals, everything will be in your system. Second, by using this, it will process. Okay. So it uses some algorithms and sees whether there is any deviations from the normal, and it gives you the output in the form of an alarm. Okay. Now, third use is advanced diagnostics. So, what do you mean by advanced diagnostics? So, AI has significantly improved the accuracy and efficiency of imaging diagnostics and even the lab test interpretations. Okay, so in one of the study, they have seen that the diagnostic accuracy rates between AI and human radiologist. They have compared and they've told that your AI's diagnostic accuracy is 92% and the human radiologist diagnostic accuracy is around 78%. So example for this is, so there is something, a CT, MRI, whatever it is. Okay, so the radiologist has detected that here this is the anomaly. So you think that, okay, there is an aneurysm which is present. So they have told that, yes, there is a aneurysm which is present. Done. But when you give the same thing to your AI, so this also detected that there is an aneurysm, but also it detects there is a small aneurysm or something, a subtle sign which is present, which couldn't be identified by your radiologist, can be identified by your AI. Okay, hence they tell that the accuracy is around 92% by AI detected anomalies, whereas 78% for radiologist detected anomalies. Okay, so that is an example for your advanced diagnostics. Now, the next one is it augments clinician expertise. Okay, so how does it augment? Okay, how it reduces the cognitive overload of the physician and hence helps in accelerating decision making processes. Okay, so all the clinicians, all you people, all okay, you face a lot of immense pressure to interpret large volumes of data under tight time constraints. So AI will help you in minimizing all these things. Okay. So it will take some decision support tools into account. It will synthesize the data. It highlights the actionable insights, and because you can't go through each case sheet, you can't go through all the vitals 24 hours, right? So by using AI, you can actually identify a patient who is having some complication due to some procedure or whatever it is, so which you might have missed it, so AI will help you in doing that. Okay, so that is the advantage of using AI. It augments your clinical expertise. And the last one is workflow efficiency. So by automating the repetitive tasks such as documentation and data analysis, it also optimizes resource allocation. For example, AI systems that prioritize patient cases based on urgency enable clinicians to address high risk patients first, reducing delays in the care. So, it improves your workflow efficiency also. So, in short, AI in critical care medicine, what you need to know. So, where it is set, so it can be used in perioperative period, in the intensive care, in the emergency department, and also in the outreach. Okay, it also provide education to the doctors and healthcare professionals. So there could be some personalized learning platforms, curriculum development, and AI driven reality simulations will also be provided. And then comes your applications. So whatever applications which I have told you, you can write about those applications. Then comes some technical objectives. Need not to remember all the technical objectives here. And autonomy in AI. So AI could be fully automated, augmented AI, or it can be only used for clinical decision support system. Okay. So I don't think that this is really required for you. What is supervised learning, unsupervised learning, reinforcement learning? This is all technical aspects. So these are some of the examples which the articles have demonstrated that AI has actually helped. Okay. So using arterial waveforms to predict shock subphenotypes. So in that AI has helped. Second, endotracheal tube detection, whether it is in a proper position or not. So it has predicted early ARDS. So a lot of articles are present on this. It has helped in subphenotyping of TBI patients. And lastly, AI tailored clinician training. How to give the training is also done by the AI. So these are the clinical examples of using AI in critical care medicine. Okay, so if they ask you about AI, so you should write the advantages. Second, applications. Okay, if possible, give an example and write the applications. So 5 important applications. Then you can just put this flow chart, give some examples, clinical AI examples, and the last one would be your disadvantages. Okay, so in disadvantages, the first one would be yes, It is associated with very, very high cost. Okay. And second, there will be a lack of trust. Okay. So whether to believe the machine or not also is a problem, right? So lack of trust. Third, training gaps. Okay. So you need a lot of training before you actually use AI. Okay. So ideally they tell you should have at least around 6 months of proper training. Then only you'll be able to understand how to work in the ICU with the help of AI. And fourth is regulatory hurdles. Okay, so compliant with stringent regulations slows down the AI deployment. And fifth one is your technical limitations. So data integrations, interoperabilities, problems. So some technical limitations are also present. So these are the disadvantages or limitations of using AI in critical care medicine. Okay, so this is the basic thing which I've covered. Okay, now how it is, what it is, uh, it's all very hi-fi. So a lot of technical aspects are present in this. So at least if you write this much in your exam, that is more than enough. Okay, and the third topic would be your ARNI. Okay, so yeah, most of them, now ARNI has become one of the uh, new drug, most commonly used drug in critical care medicine. So what is ARNI, how to use it, basically when to start it and how much to start, that we should know. So ARNI stands for angiotensin receptor neprilysin inhibition. Okay. So before going to it, so basically ARNI is used for heart failure patients. So heart failure is a complex clinical syndrome with signs and symptoms resulting from any structural or functional impairment of ventricular filling or ejection of the blood. And there are lots of classifications of your heart failure. So you have your AHA classification, you have your NYHA classification, you have your intermesses profiles. So a lot of things are there. So you can just remember one thing. I think we all know about the NYHA class 1, 2, 3, 4. So one is no limitation of physical activity, two, slight limitation, three, marked limitation, and four, inability to carry on any physical activity. Okay. There is one more way of classification of heart failure depending upon your ejection fraction. Okay. So heart failure with reduced ejection fraction means less than or equal to 40%. Mildly reduced ejection fraction means 41 to 49%. Preserved ejection fraction is more than or equal to 50%. And there is something known as heart failure with improved ejection fraction. What does that mean? So your baseline was reduced, but after some treatment, it has been increased to more than 40%. That is heart failure with improved ejection fraction. Okay. So before going to the heart failure, you should know the normal neurohormonal activation that happens in your heart failure. So heart failure can happen due to lots of causes, lots of mechanisms, but here we are only concentrating about the neurohormonal activation. So what happens in a failing heart? In the failing heart, the most important hormone which is synthesized is your renin. So renin concentrations will be increased. Okay, so this renin usually converts your angiotensin to angiotensin 1. Okay, this angiotensin 1 is converted to angiotensin 2 with the help of the enzyme or angiotensin converting enzyme ACE. Okay, when this angiotensin 2 is formed, it basically binds to the receptor, that is your angiotensin receptor 1, and that causes worsening of your heart failure. This is one method. Second method is your aldosterone production. So this angiotensinogen can be also converted to aldosterone, and this aldosterone gets attached to your aldosterone receptor, leading to worsening of the heart failure. So this is one of the method. So production of renin. Second method is this failing heart also stimulates your sympathetic nervous system, causing the heart to fail. Now, third method or the third way of causing heart failure is the one which we are discussing now. That is your natriuretic peptide system. Okay, so this is the third system which leads to heart failure. So when this system gets stimulated, there is a release of neprilysin. Okay, so this neprilysin is basically involved in natriuresis, vasodilatation, and your peripheral nervous system activation. And we all know that when the RAS is stimulated, what happens? There will be salt and water retention, vasoconstriction, and your sympathetic nervous system activation. All this leads to a bad effect on your failing heart. Okay, so now we'll discuss about the drugs here only. So important drugs are, one is your beta blockers, which we use commonly. So where does they act? So they act here. So they act on your sympathetic nervous system and then helps the heart. Now, second, you use your AC inhibitors and your ARBs. So your AC inhibitors will basically act on your angiotensin converting enzyme. So this inhibits this enzyme, your ACE inhibitors. So your angiotensin 1 will not be converted to angiotensin 2. So when angiotensin 2 is not converted, it will not cause any worsening of your heart. The third one is, yes, it is converted to angiotensin 2, but it is not binding to the receptors. Here comes your ARBs. Okay, so this is the third group of drugs. Now, fourth group of drug are your mineralocorticoid receptor antagonists. So they basically block your aldosterone receptors. So when your aldosterone doesn't bind to the receptor, then it will not work. Okay, so here comes your MRS. And the fifth drug is your ARNI. So ARNI contains two drugs, your valsartan and sacubitril. So valsartan, it's an ARB, so it acts on this. Your angiotensin receptor 1 blockade happens, whereas your sacubitril will inhibit your neprilysin's actions. Okay. So this is how your heart failure medications act on the neurohormonal system. Okay. Very important diagram, very easy to remember also. Okay. Now coming to the actual topic. So natriuretic peptides. Okay. So NP family, that is known as NP family. Okay. It basically includes three different molecules. One is your ANP, your atrial natriuretic peptide, your BNP, brain natriuretic peptide, and there is one more, the CNP. Okay, that is a C-type natriuretic peptide. All these are involved in your cardiorenal homeostasis. Okay, so all these are synthesized within the heart in response to volume overload and myocyte stress and in response to neuroendocrine regulation, which we have seen in the previous slide. And all the natriuretic peptide effects are mediated by your guanylyl cyclase receptors. Okay, so there are two important guanylyl cyclase receptors. One is your NPRA and your NPRB. So basically, your NPRA receptor is the main effector of both your ANP and BNP, whereas your NPRB receptor, it usually mediates your CNP actions. Okay, so the biological signature of this natriuretic peptides is to reduce the body fluid and maintain the BP and your cardiovascular homeostasis. In other words, these are all the physiological antagonists of both your sympathetic nervous system and the RAS. So this is the fundamental factor in your heart failure. Okay. So now we coming to your ARNIs. So this ARNI was been first approved in 2015 for your heart failure. So as I told, it contains two drugs. One is your sacubitril, which basically inhibits your neprilysin. And the other drug is your valsartan, which basically is a angiotensin 2 receptor 1 antagonist. So it is a two-step benefits, right? So it is acting at two different steps. Okay, so both of them are having a 1:1 molar ratio. So what is the advantage of that? I will tell you in the next slide. So upon ingestion, the sacubitril is metabolized into its active form, which is sacubitrylate by deethylation via esterases. Now see, these both are individual agents. So this is the sacubitril, this is the valsartan. When you combine them in the ratio of 1:1, it forms something known as co-crystal. Okay. And what is the advantage of this co-crystal? This co-crystal, compared to your individual agents, has a higher dissolution rate. There is a simultaneous release with desired simultaneous inhibition of both the systems, that is your neprilysin and your AT1 receptors, and the co-crystal has a higher bioavailability compared to your individual agents. Okay, so these are the advantages of the co-crystal. Okay, now coming to the pharmacokinetics. So absorption, the time to peak is around 30 minutes and time to peak of the formation of metabolite is about 2 hours. The protein binding, it's highly protein bound, 94 to 97%, and the volume of distribution is also high. It is 103 liters. Metabolized, as I told, to esterases, by esterases, and the elimination half-life is around 12 hours and is usually excreted in urine and feces. Now, who should be treated with ARNI? So, some of the questions which are very, very important. So, sacubitril and valsartan is considered as a first-line therapy in patients with class C, NYHA class C heart failure with reduced ejection fraction. Okay, so this is considered as the first-line therapy. So, this can be started either in hospital once the patient has been stabilized or in the outpatient setting. And in certain patients, you can start this as a drug of choice also for heart failure with reduced ejection fraction. Now, should ARNI be used as a monotherapy or in association with other drugs? If not, is there a specific order in which the neurohormonal modulating drugs should be initiated? So this is one more question. So whenever you are using it for class C heart failure with reduced ejection fraction, these drugs should be always used in combination with either a beta blocker or a mineralocorticoid receptor antagonists. And the order in which these agents should be used is individualized. There is no particular way that this has to be given after this. Okay, so it can be individualized. And before starting this, you need to see some important things. You should rule out some important things and then start this drug. First, the systolic BP. This is basically those patients who have been admitted in the hospital or especially in the ICUs. Okay. So before starting it, see that the systolic BP of the patient over the preceding 6 hours is more than or equal to 100 mmHg. This is the first criteria. Second, the diuretic dose should be stable enough. Third, there should be no use of any IV vasodilators in the preceding 6 hours. Fourth, patients should not have required any intravenous inotropic or vasopressors or any mechanical circulatory device within the preceding 24 hours. So if all of these criteria meet, then you can start your drug. Okay, so this is very, very important criteria to start. Okay. Next, what is the starting dose? Okay, now the starting dose of sacubitril and valsartan, so it actually varies between the outpatient patients and the in-hospital patients. Okay, so for us, it is in-hospital ICU. So we are going to deal with only about the ICU patients. So the initial dose is basically determined by their systolic blood pressure. Okay, you can't start whatever dose you want. So if your systolic blood pressure is more than 120 mmHg, then you have this dose that you have to give. 49 by 51 mg twice daily regime. Now, if your systolic BP is 100 to 120, then you should reduce the dose to half. 24 by 26 mg twice daily. Okay, and those patients who have been previously treated with ACE inhibitors should have the drug stopped for at least 36 hours before the first dose of the RNA. Okay, so if the patient is having ACE inhibitors, you need to stop that. Otherwise, there will be precipitous drop in BP because you are using two ARBs together. Okay, so this is how you define the starting dose of the patient for RNA. Now, what is the target dose of RNA? So regardless of whatever dose you start, whatever the clinical setting might be, whether it is in the outpatient or inpatient, the maximum dose is 97 by 103 mg twice BD. So in other words, you can tell it as 100 mg twice BD. Okay. And this up titration, suppose you have started at a low dose and the up titration, the up titration should be performed every 2 weeks. And this up titration actually, before up titration, you need to see all these things, your creatinine levels, your potassium levels, okay, whether the patient is having hypotension. So depend upon these levels, you need to slowly increase the dose. Okay. So this is about the dosing. Now coming to the clinical applications of RNA, where and all it is used. So as I told, it is a drug of choice for heart failure with reduced ejection fraction. So when you write this, please write the supporting evidence for this. So you have a lot of articles or a lot of trials which have been done. So if you have time, please go through this. Otherwise, you can just mention the trial names and what are the outcomes. So you have the Paradigm HF trial, the Transition trial, the Pioneers HF trial, and the Titration trial. Okay, so most of them have told that your RNA has reduced the composite primary of cardiovascular death or heart failure hospitalization more compared with only your enalapril. Okay, so here also it reduces your NT-proBNP concentration compared with your enalapril. It has a better tolerability compared to your other drugs. So most of the trials have shown a positive results. Now, second, is there a use of RNA in preserved ejection fraction? Heart failure with preserved ejection fraction. As such, there is no official indication. Okay, the AHA has not given any indication uh, for heart failure with preserved ejection fraction, but a lot of benefits are present by using RNA in these patients, and a lot of trials have also been done. So the important trial here is your Paramount trial. So the Paramount trial told that using RNA in these patients, okay, it improved the NYHA class and also it preserved better renal function compared to your only valsartan group. Okay. So one more trial is your Paragon HF trial. So in this trial, RNA was not associated with any decrease in CV mortality or HF hospitalization. Okay, so this trial, primary outcome, it is not achieved. Coming to the secondary outcome also, all-cause mortality, nothing. And even it has not showed much effect on your renal parameters also. Now we have something known as the Parallax trial. This was the recent trial, which is been the same RNA in preserved ejection fraction. So RNA had significantly greater reduction in your NT-proBNP levels, but it did not improve your 6-minute walk distance test. Okay. Now that was your second indication. Third indication was hypertension. Okay, so here you have your parameter study. Okay, so this RNA has demonstrated efficacy in reducing the arterial stiffness in the elderly with systolic blood pressure or systolic hypertension and the pulse pressure more than 60 mmHg. So in hypertension also RNA has a role. Now that were the uses of RNA. Now coming to the last part, the adverse effects and contraindications. So adverse effects are postural hypotension, worsening of renal function and hyperkalemia, which we are always worried about. Sometimes cough because of your valsartan, and angioedema, but comparatively, because it is a co-crystal formation, even the release of bradykinins is less compared to your only use of your ARBs or ACE inhibitors. Now, coming to the contraindications, if there is any history of angioedema or anaphylaxis to ACE or ARBs, underlying renal impairment, CKD patients, and hepatic involvement, that is, if the patient has a childbirth C grading. Okay, so this is about the ARNI, and the last slide is about the guidelines. So we have seen all of the trials. Now, what does the guidelines tell about ARNI? So these are the ESC 2021 recommendation, and these are all the other guidelines, your AHA and the other guidelines. So for heart failure with reduced ejection fraction, so this has class 1 recommendation. So your ARNI has class 1 recommendation. Similarly, in all other guidelines, it is class 1 recommendation. Now coming to heart failure with mildly reduced ejection fraction. Okay, in that it is class 2B indication. Okay, ARNI. Here also you have class 2B indication. As I told, heart failure with preserved ejection fraction, there are trials which are telling that there is some benefit, but guidelines, there is no recommendation here. But your AHA guidelines tells that you can use ARNI as a class 2B indication. Okay. So this is about the guidelines. Thank you. So any doubts, you can put it in the chat box.
Thank you, ma'am.
Thank you, Darshan.
Is my screen visible?
Yeah, visible.
Okay. So, going ahead with another important drug with respect to treatment of heart failure, also in reducing the incidence of hospitalization, etc. This drug was asked in the previous exam. Okay, so these two were the reasons why we had placed these topics. Okay, one was already asked previously, so we thought if SGLT2 was asked, ARNI might be asked. So please go through these drugs again, okay? Or else please look into any drug that has come into picture into the clinical practice and which has been discussed quite frequently. So please read them. So they are probably one of the drugs that will be asked. Drug, there will definitely be one question in your exam. Okay, so please focus and read about them. So coming to the topic per se, sodium glucose transporter 2 inhibitors. So I'll be discussing under the following outlines. Okay, so sodium glucose cotransporter 2 inhibitor or SGLT2 inhibitors act primarily in the kidney, specifically in the proximal convoluted tubule. If we are talking about specificity of the PCT, it is acting on the S1 segment. Okay, so what does it do? So what is the mechanism of action of SGLT2 inhibitors? So as the name suggests, it causes glucose reabsorption inhibition. Okay, so under normal conditions, in a normal patient, SGLT2 is responsible for reabsorbing roughly around 90% of the filtered glucose from the renal tubules back into the bloodstream. But if you give these patients a SGLT2 inhibitor, it prevents this glucose reabsorption from the proximal tubules and cause glycosuria. Okay, what essentially it does is it reduces the renal threshold for glucose. And along with this, we told it is sodium glucose, correct? Both of them are involved. So, what it does when this is inhibited, SGLT2 also plays a role in sodium reabsorption. It inhibits sodium reabsorption, causing overall sodium load to get decreased. How does it do this? It causes natriuresis, that is, removal of sodium in the urine. Okay, and because there is glycosuria, removal of sodium, there will be a net loss of calorie, okay, or power in the body, and that causes a calorie deficit in the body. Okay, so because there is calorie deficit, there is osmotic diuresis, all and natriuresis. All of this would reduce the blood pressure. Okay, so there will be some amount of reduction of afterload in such patients. Mind you, despite SGLT2 causing glycosuria, natriuresis, calorie deficit, and osmotic diuresis, this does not activate the RAS system. That is one of the major important characteristics of SGLT2 inhibitors. Okay. In the previous talk in Arni, you saw what happens when RAS system activation. RAS system usually gets activated in patients with chronic cardiac disease, chronic renal disease, correct? So both of them, because RAS gets activated, because sympathetic nervous system gets activated, there will be a lot of volume overload state, and at the same time, because of organ failure, inadequate removal and sequestration of fluid which happens in the body. So we need to look at alternate ways. One, always we look at diuretics. Other than diuretics, if there's any other drug that we can use, the other one is sodium glucose inhibitors, that is SGLT2 inhibitors. What are the physiological effects of SGLT2 inhibitors? One, on glucose metabolism, I told you it causes glycosuria, and because it causes glycosuria, it decreases the HbA1c in the long term. How does it do? It improves the insulin sensitivity in these patients, and because of which there will be better tolerability of sugar and lesser fluctuations, and that is how the patient has a drop in HbA1c levels. Okay, coming to metabolic effects, because of glycosuria and volume loss, there will be weight loss to the patient. There will be reduced visceral adiposity, which is usually a consequence of increased sympathetic overdrive, and there will be improved lipid profile also in these patients. Coming to the cardiovascular impact of SGLT2 inhibitors, I told you there is no activation of RAS in this patient, and there is decrease in excessive fluid in the body, there's decreased afterload. So there will be less stress on the heart. There will be balance in the demand and supply. Okay, and that is how there will be reduced cardiovascular events. There will be improved heart failure outcomes. That is, the risk of readmission due to failure in such patients will come down. Okay, and because all of this is also going to have a direct effect, that is your metabolic effects, this causes decreased atherogenic progression. How does it affect the kidney? It reduces albuminuria, preserves the glomerular filtration rate, and in the long term, it also slows down the progression of kidney to a CKD. Okay, so these are the physiological effects of SGLT2 inhibitors. You have to write it under glucose metabolism, metabolic effects, cardiovascular, and renal. Okay, so this is how we need to talk about the physiological effects of SGLT2 inhibitors. Coming to pharmacokinetic properties, usually the bioavailability of SGLT2 inhibitors orally is usually around 60 to 80%. It's always a tablet, correct? So the bioavailability is as high as 80%, and 80% is protein bound. The T half is roughly around 10 to 12 hours. Sometimes, depending on the drug, it can even be up to 24 hours. Okay, there are two generation of drugs. Based on the generation, the T half changes. Metabolism is usually hepatic, and glucuronidation is the way it goes, and it has very minimal effect on the CYP pathway. Okay, that is your cytochrome pathway. Renal elimination is approximately 50%, and the rest remaining 50% is excreted by the feces. Okay, so you have to remember it has a 50% bearing on the renal parameters. So directly we have to keep in mind about the effects of this drug when we are treating patients with chronic kidney disease. Okay, so this is what is the take home from pharmacokinetic properties. It is available as a tablet. The oral bioavailability is 60 to 80%. 80% of it is protein bound. T half is between 10 to 12 hours in first generation, and second generation it can go up to 24 hours. Hepatic metabolism is what it undergoes, and majorly it undergoes glucuronidation, and elimination is renal predominantly up to 50%, and the rest of the 50% is by feces. Okay, it just gets excreted. What are the examples of SGLT2 inhibitors? Dapagliflozin, empagliflozin, canagliflozin, and ertugliflozin. So there are two generations I told you earlier. The first generations are dapacana and empagliflozin. Second generation is sotagliflozin and ertugliflozin. Okay, sotagliflozin has a dual advantage of having to block both SGLT1 and 2. Okay, so as of now, we are not dealing with that, but majorly we're looking at SGLT2 inhibitors. Okay. So dosage considerations when we are looking at it, base, I told you excretion is majorly renal up to 50%. That is where it comes into picture. The starting dose is usually around, if you're taking DAPA and EMPA, that is what is commonly used in Indian settings. If you're taking dapagliflozin, usually they start with 5 milligrams daily, and the maximum dose is up to 10 milligrams per daily. If the GFR is less than 30, it is contraindicated. Usually, there is no renal adjustment necessary for DAPA and empagliflozin, but in canagliflozin, there is renal adjustment which is required if the GFR drops less than 60. Okay, so that is one of the major reason canagliflozin has been removed from routine care, and DAPA and empagliflozin is still being used. The major advantage is it can be still used in patients with CKD up to a patient whose GFR is more than 30. Okay, so that is the cutoff. Coming to potential adverse effects associated with SGLT2 inhibitors, so commonly it causes mycotic infections, urinary tract infections, volume depletion. Okay, that is because of glycosuria and natriuresis. Okay, rarely it is known to cause euglycemic diabetic ketoacidosis, which commonly we see in patients who come to the ICU with the sepsis with the background of SGLT2 inhibitors. Okay, so always, if at all you get your reconciliation and the patient has this SGLT2, if you find that there is some amount of ketosis present in the patient and you have a DKA setting with euglycemia, that time probably it is because of SGLT2 inhibitors. Okay, it is also known to cause acute kidney injury because of volume depletion, and rarely it is also known to cause bone disease. Okay, having said this, okay, we saw what are the advantages. We also saw what are the disadvantage. The major thing that we need to understand based on multiple RCTs is the risk overweigh. I mean, the benefits overweigh the risk. Okay, so it has very minimal risk as compared to the benefits which it's throwing at us. Okay, so that is the reason most of the societies, like you saw in the previous presentation, it has a class 1 recommendation, especially in patients with heart failure with a reduced ejection fraction and with patients with moderately reduced ejection fraction as well. Okay, so coming to the role of SGLT2 in critical care per se. Okay, till now we generally saw what is SGLT2 inhibitors. I talked about the pharmacokinetics, pharmacodynamics, and what are the adverse effects and what are the dosing. So coming to role in critical care per se, first and foremost, remember, if the patient is having clinical instability in the ICU, we cannot use this drug. Okay, or it's always better to keep a watch. If the patient's GFR is very low, if the patient is on end-stage renal disease, we cannot use this. Okay, if that is patient requiring dialysis. Okay, so if the patient is not having any such things, then we can start initiating the patient on SGLT2 inhibitors. Okay, how does it act? What is the role? So two things we looked at: natriuresis and glycosuria. Natriuresis helps in optimizing the hemodynamic effects, and glycosuria helps in metabolic effects. Okay, so what does it do? Natriuresis decreases the plasma volume and decreases the blood pressure and reduces the risk of heart failure. Similarly, insulin resistance is reduced, body weight is reduced, ketotic metabolites are increased, and the ketotic metabolite is usually the substrate which is required for the cardiac myocyte. Okay, so thereby it helps in optimizing the cardiac myocyte metabolism and thereby reduces the risk of development of heart failure. Okay, so role of SGLT2 in heart failure, if you have to answer it, it is under these topics. Okay, firstly, it is multifactorial. Okay, first is diuretic effect. Okay, so I told you earlier it does not activate the RAS pathway or the sympathetic nervous system, so that is a major plus point. Okay, again, it helps in desequestration, that is, it removes fluid from the interstitial cells, and then it helps in natriuresis. So that is one major advantage of SGLT2 in heart failure. The second important point is it reduces the preload. Okay, and it also reduces the arterial stiffness. I told you the atherosclerotic pathway would have come down. Okay, because it reduces the afterload, also there will be improvement in cardiac function. Okay, so diuretic effect, hemodynamic optimization, reduction in cardiac afterload, improved myocardial energy efficiency. So it shifts the substrate utilization from glucose to ketones, which is a more efficient fuel, especially to the cardiac myocyte. Okay. Along with all these three major issues, it causes long term benefits to the patient with heart failure. What are the long term benefits? It is an anti inflammatory, anti fibrotic drug. Okay. Along with this, since we are optimizing the demand supply mismatch in heart failure, it reduces the risk of readmission and in the long run reduces the incidence of cardiovascular death with patients of heart failure. Okay, so this is the role of SGLT2 in heart failure: diuretic and hemodynamic effects, reduction of cardiac afterload, improved myocardial energy efficiency, anti-inflammatory and anti-fibrotic effects, and reduction in hospitalization and mortality. Okay, so this is the role of SGLT2 inhibitors in heart failure. So when do we initiate this? Okay, so primarily it can be used for outpatient, department candidates who come with IHT with reduced ejection fraction, even though they do not have any heart failure symptoms. Okay, it can be used as a preventive therapy. Or else, if you're using it for active management, it is recommended for patients with heart failure with reduced ejection fraction, that is an EF of less than 40%, with an NYHA grading of dyspnea between 2 to 4 after optimal medical management. Okay, so you start with optimal medical management with the four pillars for this thing, and one of the four pillars can include SGLT2 inhibitors as well. These things can be used in advanced heart failure as well, but usually if the patient has hemodynamic instability, the initiation of SGLT2 is kind of a double-edged sword. Okay, so what is the evidence that we have currently? So majorly, if you look at the two major candidates which we are looking at, one will be the patients with heart failure and reduced ejection fraction. The other group of patients would be heart failure with patients having preserved ejection fraction. Both of these cases have good outcomes. Okay, so level one evidence, as shown previously itself, you know that in heart failure with reduced ejection fraction, what are the trials? It is DAPA heart failure trials. The drug being is dapagliflozin. Empagliflozin also has demonstrated similar reduction in hospitalization due to heart failure, and it also has been shown to decrease worsening of CKD. Okay, so both these trials in the long run have helped the patient. Okay, so majorly because it involves both the heart and the kidney, cardiorenal syndromes, which usually happen because of prolonged heart failure with reduced ejection fraction, that can be offset. Okay, similarly, if at all the patient has a preserved ejection fraction, is there a need for this? Definitely yes. You looked at what does it do for energy substrate utilization, anti-inflammatory and anti-metabolic pathways, correct? Anti-fibrotic pathways. So all of this is the one which we are focusing in patients with heart failure having reduced or preserved ejection fraction. Okay, so the evidence for preserved ejection fraction are Emperor Preserve trial, where empagliflozin was the trial, and Delaware trial. Okay, so based on both of this, now SGLT2 inhibitors, that is dapagliflozin and empagliflozin, are the first line therapies in guidelines for heart failure. Okay, in reduced ejection fraction, definitely it's the first line, irrespective whether the patient is having diabetes or not. Okay, coming to preserved ejection fraction, there is strong evidence, but again, it depends on person to person, and it's still level 2B. Okay, so class 2B, I'm sorry. So we have to still wait for larger trials to come and put it into a guideline perspective. Coming to mechanism of action in CKD, till now we looked at what it does to the heart, we look at the kidney right now. So major action, we know it acts in the proximal convoluted tubule, okay? And for it to act in the proximal convoluted tubule, majorly what it does is it restores the tubuloglomerular feedback, okay? Which enhances the sodium delivery to the macula densa. This leads to afferent arterial vasoconstriction, leading to intraglomerular pressure reduction, okay? And because of this, there will be mitigation of glomerular hyperfiltration. Okay, remember, glomerular hyperfiltration is a key driver for CKD progression, and this glomerular hyperfiltration would be blocked by SGLT2, and because it blocks glomerular hyperfiltration, it restores the tubuloglomerular feedback and slows down the progression of CKD. Okay, so along with this, it's similar to the anti-inflammatory effects, etc. also continues. Okay, so again, patients with diabetes, with diabetic nephropathy, etc., it helps in a better glycemic control and better insulin sensitivity. Okay, so all of this is also restored in patients. So what is the clinical evidence for patients requiring SGLT2 inhibitors in CKD? The trials are DAPA CKD trials, Credence trials, all showed significantly slower rates of development of CKD in patients who have been started with SGLT2 inhibitors. Okay, again, SGLT2 inhibitors the benefit is seen majorly in diabetics with CKD as compared to non-diabetics with CKD. So as of now, earlier on heart failure, I told you it can be given irrespective of diabetic status. But in CKD patients, when we are looking at it, better to give it to patients with CKD who have a background history of diabetes. Okay, that is one of the major take-home points I wanted to understand. Okay, so majorly because it reduces glomerular hyperfiltration, there will also be a reduction in albuminuria, which usually see in patients with early stages of CKD. What are the challenges and considerations? You should remember patients with low GFR, especially less than 30, it's usually contraindicated, especially if the patient ends up in ESRD, majorly because the drug will not act because the nephron is no more functional. Okay, so that is the major issue. Along with it, it is known to cause euglycemic ketoacidosis, urinary tract infections, etc., like I have discussed earlier on. Okay, what are the key applications? Heart failure, AKI prevention, sepsis. It's still in research. We don't have major trials to tell for the routine use of it. Hyperglycemia, definitely in patients with diabetes and AKI or CKD. Okay, in such patients, it is known to have better glycemic control. Okay, so always be aware. What are the limitations? When you start using SGLT2 in the earlier phases, especially patients with CKD not on dialysis, there's a risk of volume depletion in such patients, okay, and cause hypotension. So always be careful about it. Along with this, patients with diabetes, they are known to cause euglycemic ketoacidosis, so it can be missed, okay. And one of the only ways we will know is the patient will be admitted to the ICU for some other reason, and then we might have to pick it up, okay. Always keep a watch for, of the renal parameters for a patient on CKD. Suddenly, these patients might develop end-stage renal disease and end up on dialysis. At that particular time, we might have to stop SGLT2 inhibitors. The first and foremost thing which I have to tell, and I still want to insist, is hemodynamically, if the patient has to be stable when you're thinking of initiating SGLT2 inhibitors. If at all you find this patient having shock on multiple pressors, better to avoid it. Okay, because if you start this again, it causes glycosuria, natriuresis. Okay, once both of them start, there'll be no way that you'll be able to stabilize the hemodynamics. Okay, so this is one of the limitations in critical care. So this is one article I just want you guys to look at. It's a beautiful article. It's a state of the art review for SGLT2 inhibitors. Okay, any questions? I'll be happy to answer. Thank you. Shrihari, if he's there, I can think so you can start.
Good evening, Darshan.
Hi,
I
Shrihari.
need to share.
Yeah, yeah. Okay.
Yeah.
Thank you.
Okay. Hope the screen is visible.
Yeah, yeah, it's visible, Shrihari.
So for now, two topics that I'll be discussing. One is on tension pneumothorax, and the other one is on quality indicators. So with regard to tension pneumothorax, so coming to the introduction, it's basically collapse of the lung when air accumulates between the parietal and vesical pleura within the chest. So air is outside the lung, but inside the thoracic cavity. So this places pressure on the lung, leading to collapse and shift of the surrounding structures. So pneumothorax can be classified either as a simple pneumothorax or a tension pneumothorax. So the difference between them is the shift of mediastinal structures. In simple, there is no shift of mediastinal structures, whereas in tension, there is shift of mediastinal structures. So coming to the etiology, it can be traumatic, atraumatic, and miscellaneous causes other. So under traumatic, it can be penetrating or blunt trauma and iatrogenic. So penetrating and blunt trauma can lead to rib fractures, and that can lead to tear in the pleura, which can lead to pneumothorax. Whereas iatrogenic causes can be because of CVC insertion, routinely with the use of the internal jugular vein and subclavian, especially when a beginner tries to attempt central venous catheterization. It is pretty common. Then lung biopsy, percutaneous tracheostomy, pacemaker insertion, bronchoscopy during CPR, and intercostal nerve blocks, and also another one that is missed is intrapleural nerve blocks. So all these can lead to pneumothorax. So under atraumatic, you can classify it as primary or secondary. So under primary, it is situation where the cause is unknown. So the risk factors for atraumatic primary pneumothorax would be cigarette smoking, cannabis, cocaine, and genetic predisposition in patients with alpha-1 antitrypsin deficiency or Marfan syndrome. The risk of developing atraumatic pneumothorax is pretty high. And due to increased Valsalva maneuver, as in diving or military flying. And secondary atraumatic pneumothorax is seen in patients with underlying lung disease like COPD, lung malignancies, necrotizing lung infections like pneumocystis, TB, or bacterial infections like Streptococcus, Staphylococcus, Klebsiella, and Pseudomonas. Under miscellaneous causes, it can be because of anorexia, catamenial, or exercise induced. So all the causes mentioned above can lead to a tension pneumothorax. So that is the important thing you need to keep in mind. So coming to the pathogenesis, under normal circumstances, pleural cavity pressure or intrapleural pressure is negative as compared to the lung pressure and atmospheric pressure. So there is a tendency of the lung to recoil inward and the chest wall to recoil outward because of this negative pleural pressures. So the pressure gradient that develops in the pleural space prevents the lung from collapsing. So during a pneumothorax, a communication develops between the pleural space and the lung. So it causes air movement from the lung into the pleural space. So this nullifies the pressure gradient that is usually present, leading to a progressive rise in intrapleural pressure. So air accumulates in the pleural cavity through the disrupted pleura, but is unable to exit like a one-way valve. So this leads to an increase in intrathoracic pressure in the affected site. So the increase in intrathoracic pressure in the affected site can cause compression of that lung, decreasing its volume. So leading to collapse, and the affected lung is unable to function at its normal capacity. So that leads to a decrease in gas exchange, leading to hypoxia. So that causes stimulation of your hypoxic pulmonary vasoconstriction, leading to an increase in pulmonary vascular resistance, leading to worsening hypoxia and decrease in your cardiac output. On the other side, compression of the mediastinum leads to pushing it to the contralateral side. So it compresses the heart and the great vessels, reducing the preload and cardiac filling pressures. So that also contributes to a decrease in cardiac output. Ultimately, this decrease in cardiac output and worsening in hypoxia can lead to cardiac arrest if not treated in a timely manner. So clinical evaluation. So in history, usually they present with sudden onset breathlessness, which can range from mild to severe. Unilateral pleuritic chest pain could be there. And it is important to look for risk factors and genetic predisposition. So physical exam, in mild cases, the exam findings are insignificant, whereas in severe ones, there can be enlarged hemithorax on the affected side, diminished breath sounds, absent tactile or vocal fremitus, and hyperresonance on percussion. Hemodynamic compromise, if it is present in a background of a pneumothorax, it is supposed to be a very ominous sign. So, with regard to the diagnosis, when an ABG would reveal hypoxemia with respiratory alkalosis due to well-functioning contralateral lung, whereas if respiratory acidosis sets in, it's an ominous sign indicating patient fatigue. So, metabolic acidosis, if it is there, it is hyperlactatemia related and it indicates a diminished cardiac output. So ECG is usually non-specific. The most common finding is sinus tachycardia. If the patient has a previous chronic parenchymal lung disease, then usually right bundle branch block with RV strain may be seen. So chest X-ray is not usually done in unstable cases due to logistic issues. The effective position, the air moves to the least dependent portion of the lung, and thus the radiographic appearance of pneumothorax depends on the patient's position. So in a supine position, that is in mechanically ventilated patients, the pleural gas accumulates anteriorly in a pulmonic function, leading to the deep sulcus sign, where the gas outlines the costophrenic sulcus. So other findings that can be there are subcutaneous emphysema, tracheal deviation to the opposite side in cases of tension. And in patients with pneumomediastin, there can be a continuous diaphragm sign where both the leaflets of the diaphragm can be seen as one. So here you can see there is a pneumothorax, and here you can see the deep sulcus sign. So this is supposed to be a continuous diaphragm sign, which is indicative of a pneumomediastinum. Sorry, this was the one. The previous one indicates subcutaneous emphysema over here. So this is the continuous diaphragm sign where you can see that both the diaphragm is seen as like a single structure. So for assessment of size, as per the British Thoracic Society guidelines, the distance from the chest wall to the visceral pleural line at the level of the hilum is usually taken into consideration. So if it is less than 2 centimeters, then it is considered as small, whereas if it is more than 2 centimeters, it is large. So it correlates roughly with the pneumothorax occupying 50% of the thoracic cavity. So there is another formula, that is the ABC formula. So you take 3 areas of the pleura, the distance between the parietal and the visceral pleura. So the vertical diameter, the vertical distance, then the distance at the upper end and the distance at the lower end. So you would get A, B, and C, and then that summation needs to be done and divided by 3. So that would give you a percentage of the pneumothorax. So this is also another method of assessing the size and quantification. So pleural ultrasonography, the usual findings that need to be there are absent lung slide, absent B lines, absent lung pulse, and a presence of a lung point. So if all are present, it indicates pneumothorax and with a very good sensitivity and specificity. So the sensitivity is 94% and specificity is 100%. So CT scan is not done in cases of tension pneumothorax for obvious reasons. The patients are hemodynamically stable, transferred to the CT room. The time during which it is done itself can lead to a cardiac arrest. So this is just few images thought I should show you. This is a lung point. So it is a transition zone on the ultrasound where the normal lung sliding meets the absent sliding, and its present is nearly 100% specific for a pneumothorax. So presence of lung point is supposed to be pathognomic for a pneumothorax. So other 2 things I told was lung sliding. So this is one image with the normal lung sliding, but in pneumothorax there would be absent of lung slide. And here you would see presence of B lines. So B lines usually indicate congestion, but in a patient with a pneumothorax, because of air occurring between the pleura, occurring between the parietal and the visceral pleura, the ultrasound waves are not able to penetrate beyond that air. So that images that are produced subsequently are unable to reflect the congestion that is present below it. So usually B lanes are not seen. So usually when a patient who has respiratory distress and you suspect pneumothorax, if you identify presence of B lanes, then it nullifies the presence of a pneumothorax. So lung pulse. So it refers to the sonographic finding of apparent oscillations of the pleural line occurring secondary to transmitted vibrations from the cardiac contractile activity. So the treatment, the first part of it is airway breathing and circulation needs to be stabilized. If hemodynamically unstable, first you need to do needle compression without delay in the second intercostal space at the mid-clavicular line. So following this, the chest drain is placed attached to the water seal. The technique can be either a Seldinger technique or a dissection-based technique. If there is no hemodynamic instability, then there is no requirement for a needle decompression. So this going ahead with the second intercostal space at the mid-clavicular line was as per the general guidelines, but now in the latest ATLS, the concepts related to this have changed. So the basic rationale for doing a needle decompression is to convert a tension pneumothorax into a simple pneumothorax. So doing that is not the definitive therapy. You will need to proceed with a thoracostomy drain. So recent evidences support placing the large over the needle catheter at the fifth intercostal space slightly anterior to the mid-axillary line. So that is where now they recommend to do the needle decompression. So there may be certain scenarios like in obese patients, due to the variable thickness of the chest wall or kinking of the catheter and other technical or anatomical complications, needle decompression may not be successful. So in this case, finger thoracostomy is an alternative approach. So here you can see needle tension pneumothorax can be managed initially by applying a finger decompression technique. So for selection of tubes, for majority of cases, like stable cases due to spontaneous or iatrogenic etiology, usually a 18 to 14 French is sufficient, but not if the patient has features of tension pneumothorax. For patients on mechanical ventilation or with the presence of a tension pneumothorax, you will need to go with larger thoracostomy tubes, usually 24 to 28 French is preferred, mainly due to the risk of bronchopleural fistula. So the rationale for tube selection is based on the Hagen-Poiseuille equation. So basically flow is proportional to pressure and the fourth power of radius and inversely proportional to the viscosity and the length of the tubing. So this flow and the length of the tubing plays a big role. So routine use of negative pressure suctioning is not recommended and there is no evidence to suggest its benefit. So coming to the placement, this was asked in the DRNB paper 1 2 years back. So it is important to know about the anatomy. So any pneumothorax is best treated with the chest tube placed in the fifth intercostal space just anterior to the mid-axillary line. So the triangle of safety is the one you need to know. So the base is at the level of the fifth intercostal space. The apex is at the base of the axilla. The anterior part of this triangle is the lateral edge of the pectoralis major, and the posterior part border is by the lateral edge of the latissimus dorsi. So this needs to be remembered. So differential diagnosis in relation to chest pain and dyspnea. One, there can be pulmonary embolism, acute coronary syndrome, pneumonia, acute pericarditis, rib fractures, esophageal spasm, and acute costochondritis. So this is about the first topic. So is the screen visible?
Yes, sure.
Yes, sir.
Okay. Okay. So the basic source I had taken for this topic is from the ISCCM guidelines. So coming to the introduction, quality indicator is a measure of structure, process, or outcome that could be used by local teams to improve care. So it helps to understand a system, compare it, and improve it. So that is the main reason why quality indicators are used. So the main objective is to select very common parameters, mainly focusing on outcomes like morbidity and mortality, use of process measures, assess for infections, human resources, and safety. So the parameters that are routinely used in ICU practice are in relation to mortality is the SMR. There is a standardized mortality rate. With regard to morbidity, iatrogenic pneumothorax rate and decubitus ulcer rates, operational or process are length of stay and ICU readmission rates, error and patient safety, patient fall rate, medication error, needle stick injury rate, reintubation rates. With regard to infection control, you have VAP, CRBC, COTI rates, and resistance rates. And human resources, you have overall employee satisfaction rates. So these are the important ones that you need to definitely know about. So first coming to SMR or risk adjusted mortality rate. So the main rationale is raw mortality is not a good indicator of quality as it does not consider the difference in cases or the severity of illness. That is an important point that needs to be kept in mind. So use of SMR calculated from approximately calibrated severity of illness scores enable comparative auditing controlling for the severity of illness by predictive models. All right. So the population that is taken into account are all patients admitted to the ICU. So the formula is the observed rate, that is the actual death rate in the ICU divided by the risk adjusted expected rate into 100. So how do you interpret this formula is, so you have an ICU of 10 beds and in a month you have had an admission of about 100 patients and in about those 100 patients, 10 patients have died. So that would be the observed rate of actual deaths. So the risk adjusted expected rate, that is if you are using an Apache 2 score, for all the patients who are admitted in the ICU, you calculate the Apache 2 score and then you take an average of that. So that would give you your denominator. So then you will have to, based on the Apache 2 score that you get, that would give you the predicted mortality. All right. So the numerator will have your ICU death rate and the denominator will have the Apache rate based mortality percentage. So that needs to be calculated and multiplied by 100. So the interpretation, if it is equal to 100, then the ICU mortality rate is equal to the expected rate. If it is more than that, then ICU mortality rate is more than the expected rate. And if it is less than 100, then the ICU mortality rate is less than the expected rate. Then coming to iatrogenic pneumothorax. So procedure-related pneumothorax is associated with increased morbidity and mortality, prolonged ICU stay, and increased costs. So population, it includes all patients admitted to the ICU, and the formula is number of cases of iatrogenic pneumothorax divided by number of ICU cases in a month by 1000. So the benchmark is 0.83 per 1000 cases. So from an exam perspective, till your practical exam gets over, please remember these benchmarks. Either write it in a piece of paper and look through it every day, or have any other sources through which you can regularly revise it. Then coming to decubitus pressure ulcers. So decubitus ulcers and pressure sores are synonymous. So prolonged uninterrupted pressure over bony prominences cause necrosis and ulceration. Hip and buttocks contribute to 67% of the pressure sores. So it is associated with increased cause and infection risks. So again, the population here include all patients admitted to the ICU, and the formula goes by the number of cases with pressure ulcers de novo, which has occurred newly, by the number of ICU cases in a month divided by 1000. So here the benchmark goes as 22.7 per 1000 cases. For iatrogenic pneumothorax, it was 0.83. Here it is 22.7. Or 3 to 11% of ICU cases. So length of ICU stay. So the main rationale for doing this testing is ICU beds are limited in any hospital. That is one thing all of you would know. So thus rationale is used for needing patient is necessary. So the length of stay is used to assess the quality of care and resource utilization. So the total hours and days patients managed in the ICU with midnight bed occupancy is taken as the variable under consideration, which is the most accurate. So I'll again discuss about this in the formula. So the population is all the patients who are admitted to the intensive care unit. So the formula goes by the total occupied bed days, that is the inpatient days, divided by the total number of ICU discharges or deaths in a given time frame, usually a month or a year. All right. So the total occupied bed days, how do you take it into consideration? So if your ICU consists of 10 beds, all right, it's not very common that all beds are going to be filled most of the time. Most of the time it would have six beds when may be filled, or sometimes there may be 8 beds which may be filled, or there may be few times when all the beds are filled. So usually, if you ask your senior staff nurse who's in charge, they would have a midnight census. So based on that midnight census, you can calculate the number of patients who are there at that point of time. So that every day, that midnight census needs to be calculated for that whole month and then averaged. So that would give you the numerator, total occupied bed days. The denominator is pretty straightforward. The total number of ICU discharges or deaths in a given time frame. So usually we take it as a monthly basis. Usually the clinical audits or this meets usually happen on a monthly basis. So at that time, you can take it for a month's basis and then use it as the denominator. So since the data distribution for occupied bed days is likely to be skewed, you need to go with the median value because it provides the best accuracy. All right. So the benchmark here is for a general ICU, it is about 4.36 days, and for a vascular ICU, it is 2.36 days. So ICU readmission rate, that is within 48 hours of ICU discharge. So the main rationale here is early high readmission rate, that is within 48 hours, suggests poor ICU discharge decision making. So this can be due to three reasons. One, discharges occurring before the patient is ready for ward-based care, incorrect use of ward care, or deficient handing over to staff taking over care and responsibilities of the patient. So these are the three circumstances where readmissions can occur. So the population here are all patients admitted to the ICU, and the formula is pretty straightforward. The number of readmitted patients by the total number of patients managed in the ICU into 100. So the benchmark is 5 to 6%. Then comes patient fall rate. So the main rationale for this is an untoward event which results in patient coming to rest unintentionally on the floor or another lower surface. It can be anticipated or unanticipated accidental event which is associated with increased morbidity, prolonged stay, and customer dissatisfaction. So here again the population includes all patients in the ICU, and the formula goes by the number of falls by the number of bed days. So the number of bed days is the one which I had mentioned previously. So you take the midnight census, you calculate the number of beds that have been occupied, then take it for the full month and average it. So that would give you the denominator. So the interpretation would be without injury, it is about 2 to 2.6 per 1000 patient days, and with injury, it is 0.22 to 0.7 per 1000 patient days. Then coming to medication error. So the rationale for this is medication error can be due to wrong prescription, wrong dose, or a communication gap. Many a times, verbal orders when it is being given, it can lead to a very, very high chance of medication error. So usually in most scenarios and now in most of the NABH hospitals, it is now mainly a standard norm that you need to give your orders in writing. So it can occur at a mean rate of 19% of hospitalized patients, and in about 2% of them, this can cause significant patient harm. So it includes all patients admitted to the ICU, and the formula goes by the number of errors by the number of bed days divided by 1000. So the interpretation is a median of 105.9 per 1000 patient days. So needle stick injury, the main rationale for it is needle stick injury is a penetrating stab wound from needle or other sharp objects that may or may not be associated with exposure to blood or other body fluids associated with transmission of bloodborne pathogens. So it is a preventable injury, hence adequate training to a healthcare provider is a must. So it includes all healthcare workers. So among all the previous scores previous formulas that we had population that we had seen, this one includes healthcare workers. So the formula is number of needle stick injuries reported in a month divided by the total of number of staffs in the ICU per 10,000 venipunctures. So the interpretation is the benchmark should be less than 0.94 per 10,000 venipunctures. So reintubation rates. So the rationale is reintubation within 48 hours of extubation. So that is the reintubation rate. So why this is concerning is accidental extubation and subsequent reintubation can lead to prolonged stay, prolonged ventilation, and higher nosocomial pneumonia rates. So here it includes all patients admitted to the ICU, and the formula is straightforward. Number of patients reintubated by the number of patients extubated into 100. So the benchmark is 12%. So next is the infection control related parameters. So first one is the VAP rates. So VAP increases morbidity and mortality, plus associated with increased ICU length of stay and increased cost. So it includes all the patients admitted to the ICU, and the formula goes by the number of patients with VAP divided by the number of ventilator days. So the number of ventilator days is the number of days the patient is mechanically ventilated with either a endotracheal tube or a tracheostomy tube. Now, how do you go about ventilator days? It is almost similar to the number of bed days or occupied bed days. It's almost similar to that. So you have a 10-bedded ICU and you have about 6 patients. So in that, 3 patients are on mechanical ventilation through an endotracheal tube. All right. So those 3 patients at the midnight census are taken as a number of 3. So for the whole month, the number of patients who are there on mechanical ventilation are taken into consideration as a part of the midnight census. And at the end of the month, these numbers are then added up and averaged. So that would give you a denominator as the number of ventilator days. So the interpretation, the usual benchmark is for trauma ICU, it is 9.3 per 1000 ventilator days. Medical ICU, it's 2.5. Neuro ICU, it is 7.1. And neurosurgical ICU, it is 6.5. Bloodstream infections due to central line rates. So the use of CVCs is indispensable in the treatment of critically ill patients. So infections is one of the most common complications of intravascular catheters. And this is also associated with increased morbidity and increased ICU length of stay, and they say by about 5 to 8 days. So the main population are all patients admitted to the ICU, and the formula goes by number of patients diagnosed with the central line associated bloodstream infection by the number of central line days in a month. So this formula is also similar to that of your number of ventilator days and number of bed days. So in patients who are admitted in your ICU, you have a 10-bedded ICU, and in that 10 beds, your ICU census is about 6, and the number of patients with the central line is about 2, as per the midnight census. The next day it is 4, the next day it is about 2, because some patients may be shifted to ward with the central line. So then they may not be included in their numbers. So that number of patients who are there with the central line and during your midnight census are taken into account. And at the end of the month, all these numbers are averaged, and that would give you your denominator. So for benchmarking, usually in medical ICUs, 2 to 4 per 1000 central line days is usually taken as the benchmark. For trauma ICU, it is 4. Neuro ICU, it is 1.2, and coronary ICU, it is 2.1. So 2.4, 4, 1.2, and 2.1. So for CAR-T rates, so for all infection related, you can mention it is associated with increased morbidity, increased length of stay, and increased cost. So invariably, these are the things that occur. So it includes all patients admitted to the ICU. So the formula is number of patients diagnosed with CAR-T divided by the number of catheter days. It is similar explanation like I told for ventilator days and catheter days, central line catheter days. So here the benchmark is for medical ICU it is 4.1, burns ICU is 7.7, neurosurgical ICU it is 6.8, and surgical ICU it is 4.1. So for medical and surgical ICU, CAR-T rates are almost similar. Whereas for burns it is higher, and neurosurgical ICU it is lesser compared to the burns ICU. Then comes the resistance index. So the main rationale is to assess the epidemiological trends of organisms in ICU. So the antimicrobial resistance is usually associated with increased mortality, morbidity, financial burden, and length of stay. So it includes all patients admitted to the ICU. So the formula goes by the number of resistant isolates by the number of isolates tested into 100. The important thing to note here is at least 30 isolates are needed to get a good accuracy and precision. So it varies from institution to institution. And the important thing is it provides the foundation for selection of antibiotics for a specific set of infections. All right. In many of our hospital acquired infections, when you write the answers, we always say based on local antibiogram, local epidemiological data, all that is based on these formulas and derivations. Then comes the human resource related parameters, overall employee satisfaction. So the main rationale is satisfaction level of staffs working in ICU is assessed. So satisfied workforce gives better output and the retention rate is very high. So many a times in many ICUs, if the pay is not good or the workload is very hectic, then many people would have double minds. And if they are not, there is another center where they're ready to provide better opportunities with a more flexible timing and work, then they would have a tendency to go there. So all those things also need to be looked into. So the population is, it includes all staffs working in the ICU, and the formula is usually a questionnaire based format from 1 to 5, where 1 is the lowest satisfaction and 5 is the highest satisfaction. The ideal benchmark needs to be 4. Then customer satisfaction rate. So the main rationale is patient satisfaction is perceived parameter by the patient. It reflects performance of the hospital as reflected by the patients. So it includes all the patients admitted to the ICU capable of giving feedbacks. So it's a questionnaire based assessment with a point of 1 to 10, where 10 indicates the best possible service. So the benchmark is satisfaction to physician communication should be at least 80%, nurse communication 74%, cleanliness 70%, noise 50%, pain management 68%, and recommends hospital orders is 68%. So you can remember it as 80, 75, 70, 50, 68, and 68. All right. So thank you. So why I was emphasizing on quality indicators is, from theory, usually every alternate year, almost they have asked questions related to quality indicators. That is one thing. Second thing, in your practicals during the afternoon session, one section is specifically dedicated to quality indicators. Because many people don't concentrate on this, the marks they obtain in this area is relatively less. But there is only a certain set of questions that they can ask related to quality indicators. And if you are able to answer them, you would be able to score at least 90% of the marks related to that. So I would highly recommend everyone to give a lot of importance to the quality indicators. Thank you.
Thank you, Srihari. Yeah, as Srihari was telling, it is both a question which is asked in practicals as well as theory. There's a lot of formulae that you need to remember. Sometimes that is the way it is. So it has been asked as a question previously as well. Going with the last two topics in miscellaneous, then we will be starting with sepsis. I know in your agenda we have written it as sepsis, but I'll be finishing off the miscellaneous topics. Okay, so is my screen visible?
Yeah, Darshan.
Okay. So coming to principles of end of life care. Okay, this is also one topic which they have asked a few of the times, both in FAT exams and in theory exams. So to understand that, we need to understand what is palliation and what is end of life care. So WHO defines palliative care as an approach that improves the quality of life of patients, both adult and children, and their families who are facing problems associated with life-threatening illnesses. It prevents and relieves the suffering through early identification, correction of pain and assessment at timely intervals, and recognition and alleviation of other associated problems, whether it is physical, psychosocial, or spiritual. Okay, it is a holistic look towards health. Is palliation and hospice the same? No. Okay. Usually, what happens is hospice is generally given to patients who have a life expectancy less than 6 months. Okay. So, palliative care does not have any time constraint like this. And palliative care and hospice care follow one thing. Here, there is no curative treatment that you are looking at. Only thing is keeping the patient comfortable. That is similar. The treatment goal in palliation and hospice is similar. Only thing is the timeline. Okay. So both can be given in any location like hospital, clinics, or at home. Okay. And prognosis, usually patients in hospice are very sick. Okay. So the timeline, as I told you, is less than 6 months. So they are bound to pass away very quickly. Okay. So sometimes when we say 6 months in hospice, it does not require to be like that. It can be rectified as time and progresses. Okay. So in palliative care, there will be frequent visitations for pain management, symptom relief, etc. But most of the times, hospice patients are extremely sick and they will be towards the end of life. So, usually, whenever we think about a terminal illness, we start screening, diagnose the patient, start with curative care. Okay. And when we get the diagnosis itself, we will be knowing the prognosis and we will start reducing the disease burden as much as possible. That is active disease directed treatment. Okay. Towards the end of curative treatment, we should already start priming the patients and the family about the overall prognosis. Okay. So that death does not come as a surprise. Okay. And when they are ending towards futility of care, it should be in a very calm manner and not in a chaotic, confused way. Okay. So end of life care is usually initiated when all the curative aspects have been exhausted and there is no further improvement in medical care. So establishment of medical futility has to be present. Okay. After that, we initiate end of life care, and then it is followed by death and bereavement, which are very important components of end of life care. Okay. So it does not end with death; it ends with bereavement. So, what is end of life care? So, end of life care, as per WHO definition, it says that it's the care that helps all those with advanced, progressive, incurable illnesses to live as well as possible until they die. Okay. Similar definitions have been given by the National Health Services and the NICE. Okay. So, majorly, what you have to remember is it is a holistic care which is given to people with terminal illnesses so that they die with dignity. What are the key principles of end of life care? It is patient centered or person centered. Pain and symptom management is the primary pillar. Active communication, holistic approach, focus on quality of life, family support, multidisciplinary team approach, ethical practice, and ready access to care at whatever settings the EOLC is being initiated. Okay, so these are the key principles of end of life care. So, what do we mean by patient centered care? It is respecting the patient's autonomy, preferences, maintaining the dignity throughout the care, individualizing the care plans based on personal, cultural, and religious values. If at all there are any advanced directives given by the patient, we must honor them. Okay. Coming to pain and symptom management, I told you it is one of the very important things that can be managed. In medical futility, everything might fail, but management of pain can continue till the end. Okay, so that is one thing that we can do justice to this patient. So effective assessment of pain, timely reassessment and management has to be done. You all know pain is also associated with psychosocial problems. So psychological stress would also be there, one because of the disease, two because of the pain. So both have to be taken into consideration and managed accordingly. Probably the patient has to have some sort of a peer group, okay, along with behavioral therapy, psychosocial therapy, okay, group discussions, etc. All of this also have to be considered in pain and symptom management for these patients. Communication, whenever we are talking about end of life care, we need to be very clear, honest, and very transparent about the prognosis of the patient. It must include the family first, and then it also has to be communicated to the patient. Regular updates of the conditions has to be given as and when things are worsening and the treatment starts failing. The family and the patient has to be apprised about the possible eventualities so that it doesn't come as a surprise when the patient does not make it. Okay. So coming to the meaning of holistic approach is addressing not only the physical problems but emotional, social, and spiritual needs of the patient. Here it encompasses care of both the patient and the family. Okay, so this is usually done by a grief counselor most of the times, and you'll have a lot of other counselors in the hospital. See, end of life care does not mean palliation care, does not mean it is doctors alone who have to do it. There are a lot of support staff who are involved in end of life care. They can be involved in delivery of good care in end of life. Okay. So these are the places like holistic approach, okay, quality of life management, okay, wherein people can come and tell them what other things they can do in the final moments. Okay, if so, focusing on comfort rather than cure is what is necessary when we are talking about quality of life. Okay, meaningful activities have to be emphasized and encouraged, and most of the time, most importantly, the patient should not be in the hospital. If at all they're in the hospital, it should be along with the close family members. So that is what is the primary focus of quality of life. Family support, definitely the family is also going to have a shock, so they have to be included first in the decision making of end of life care. Along with that, how to go about the delivery of end of life care. So both of this has to be done, and in the end, ultimately, when the patient passes away, the most important problem, the stress will continue in the family. So bereavement support is something that has to be focused and have to be continued if we are looking at provision of healthcare as a whole. Coming to multidisciplinary team approach, it is one of the primary things that we do in end of life care. So even before we talk about palliation and end of life care, usually all the team members who have treated the patient have to come to a consensus that there is medical futility, and this has to be communicated as a team to the family. So that does drive the point across in a clear manner, and there is no ambiguity, and there will be faith which will be restored. Okay, so this will help in comprehensive care planning later on. Okay, so there will be no disparities between one treating physician over the other. Always when we are doing end of life care, ethical principles have to be kept in mind, the four pillars. Okay, access to care whenever it is available have to be given. If at all the patient wants to go and all about and do everything, it has to be reverted back. If the patient has undergone end of life care, non-escalation of care, or palliation, and they do want to come back to all possible approach, it has to be provided to them. Okay, they will be allowed to change decision whenever it's necessary. It's not that once they accept end of life care, it is the end of all. Okay, so settings, I told you earlier, it can be given anywhere. It can be in home, hospital, hospices, or even nursing care homes. Okay, majorly what is necessary for a setting of end of life care is, if it is in a home, probably you have to have some nursing available or someone who has trained in nursing, family support, equipment provision, probably some amount of oxygen, like oxygen concentrator, suction devices, nebulizers, etc. Okay, and medication management and emergency planning has to be told to the family just in case of an emergency, if at all they seek hospitalization. Okay, hospital, definitely you need to have a specialized unit for end of life care, because we know they are not going to be escalated into the main critical care areas. Okay, so acute care, whenever it is necessary, should be just for symptom relief. They should not be for overall improvements. Okay, as we know, there is medical futility. Okay. Majorly in hospitals, what we are looking at is for symptom management and crisis intervention. Okay, so few families will be skeptical of taking very sick patients home. For such patients, probably we can provide specialized units in the hospital for delivery of end of life care. Similarly, hospice, here we've already come to an understanding the patient will pass away quickly. So mostly what we need is counselors, especially grief counselors. Okay, so this is the primary focus, along with some routine nursing care. Okay, care homes, again, it is similar to what we see in hospice. So, what are the infrastructural requirements for delivery of good end of life care? Primarily, you have to have a standing policy, okay, so that there is no ambiguity in initiation and implementation of end of life. So, a hospital's policy, the administration should have enough knowledge of what to do. Adequate spacing and staff allocation should be done. There should be education of most of the faculty, okay, be it doctors, nurses, or aides, all have to be spoken about what is end of life care and what do we do with it. Okay, and whenever decision of end of life is done, appropriate documentation has to be done, because there are legal repercussions. Okay, so they have to be always done in a timely, just manner. Okay, and it has to be completed at the right time. Any special supports, like psychologists, counselors, funeral directors, etc., all of this also should be present, and there should be one single point of contact for the family, so that they do not run from pillar to post to find out whom to talk about, especially when the patient passes away. Okay, so these are the basic infrastructural requirement for good end of life: policy, space and staffing, education and training, documentation, and special support. Okay, so this is about the infrastructural requirements for good end of life care. Coming to ethical principles of end of life care. So we know this from a long time. This you have been studying, ever since you entered critical care, right? So the four major pillars are autonomy, non-maleficence, beneficence, and social justice. And the primary, the center of whole of this thing is dignity, correct? So autonomy is patient self-determination and the patient's right to make informed decisions. Patient also has the authority to give advance directives, consent, and has the choice to decline whenever we give them an option. Okay, so that is about autonomy. Non-maleficence is the principle of primum non nocere. Okay, that is do no harm principle. So avoid unnecessary suffering, preventing medical complications, proportionate medical interventions, and minimizing invasive procedures as and when it is possible. So if at all we have an alternate, less invasive pathway, that is what we need to choose. So that is the ethical principle of non-maleficence. Next, coming to beneficence. Okay, beneficence deals with actions promoting patient's best interests. It is focusing at minimizing harm and improving benefit. Okay, and usually it focuses at better quality of life. Social justice is for even distribution of care, okay, equitable treatment, and addresses healthcare disparity by and large. Okay, so usually whenever we have a single bed or and we do not have access to healthcare, probably an elderly patient with multiple comorbidities will not get the choice as compared to a patient with a younger age group. Okay, so here social justice comes into picture. Probably the younger patient has a better chances of survival, and that is one of the reasons we can argue that you have tried to treat this patient first as compared to the elderly gentleman with multiple comorbidities. So these are the four important things: autonomy, non-maleficence, beneficence, and just social justice. And dignity is one other thing that I want you to know. Again, here it is maintaining the privacy of the patient, emotional support, sensitivity, especially to the cultural beliefs, and respecting individuality. Okay. So, coming to the principle of doctrine of double effect. What is doctrine of double effect? It is an ethical principle that addresses the situation wherein an action intended to do good may also cause harm. Okay. What is the core principle? Doctrine of double effect. Usually the doctor would not be doctor or any healthcare provider would not be held responsible if the nature of the act is good and morally neutral in itself, and if the agent's intention is to do good and aimed at a positive effect rather than its negative byproduct. The good effect always outweighs the bad effect in circumstances significant enough to warrant or causing harm. Okay, the good effect cannot be achieved without doing the bad effect. Okay, in such places where doctrine of double effect comes into picture. So if I have to tell you with an example, right? So consider pain management. Okay, if you're giving pain management drugs like say suppose you're giving a patient with end of life care decision with morphine or any other opioid, and because of this patient develops respiratory distress and has a cardiac arrest and passes away. At that time, you all know very well that the drug which was given was intended to treat the patient, but unfortunately it caused a potential known adverse effect, that was respiratory depression, causing an adverse event like cardiac arrest. So in this case, the primary intent, okay, like I was discussing earlier, was to do good. Okay, it was morally correct. It was thinking of doing a positive effect
Darshan sir, you are not audible.
Right. Uh, so due to glitches on Darshan's side, we'll go ahead with the infectious diseases. So I'll cover catheter-related infections, diarrhea, and tropical infections. So all three are potential questions that can be asked in the exam. So first, coming to catheter-related bloodstream infections, first you need to know the difference between CRBSA and CLABSI. All right. So CRBSA are bloodstream infections where organism identified in peripheral blood is also present in the tip of the catheter or in a blood sample drawn through the catheter. So this is mainly used by the IDSA. So the definition is commonly used in clinical practice and it requires evidence of a catheter involvement with the same organism present in the peripheral blood. So it includes all types of catheters: peripheral venous catheter, peripheral arterial catheter, CVC, PAC, PICC line, long-term CVC like Hickman or Broviac catheters, and implantable devices. Whereas CLABSI is defined as recovery of a pathogen from a blood culture. All right. Single blood culture for an organism not commonly present in skin, and 2 or more positive blood cultures for skin commensals. In a patient who had a central line at the time of infection or within 48 hours before development of infection with no other source of infection except the catheter, with evidence of microbial growth on the suspected catheter not being required. So this is used by the CDC. So it's mainly a surveillance definition used for public reporting and it is restricted to the application on patients with central lines. The problem is this definition can lead to overestimation of bloodstream infection incidents caused by the catheter infections, especially in ICU and hemato-oncological patients. So coming to the pathophysiology, so the commonest route is via the skin colonization. So microbes on the skin can migrate along the subcutaneous tract of an indwelling catheter and eventually reach and colonize the intravascular portion of the catheter. So the commonest commensals are Staph aureus and coagulase negative staph. So deposition of biofilm on the external and internal surface of vascular catheter plays an important role in colonization. Then comes infusate contamination. So that is supposed to be the rarest cause. So suspected in an otherwise low risk patient receiving IV solutions with uncommon gram-negative bacteria. So administration of contaminated infusate or additives like blood products or contaminated heparin flush, or the next route of contamination is through intraluminal contamination. So contamination of internal lumen of vascular catheters can occur through breakpoints in the infusion system, like catheter hubs, which is usually suspected in long-term indwelling catheters, especially dialysis catheters. And then hematogenous seeding. So microorganisms in circulating blood, especially due to infections of the GI tract, can attach to the intravascular portion of the indwelling catheter. So recurrent bacteremia from the catheter may be difficult to distinguish from worsening of the primary focus of infection. So the difference between these two can be identified by removal of the catheter, which may help in distinguishing these possibilities, either recurrent bacteremia from the catheter or a GI source. So coming to the microbiology, the commonest organisms that are usually isolated are coagulase negative staph, Staph aureus, Enterococcus, Candida, Klebsiella, E. coli, Enterobacter, and Pseudomonas. So in special populations, in Burns patients, the commonest is Pseudomonas. In hematological patients, it is gram-negative bacilli. So the association may be due to translocation of gut bacteria in patients with an altered gut mucosal barrier. In hemodialysis patients, gram-positive bacteria, and in infusate contamination. Especially IV fluids, commonest is gram-negative bacteria, and in TPN, it is candidemia due to Candida parasilosis. So the risk factors, you can classify it into host factors and catheter factors. Host factors are those like chronic illnesses, bone marrow transplantation, immune deficiency, especially neutropenia, malnutrition, TPN administration, previous bloodstream infections, extremes of age, loss of skin integrity, like in burns. Catheter factors are duration of catheterization. The more the duration, the more the risk. The type of catheter material, the condition of insertion, whether it was done on an emergency basis or an elective basis, catheter site care, skill of the catheter inserter, the site of insertion, the highest being for the femoral root, submaximal barrier precautions, and multiple lumen versus a single lumen, with the multiple lumen having a higher risk. So in these risk factors, I've mentioned a handful of them. at least 3 to 4 should be in your mind when if at all you're asked this question. So the clinical manifestations, so the general presentation, they present with fever or inflammation, pain or purulence at the catheter site, which can be associated with hemodynamic instability or an altered mental status. So if clinical signs of sepsis are there that start abruptly after catheter infusion, then a high suspicion of infusate contamination should be kept in mind. It should be confirmed with concordant growth of pathogen from the infusate and cultures of percutaneously obtained blood. Alright, so this is one thing that you need to keep in mind. We don't routinely look into this, but this also should always be at the back of your mind. So the lab tests, we usually do total WBC counts, CRP, procalcitonin, all these are non-specific, and blood cultures. So features of complicated catheter infection: hemodynamic instability, neutropenia, immunosuppression, and local exit site signs like cellulitis, redness, and purulent discharge. These 4 need to be kept in mind. Already, hemodynamic instability, neutropenia, immunosuppression, local exit site signs. So coming to the diagnosis, so we go by the 15, 3 and 2 rule. Alright, so this is mainly when I prepared notes, this was something that I had written just to keep it as a good memory. So the diagnosis of CRBSI should be suspected in patients with fever, chills, and or hypertension in the setting of a catheter placed for at least 48 hours prior to the development of symptoms. So the culture methods are: one, semi-quantitative culture of the catheter tip. So the distal 5 centimeters of the catheter is severed, and this is considered as a gold standard. So the same organism on the catheter tip and in the peripheral blood of about 10 ml is usually seen, and the growth from the catheter tip should have more than 15 colony forming units in 24 hours. That's why the 15 number comes here. The problem is it detects only the outer surface of the catheter, not the inner surface, which is a potential source of colonization from the catheter hub. Then we have the differential quantitative blood cultures, which has a diagnostic accuracy of 94%. So the same organism in the peripheral blood and the catheter blood is seen, and the colony count from the catheter blood is 3 or more times greater than the colony count from the peripheral blood. The problem is it does not detect organisms on the outer surface of the catheters. So that is the problem with this modality of testing. Then the last one, which most of us are very familiar, is the differential time to positivity. Even though it is something that most of us know, compared to the 3 of them, this is supposed to have the least diagnostic accuracy actually. So the same organism in the peripheral blood and the catheter blood is noted, and the onset of growth in the catheter blood is at least 2 hours before the onset of growth in the peripheral blood. So 2 hours is the minimum time difference that needs to be there between the catheter and the peripheral blood. So 15, 3 and 2. 15 for the growth from the catheter tip having more than 15 colony forming units. 3 for the colony count from the catheter blood being 3 or more times greater than the colony count from the peripheral blood, and 2 being the onset of growth in the catheter blood being at least 2 hours before the onset of growth in the peripheral blood. All right. So the 2 important differentials you need to keep in mind is primary vascular graft infection in those who have it done, especially like AV fistulas for hemodialysis, or any kind of grafting that has been done for any vascular abnormalities or vascular diseases, and myocardic aneurysms. That is infections of arterial wall causing development of new aneurysm, or when pre-existing aneurysm becomes infected in the setting of bacteremia. So coming to the treatment, we have 2 areas to keep in mind. One is catheter management, and other one is the antimicrobial therapy. So with regard to the catheter management, the first thing is you check if there is suspicion of a catheter related infection. If it is yes, then you assess for whether there is signs of severe disease, that is shock, neutropenia, immunosuppression, local exit signs like purulent discharge, redness more than 5 centimeters diameter, and patients with prosthetic valves or an indwelling pacemaker wires. If any of these are there, then you need to remove the catheter. If not, you can go ahead with the watchful strategy, especially in patients with the long-term indwelling catheters. So many a times there may be patients with the long-term catheter, and for catheter salvage, you can go ahead with antibiotic lock therapy. So the same antibiotic used systemically in a concentration of 2 to 5 milligrams per ml in heparinase saline is injected and allowed to dwell for 24 hours. So during the 24 hours, the catheter should not be manipulated or not, there should not be any touching of that catheter during that period. So after 72 hours, you reevaluate again and reassess. So once you get the cultures, if it is a confirmed CRBSI, you need to assess if it is complicated or uncomplicated. If it is complicated, you need to remove the catheter and look for complications. Whereas if it is uncomplicated, you just go with catheter removal. Whereas after 72 hours, if you find that the cultures are all negative, or possible blood cultures are not related to the catheter, then you go ahead with the watchful waiting strategy. All right. Then coming to the antimicrobial therapy, if there is a suspicion of a catheter-related infection and there is a clinical and lab signs of risk factors for complicated catheter infections, then you go with empirical treatment. So for gram-positive coverage, either MRSA and enterococci, vancomycin is the first-line drug. If ICU is prevalent with MRSA that have vancomycin MAC more than 2 mics per ml, then you need to go with daptomycin. For gram-negative coverage, it is based on the local antimicrobial susceptibility and severity of disease. So based on your ICU antibiogram, you can go with either piperacillin tazobactam, cefepime if pseudomonas prevalence is high, carbapenem, and aminoglycoside if MDR prevalence is very, very high. So empirical antifungals are recommended in the following settings, like patients with a femoral catheter, TPN, hematological malignancy, prolonged antibiotic use, recent transplant. So the recommended antifungal is to go with echinocandins. So fluconazole can be used in the following settings. That is, there is no prior azole exposure in the last 3 months. In the healthcare setting or in the healthcare setting where the incidence of Candida krusei or glabrata is low. So in these two scenarios, fluconazole can be attempted. So the complications following CRBSA, one is septic thrombophlebitis. So venous thrombosis associated with inflammation in the setting of bacteremia. It needs to be suspected in patients with CRBSA with persistent bacteremia after for 72 hours of appropriate treatment. So the diagnosis is through duplex ultrasound and positive blood cultures, and treatment is antibiotics and anticoagulation if complicated, plus or minus surgery if it is persistent despite the above measures. Then infective endocarditis, where there can be infection of one or more heart valves, suspected in patients with CRBSA or bacteremia for more than 48 to 72 hours with pathogen associated with IE. And the most concerning one is the metastatic musculoskeletal infections manifesting as septic arthritis, osteomyelitis, or orthopedic hardware infections. So it is suspected in the setting of new onset musculoskeletal pain, but many a times in patients who develop new onset fever or in the ICU and has a catheter related infection, it is very, very important to look for these three complications. Because even after you remove the catheter, there may be times when the patient still persists to have fevers. And if it is not identified at the right time, then complications may ensue and it may further increase morbidity and mortality. So treatment of specific pathogens, if it is MSSA, you go with nafcillin or oxacillin, and the alternative is cefazolin and vancomycin. Whereas if it is MRSA, then you need to go with vancomycin, and the alternative is either to go with daptomycin or linezolid. So for enterococcus, if it is ampicillin sensitive, you go with ampicillin. The alternative is vancomycin. If it is ampicillin resistant but vancomycin sensitive, then you go with vancomycin, and the alternative is daptomycin or linezolid. Whereas if it is ampicillin and vancomycin resistant, then you will have to go with either daptomycin or linezolid. But the alternative would be quinupristin or dalfopristin combination. which is not usually effective against Enterococcus faecalis. For gram-negative bacteria, usually it is based on the antibiograms. So for Acinetobacter, the preferred one is carbapenems, provided there is no evidence of crab. Alternative is ampicillin sulbactam, but now the recent guidelines for crab infections is to go with Dorlobactam sulbactam. So that needs to be kept in mind. For E. coli Klebsiella, again, you need to know if it is carbapenem sensitive. If it is a CRE, that is a CRE bug, then you need to know whether it is a KPC, NDM, or a OXA. So based on that, you need to know whether you need to go with plain ceftazidime avibactam or you need to combine it with Astronam. For Enterobacter, they are AMC producers, so the preferred agents is carbapenems. The alternative that can be used is cefepime. And for Pseudomonas, piptaz, cefepime, carbapenem, or aminoglycoside can be used. And piptaz, cefepime, or carbapenem should be used, and it needs to be done in combination with aminoglycoside, like amikacin. So for candidal infections, the ideal one is to go with echinocandins. So caspofungin, loading dose of 70 milligrams and a maintenance of 50 milligrams per day, and andilofungin, loading of 200 followed by a maintenance of 100 milligram per day. So the alternative, if at all these are resistant, then you need to go with liposomal amphotericin B. Fluconazole, if at all your cultures turns to positive for Candida and it is susceptible, then you can shift over to an azole. Or, like I said, in the two scenarios where azole therapy can be used is if there is no prior exposure in the last 3 months, or your ICU does not have prevalence for Candida krusei or glabrata. So the duration of treatment is usually for 10 to 14 days. And for candidemia, it needs to be continued for 14 days after the first negative blood culture. So CVC checklist bundle, hand aging, good compliance is a must. Use of maximum barrier precautions during insertion, including fluid rape. Use of 0.5, preferably 2% chlorhexidine skin preparation for disinfecting and cleaning skin before insertion. Catheter site selection, avoiding femoral route and use of ultrasound guidance to decrease the number of pricks. Daily inspection of the catheter site, immediate change of unstuck, soiled or moistened catheter dressing, and removal of the catheter as soon as it no longer needed. So other important practice is scrub the hub with isopropyl alcohol. So this is about CRBSA. So is the screen visible?
Yes, sir.
Okay. So under in patients admitted to the ICU with tropical infections, usually the questions are asked in relation to approach to a patient with tropical infections, or they may ask a specific set of tropical infection and they may ask into clinical manifestations, diagnosis, and management. So in today's discussion, the predominant question that was asked was on severe malaria and approach. But for your exam purposes, I have also prepared points in relation to dengue, lepto, scrub, enteric fever, Zika, and Nipah. So I will not be discussing about these topics. I'll keep the slide for 5 seconds for each of these areas, so that when you read through these recorded videos, it would be definitely beneficial. So when you are asked about these infections, it is always better to mention it under these subheadings: classification, etiology and pathogenesis, clinical manifestations and severity assessment, diagnosis, treatment, and related trials, if any. So coming to severe malaria, that is most commonly because of Plasmodium falciparum. So the classification as per the WHO comes as uncomplicated malaria versus severe malaria. Now, severe malaria is defined as any one of the above: impaired consciousness, presence of seizures, acidosis, acute kidney injury, severe anemia, pulmonary edema, ARDS, shock, jaundice, or eye parasitemia. So, if any of these features are there, then it comes as severe malaria. So coming to the etiology and pathogenesis, I've made it very concise because in the exam you are only given 5 pages. So if you see most of the notes or books in relation to the pathogenesis of malaria, that itself goes for 1.5 pages. So from an exam perspective, that is not feasible. So what I've written here can be made like a flow chart. So coming to Plasmodium falciparum, the infected red blood cells express this uh, PFEMP1. So that leads to cytoadherence to the vascular endothelium, leading to microvascular sequestration of the RBCs in the brain, lung, kidney. So because of this, there is obstruction of the microcirculation, which leads to tissue hypoxia, which leads to lactic acidosis. Further, because of this inflammation occurring, there is release of cytokines which amplify this endothelial injury, and subsequent hemolysis occurs. This hemolysis contributes to anemia, and hypoglycemia occurs due to the parasite consumption, and if patients are initiated on quinine, that causes hyperinsulinemia and that can lead to hypoglycemia. So this is about the simplified version of pathogenesis. So coming to the clinical manifestation and severity assessment, high-grade fevers, rigors, and diaphoresis are there. Neurologically, they can present with coma or seizures. Respiratory, either ARDS or pulmonary edema can be there. Renal, they can present with acute tubular necrosis and eventually develop oliguria. Jaundice can be there because of hemolysis or because of hepatic injury itself. Hematologically, there can be severe anemia, and because of endothelial injury that occurs in the microcirculation, there can be activation of platelets leading to consumption, and eventually consumptive coagulopathy can lead to TAC. Severity markers that need to keep in mind is GCS less than 11 or more than 2 seizures in 24 hours, lactate more than 5, severe acidosis with creatinine more than 3, urine output less than 0.3 ml per kg per hour, hemoglobin less than 7 with presence of shock, or parasitemia more than 5% in low transmission areas or more than 10% in high transmission areas. Now, why this is very important is these all form the basis for your ICU admission. If these are there, you need to take that patient into your ICU. So diagnostic testing, you have peripheral blood smear, thick and thin films, which is the gold standard for diagnosis. It aids in species identification and parasite count. It is usually repeated every 12 to 24 hours if negative, but the suspicion remains. So rapid diagnostic tests that can be done are histidine-rich proteins, that is HRP2 or parasite LDH. So one thing you need to keep in mind is, if at all you're able to remember, well and good. PF, Plasmodium falciparum, histidine-rich protein 2 gene deletion usually leads to false negatives. Then PCRs, it is the most sensitive, so it can detect up to 1 parasite per microliter, but not widely available for urgent diagnosis. Then supportive labs, complete blood count, liver and renal functions, arterial blood gas, serum lactate, and blood glucose. So it needs to be checked hourly if quinine is used. So the treatment is intravenous artesunate 2.4 milligram per kg at 0, 12, and 24 hours, and then every 24 hours till orals are tolerated. Then you can step down to oral artemisinin therapy based combinations like artemether lumefantrine or artesunate amidaquine to complete 3 days. So the total duration they say is between 5 to 7 days, but just remember it as 7 days. So if artesunate is not available, then you can go with IV quinine, 10 milligram per kg infused over 4 hours every 8th hourly, plus doxycycline or clindamycin. With regard to pregnancy, artesunate is safe in all trimesters. Then supportive management, cautious fluid resuscitation, especially if presence of pulmonary edema is present. Transfuse blood cells if HB is less than 7. Treat seizures with benzodiazepines. RRT if AK is present, if indicated. Lung protection ventilation for ARDS. So the related trials were the Sequomat trial, which came in 2005. Artesunate reduced mortality by 35% compared to quinine in adults. So then you have the Aquamat trial where artesunate was superior to quinine in African children. So the main references are here. So for the rest of the diseases, I'll just go through it every 5 seconds to the next slide. So I'm not going to go in depth. Just for your revision, I thought these contents would be very helpful.
Sir, you are not audible, sir.
No, I'm not currently speaking. I'm just going
Okay.
through the slides. I'm not discussing this area. This
Okay,
is
okay,
just
sure.
for the candidates for their exam revision. With regard to scrub typhus, it is very, very important to know about this interest trial. Those from CMC Vellore would definitely know about it because this was the place where the study was done. So this was published in the NEJM and it is now considered as one of the main modalities of therapy. So you need to know about it. Okay, so now going to approach to tropical infections in ICU. So there are 6 important areas that you need to focus. One is the immediate, that is within the first 5 to 10 minutes. Then syndromic split. It helps to drive the first test and empiricals. Then diagnostic window by the day of illness, severity assessment, empirical therapy in tropical infections, and platelet transfusion rule. So the initial step in an unstable febrile patient in the ICU, it is important to resuscitate and stabilize. That is, you need to take care of the airway, breathing, and circulation. Draw starter labs, that is, complete blood count, LFT, RFT, VBG, or ABG, lactate with coagulation parameters, and glucose levels. So you need to send 2 blood cultures. So it is important to use PPE or isolation if viral outbreaks are being suspected, especially in like example in cases of Nipah during the first outbreak, there was not much awareness related to that. But during the second time the outbreak had happened in Calicut, so people were aware about it. And so once they were able to identify the symptoms and signs, then immediate communication was made through the hospital and isolation precautions were immediately implemented in the emergency department and in the ICUs. So it is very, very important for very high risk transmission and high fatality associated diseases, isolation precautions being taken seriously. So this component is not usually discussed in most of the tropical diseases, but it is very, very important to know about them. So coming to history and physical examination, with regard to history, it is always important to know about the history to endemic areas, activities like swimming, farming, animal contact, food habits, or insect bites. Then the incubation period. So compare the onset versus the likely infections. Then prophylaxis history, whether history of vaccinations against typhoid, yellow fever, or meningococcus has been taken, or chemoprophylaxis has been taken, especially related to malaria or leptospirosis. And see for any pattern of disease, like a syndromic presentation, like fever with thrombocytopenia, fever with rash, or fever with jaundice, renal involvement, or neurological, pulmonary, or GA syndromes. If any kind of pattern is there, then that will also be able to aid in your diagnosis. So, with regard to the incubation period and the syndromic presentation, usually if it is less than 2 weeks, the commonest organisms that infections you need to look into are malaria, dengue, rickettsial fevers, leptospirosis, typhoid, viral hemorrhagic fevers, diarrhea, arboviral encephalitis, and Zika virus. Whereas if it is 2 to 6 weeks, then it goes into a subacute phase. So malaria, typhoid, hepatitis A and E, amoebic liver abscess or leptospirosis needs to be considered. Whereas if it is more than 6 weeks, then malaria and TB need to be looked into. So the syndromic split, it helps in guiding the first test and the empirical therapy. So if at all there is fever and rash, the suspected infections are dengue, chikungunya, rickettsial infections, meningococcemia, viral hemorrhagic fevers. Whereas if there is jaundice with AK and pulmonary hemorrhage, leptospirosis is the top differential you need to keep in mind. Then if there is SR with ARDS or MODS, then scrub typhus is your high suspected DD. So if fever with jaundice alone is there, then you have a wide variety of differentials like viral hepatitis, leptospirosis, malaria, scrub typhus. Whereas if it is a hemorrhagic fever, it can be because of dengue, Ebola, yellow fever, malaria, and leptospirosis. Whereas if there is fever with CNS signs, then there can be viral encephalitis, cerebral malaria, leptospirosis, which can cause aseptic meningitis, typhoid meningitis, and scrub typhus related encephalitis. So diagnostic windows by the day of illness. So day 0 to 5, usually it is preferable to go with PCR testing. All right. So for malaria, you can go with thick and thin smears or rapid diagnostic testing. For dengue, you can go with NS1 NS1 PCR. For lepto, scrub, or Zika, you can go with PCR and NAT studies. The main reason why I'm emphasizing on PCR is in this period, the 0 to 5 days, serology testing is generally not advised because when the virus or the organism enters your body, the body's natural response is to attack it. So, for that to attack and produce immunoglobulins, it takes some time. So, usually, only after 4 to 7 days is the time when you really get these evident immunoglobulins in your system. That is the immunoglobulin M and the immunoglobulin G. That is IgM and IgG. So the IgM levels that we normally look into will be apparently seen only after 5 to 7 days. And for leptospirosis infections, they say to test it after 7 to 10 days. So initially, when they present within 5 days of your fever, that is the fever sets in within 5 days, serology testing most of the time would turn out to be negative. So in those kind of scenarios, PCRs are a better testing modality. So if it is more than 5 days, then you can go with serology testing. So another important thing is to know about this thing called PRNT, that is the plaque reduction neutralization test. Especially it is done mainly in patients with Zika. So many a times there can be co-infections which can be missed. So if you do this PRNT, it can help you identify and differentiate between Zika and dengue. So for typhoid, the gold standard is to go with blood cultures. And if there is prior antibiotic exposure, then you can go with bone marrow cultures if it is feasible. So severity assessment. So in the initial slides that I put, along with clinical manifestations, I had mentioned severity assessment. So severity assessment is mainly done to decide on ICU admission. So for malaria, GCS less than 11, lactate more than 5, parasitemia more than 5 to 10%, presence of shock, ARDS or AKI. Dengue, if there are warning signs, you admit, or there is severe dengue with plasma leak or shock, or ALT/AST more than thousands with severe bleeding. For lepto, bilirubin more than 10, creatinine more than 3, or PF ratio less than 200 with evidence of diffuse alveolar hemorrhage. For scrub, if there are features of encephalitis, myocarditis, ARDS, AK, or jaundice. For typhoid, if there is shock, presence of a bowel perforation, massive GA bleed, encephalopathy, or there is an XDR risk. For Zika, if there is rapidly progressive GBS, encephalitis, or autonomic instability, another one thing that I missed here is Zika-related ITP is very common. So if patients present with very low platelets with evidence of bleed and background of Zika, they need ICU admission. So empirical therapy in tropical infections, doxycycline covers scrub and lepto, IV artesunate if severe malaria is possible, broad spectrum antibiotics for typhoid with shock or XDR suspicion. So you need to go with meropenem. If these XDR risk factors are not there, then ceftriaxone is sufficient. Then once you get the diagnostic testing done and you are able to identify an organism, then you can go with targeted therapy. Then supported bundles. For dengue, you go with precision fluids, blood and platelet transfusions when indicated. For lepto, early RRT and ventilation for DH. For scrub, you need to go with combination therapy, that is doxy and azithro, that is based on the interest trial. Then for typhoid, if there is presence of perforation or bleed, then you need to get a surgical consent. And for Zika, if there is presence of GBS, you need to go with IVAG. Even if there is presence of ITP, IVAG is the mainstay of treatment. So platelet transfusion rule, if it is less than platelets is less than 10,000 without bleeding, prophylactic transfusion is needed to prevent the risk of spontaneous life-threatening bleed. Active bleeding, CNS involvement, or invasive procedures, you need a higher threshold, around 20 to 50,000. In dengue, avoid routine prophylaxis, transfuse only if less than 10,000 or clinical bleeding is present. So quick lab clues. For malaria, you identify for parasites on smear. Then for dengue, if you see that there is a high hematocrit with a drop in platelets, then it goes more in favor of it. For leptospirosis, bilirubin disproportionate to the transaminitis. For scrub, presence of SR, hyponatremia, and thrombocytopenia with transaminitis. For typhoid, culture positivity with relative bradycardia, and for Zika, they may present with positive urine NAT up to 14 days, and they present with GBS commonly. So this is related to tropical infections. So then coming to the next important topic is acute diarrhea and the critically ill. So diarrhea is a common finding in critically ill patients, whatever the initial cause of admission to the ICU may be. The prevalence of diarrhea in the ICU population is between 14 to 21%. So a concise and standardized diagnostic approach to diarrhea is mandatory for appropriate management. So the problem with diarrhea in critically ill patients are it is associated with the increased discomfort in a conscious patient, associated with perianal skin damage. It consumes nursing time and increased use of linen and other consumables. Plus, it causes contamination of nearby wounds and or femoral catheters if are present. Then electrolyte loss and dehydration can occur. So this can be very detrimental in patients with hemodynamic instability on vasopressors. So diarrhea can be divided based on three criteria. One is the stool frequency, stool volume, and stool consistency. So stool frequency, passage of 3 or more liquid or unformed stools per day. That is based on the stool frequency. Based on the stool volume, more than 200 grams per day or 250 ml per day, important in patients on colostomies. Based on the stool consistency, unformed or watery stools, that is Bristol type 5 to 7. So based on the chronology, it can be acute, persistent, or chronic, where acute is less than 2 weeks, persistent is 2 to 4 weeks, and chronic is more than 4 weeks. And based on the severity, it can be mild diarrhea or severe diarrhea. So mild is without dehydration or electrolyte imbalances, whereas severe is presence of fluid loss, that is dehydration, and need for electrolyte replacement. So coming to the etiologies, it can be disease related. So non-specific like gut hypoperfusion or hypoalbuminemia. Specific causes can be there because of pancreatitis, inflammatory bowel disease, terminal ileal resection, and short bowel syndrome. Then it can be medication related. So medication related, it can present with antibiotic associated with colitis like C. difficile, antibiotic associated with without colitis, and use of hyperosmolar preparations like hypertonic or sorbitol containing medications like lactulose or Kayexalate, oral electrolyte solutions, especially potassium. Then feed related, due to lactose intolerance or bacterial contamination, especially with blenderized feeds, and hyperosmotic feeds with low fiber formula. Then infectious causes like viral infections like norovirus, rotavirus, adenovirus, or CMV, bacterial like E. coli, Salmonella, Shigella, Campylobacter, Staph aureus, Bacillus cereus, or Vibrio cholerae, and protozoal, which is suspected in HIV positive patients like Entamoeba, Isospora, or Cryptosporidium. So the pathophysiological manifestation in critically ill patients, either they can be because of osmotic diarrhea, secretory diarrhea, or motor impairment. So osmotic diarrhea, it occurs due to reduced water absorption as a result of increased osmotically active non-absorbable molecules or a short passage time. So it is mainly seen with hyperosmotic medications, hyperosmolar enteral feeds, osmotic laxative abuse, or Whipple's disease. So it is seen as watery stools with an increased stool osmotic gap. Secretory diarrhea, on the contrary, occurs as a result of mucosal secretion of electrolytes and fluids into the interstitial lumen with or without decreased absorption. So it leads to watery and voluminous diarrhea. So it is seen due to increased gut permeability as in infections or inflammation, secretagogues, vasoactive intestinal peptides producing tumors, and gastrinomas, and non-osmotic laxatives. Non-impairment can occur due to decreased area of contact or gut hypermotility with decreased time of contact between the gut contact and the intestinal mucosa. That is seen in short bowel syndrome and diabetic neuropathy. So these are the three classifications and manifestations of diarrhea in critically ill patients. So the normal stool osmolarity is between 290 to 300. So stool osmolar gap is the measured osmolarity minus 2 into sodium plus potassium. So the range is between 50 to 100. If it is less than 50, it is secretory. If it is more than 100, it is osmotic. So the clinical features, if it is a non-infectious, non-inflammatory diarrhea, it is non-bloody, there is no fever, it is usually osmotic. So stool output predominantly with feeding, or it can be malabsorption associated with increased stool fat or foul smelling, especially in patients with pancreatitis who have been on long-term ICU stay because of the poor release of pancreatic enzymes. There can be malabsorption which can occur. So management of these patients would be with use of pancreatic enzymes. Whereas for infective or inflammatory, the stools with mucus or blood can be there, which can be infective or ischemic, with associated fever, abdominal pain plus or minus distension, and vomiting. So the diagnostic approach, you always need to go in a stepwise manner: history, examination, and testing. So history, first general history that you need is the onset in relation to hospitalization, the duration, the characteristics, whether it is bloody, watery, or postprandial, travel history, dietary history, and immunocompromised state. Then medical history, history of IBD, chronic pancreatitis, short bowel syndrome, hyperthyroidism, post-cholecystectomy status, or high osmolality diet with low fiber. If they are on any current medications like oral electrolyte solutions, lactulose, sorbitol containing medications, or antibiotics like erythromycin or azithromycin. Then in the physical examination, you need to assess the volume status, review the previous electrolytes, assess for perianal inflammation, see for fever, and if infectious diarrhea is present, then you need to look for also hemolytic uremic syndrome. Then diagnostic testing, you need to check the complete count, blood counts, check the albumin levels, electrolytes, and blood cultures if it is required. Then specific testing, you need to assess a stool routine, stool culture, and stool for ova and parasites, especially in immunocompromised cases. If there is more than 3 days of ICU stay with antibiotic exposure being there, then C. difficile workup needs to be done. So if there is bloody diarrhea after presence of shock, then ischemic colitis is another differential you need to keep in mind and consider CT for ischemia evaluation. So I had mentioned about the stool osmotic gap where it is beneficial is in patients with persistent or chronic diarrhea. So if diarrhea is present with more than 3 days of ICU stay, first thing is you check if the fluid and electrolyte status is disturbed. If it is disturbed, you correct it, then you go ahead with further workup. Whereas if there is no disturbances, then you check whether it is patient is possibly infectious, immunocompromised, or there is presence of bloody diarrhea. So if it is present, then you need to work up further. If neither of them are present, then you don't need to work up further. So then once you see if there is infectious or immunocompromised or there is presence of dehydration with electrolyte imbalances, you assess for signs of infection. Temperature more than 38.5, bloody stools with fecal RBCs. If it is present, then you need to do a stool workup for C. difficile and specific pathogens according to the symptoms and immunosuppression state. So bacterial infections you need to consider are E. coli, Salmonella, Shigella, Campylobacter, Vibrio or Bacillus cereus, viral, rotavirus, adenovirus or CMV, and protozoal like Microspora, Isospora, Cryptosporium, and Strongyloids. So if the workup is positive for these pathogens, then you treat them accordingly. If workup is negative or if it is positive, then you evaluate for concomitant factors also, because many times that may be multifactorial. If there is no signs of infection, then you assess for risk factors exposure like antibiotic use, immunosuppression, and contaminated feeds. If these are there, then again you need to work up for C. difficile or other infective diarrhea. If neither of them are there, then it is probably non-infective. So then you assess for medical etiologies. So if there is chronic pancreatitis because of exocrine deficiency, then you need to do pancreatic enzymes. Whereas if it is endocrine, like diabetic autonomic neuropathies, hyperthyroidism, or Zollinger-Ellison syndrome, then you need to treat the triggering factor. So if there is intoxications like heavy metals, you need to decontaminate and chelate. For inflammatory bowel disease and short bowel syndrome, again, you need to treat the underlying precipitating factors and consider immunosuppression therapy. If none of these are there, you check the enteral formulation feeds if there is high osmolality, high fat, and no fiber. So if it is that, then you need to go with low osmolality, semi-elemental, or high fiber diets. If enteral nutrition formulas are not a problem, then you check the medications. So non-absorbed sugar-containing medications, hyperosmolar medications, or antibiotics if they are present. If they are there, optimize your medications. Change oral to IV whenever possible. If there is no problem with medications also, then you go with assessment for gut hypoperfusion. So based on that, you optimize your nutrition and monitor for bowel ischemia. So just for completion, mechanism of antibiotic-induced diarrhea without colitis because of a direct prokinetic effect of antibiotics on the GI motility, especially with erythromycin and azithromycin. Microbial modification of unmetabolized carbohydrates causing osmotic diarrhea. Unmetabolized dihydroxy bile acids due to the disturbed microbiota inducing secretory diarrheas. So these are the three important mechanisms of antibiotic-induced diarrhea without colitis. So once you've identified the etiology, you need to optimize and then observe in the ICU. So if no signs of infection are there, is not immunocompromised, is not elderly with persistent diarrhea despite optimization, then you need to consider antidiarrheals. So the most important complication that's usually seen is perianal skin lesions and associated wound infection. So it is very, very important to avoid this. So whenever the patient passes stools, it is important to clean it as early as possible because the increased duration of contact of the stools with the skin can lead to inflammation. So next, coming to the very important topic, that is C. difficile. So C. difficile is one of the causative organisms of antibiotic associated diarrhea. So it can manifest as C. diff associated diarrhea, pseudomembranous colitis, and toxic megacolon. It is highly transmissible via fecal-oral route via ingestion of spores. The organisms can be cultured easily from the hospital environment, including hands, clothing, and stethoscope of healthcare workers. So the general risk factors are disruption of the indigenous microflora, mainly because of antibiotics like fluoroquinolones, clindamycin, cephalosporins, and carbapenems. Then cancer chemotherapeutics, pre-operative bowel preparation. Then opportunity for infections like prolonged hospital stay, microbial factors like toxigenicity and additions, and diminished gastrointestinal defenses like reduced or suppressed gastric acid secretion like use of PPAs, parenteral nutrition, and GI surgery. So prior risk factors associated are old age, cancer, CKD, bedridden state, and long-term use of corticosteroids. So coming to the microbiology, C. difficile is an anaerobic gram-positive spore-forming toxin-producing bacillus. So it exists in two forms. One is the spore form, which is outside the colon. It is resistant to heat, acid, and antibiotics. Whereas the vegetative form is when it is in the intestine, fully functional toxin producing form, and it is susceptible to killing by antimicrobial agents. So the toxins, C. difficile produces two toxins that mediate colitis and diarrhea by entering intracellularly via carbohydrate binding. So toxin A or enterotoxin causes inflammation leading to intestinal fluid secretion plus mucosal injury via release of chemokines and cytokines. That is arachidonic acid metabolites IL-1, IL-6, and TNF-alpha, leading to formation of pseudomembranes via neutrophil activation. So this is about toxin A. Toxin B is once intracellular, they disrupt the cellular pathways involving cytoskeletal structures and signal transduction, leading to disruption of tight junctions, leading to colonic mucosal damage and promoting shallow ulcers on the mucosal surface. So the important thing you need to keep in mind, pseudomembranes are associated with toxin A and mucosal surface ulcers are associated with toxin B. So coming to the pathogenesis, for the first infection, antimicrobial therapy leads to disruption of colonic microflora. C. difficile exposure and colonization occurs, leading to release of toxin A and B. So that leads to mucosal surface injury and inflammation. So recurrent infection can be due to persistent spores from the initial infection or reinfection by exogenous C. difficile in association with an impairment of host response. So the clinical manifestations, we have a non-severe disease where there is watery stools, that is more than 3 stools in 24 hours, lower abdominal pain with cramping, low-grade fever, nausea, and vomiting. In absence of the above features, unexplained leukocytosis may reflect C. difficile infection in at-risk populations. Then you have something called recurrent disease. So recurrent C. diff is defined as resolution of C. diff symptoms while on appropriate therapy, followed by reappearance of symptoms within 2 to 8 weeks. So that is the timeline. Then you have severe colitis, that is diarrhea, lower abdominal pain with distension, fever, hypovolemia. Because of that hypovolemia, lactic acidosis is there. Then associated hypoalbuminemia, elevated creatinine, and leukocytosis. So the last 4 are lab parameters. The first 4 are clinical manifestations. Then you have fulminant colitis, that is severe colitis with the below findings, that is severe hypotension leading to multi-organ dysfunction and megacolon. More than 7 centimeter diameter in colon or more than 12 centimeters in the cecum. So 4 manifestations are there which can manifest, non-severe disease, recurrent disease, severe colitis, and fulminant colitis. So coming to the diagnosis for lab testing, you can go with nucleic acid amplification testing via PCR. It's a type of agnostic test that detects the genetic material in C. difficile. So it identifies the TED-B, which encodes for toxin B. It is a high sensitivity but low to moderate specificity. Then glutamine dehydrogenase via enzyme immunoassay. So it detects the highly conserved metabolic enzyme present in all levels or in high levels in all isolates of C. difficile. The advantage is it is usually available in 1 hour. However, since it is present in both toxigenic and non-toxigenic strains, GDH lacks specificity. So the important thing is it needs to be combined with another test. Then C. diff toxin AB via enzyme immunoassay. It has moderate sensitivity but high specificity. So the problem is there are chances of high false negativity as 100 to 1000 picogram of toxin must be present for the test to be positive. So now the recommendation for diagnosis, usually they go with assessment of toxin A and B, and along with that they also check the GDH levels because that helps in better identification. Then selective anaerobic cultures via rectal swab specimen detects vegetative cells and spores. It is highly sensitive but takes several days to finalize, not routinely recommended for clinical use. Then cells culture cytotoxic assay detects the toxins directly in stools, begins with preparation of stool filtrate which is added to a monolayer of an appropriate cell line. Following incubation, the cells are observed for a cytopathic effect. It has a good sensitivity and specificity, however, it is time consuming and labor intensive and not routinely practiced. So for C. diff workup, you send stool for GDH and toxin AB. So if GDH is positive, toxin is positive, testing consistent with C. diff. Whereas if GDH is negative and toxin is negative, it is not consistent with GDH. With C. difficile. Whereas if one is positive and other is negative, then it is an indeterminate result. Then you do a NAT. If NAT is positive, consistent with C. diff. If NAT is negative, it is not consistent with C. diff. So the important differentials you need to keep in mind are acute colonic pseudo-obstruction, other antibiotic-associated diarrhea with colitis like Staph aureus, Klebsiella oxytoca, or Clostridium perfringens. Non-infectious like inflammatory bowel disease or celiac disease, and enteral feed-related bacterial contamination. So for diagnosis, radiographic imaging, CT imaging on the abdomen and pelvis with oral and IV contrast is the preferred modality. So plain X-rays may be useful in circumstances where CT is not readily available. So colonic dilatation more than 7 centimeters in dilatation in the setting of CDA is diagnostic of a toxic megacolon. So the other findings that can be there are air fluid levels, thumb printing, bowel perforation. So rigid sigmoidoscopy is not warranted if the patients have typical features of C. difficile with positive lab test with or without clinical response to empirical therapy. It is recommended if alternative diagnosis is suspected that requires direct visualization with biopsy. In patients with ileus or fulminant colitis in the absence of diarrhea, in this situation, sigmoidoscopy can be done. So it helps in visualization of pseudomembranes. Biopsy per se is not needed for C. diff diagnosis. It is only warranted to establish an alternative diagnosis. So the general principles of treatment, number one, which you need to keep in mind when you answer is the infection control. So patients with suspected or proven C. diff should be managed with contact precautions. Healthcare workers should wash hands with soap and water rather than alcohol-based solutions before and after patient contact. The main reason for this, alcohol-based solutions are resistant to microbial spores. Then discontinuing inciting antibiotics and PPIs. If ongoing antibiotics are crucial for treatment of primary infection, it is prudent to select antibiotic agents that are less frequently implicated in C. diff associated infections. So treatment of the inciting antibiotics is associated with prolongation of diarrhea, increased likelihood of treatment failure, and increased risk of C. diff, recurrent C. diff. Then management of fluids, nutrition and diarrhea. Correction of new fluid and electrolyte imbalance is very, very important. As diarrhea is due to colonic process, instituting measures or lactate-free diet is not needed. Antimotility agents are only reserved for use in patients with fluid losses in the absence of ileus or colonic distension. So for specific management, non-severe illness, you can go with oral fidaxomicin 200 milligrams 12th hourly for 10 days or oral vancomycin 125 milligrams q6th hourly for 10 days. Alternative agent, if both of them are not available, you can go with metronidazole. But the problem with this is it is associated with high recurrence rates. For severe illness, you can go with oral fidaxomicin plus oral vancomycin. So due to mucosal disruption, systemic absorption of oral vancomycin can occur. So it is important to monitor the trough levels of vancomycin, especially in patients with creatinine clearance less than 10 ml per minute. So there is no role for metronidazole in severe cases. In fulminant colitis, if there is no ileus, then you can go with oral or nasogastric vancomycin 500 6th hourly with metronidazole 500 8th hourly for 10 to 14 days. If ileus is present, then you can continue with this regimen plus go with rectal vancomycin 500 milligrams in 100 ml of 0.9 ns as retention enemas. And consider fecal transplant and or surgery. There is no role for fidaxomicin in fulminant cases. So coming to recurrences, the first recurrence, you can go with oral fidaxomicin for 200 milligrams BD for 10 days, then 200 milligrams OD on alternate days for 20 days. Or oral vancomycin as pulse tapered therapy. 125 6th hourly for 10 to 14 days, then 12th hourly for 7 days, 24 hourly for 7 days, then 48 hourly for 2 to 8 weeks. This with either of this therapy, you need to add Beslotoxumab. Okay, so that is a map that is targeted against the toxin B. So there is no renal or hepatic dose modification, and you need to be very cautious in patients with congestive heart failure. So the dose is 10 milligrams per kg, and it is a map targeted against toxin B. So this is very, very important. So if there is a second recurrence which has occurred, then you need to go ahead with fecal transplant and also need to repeat Beslotoxumab. So indication for surgery is ileus, significant abdominal distension, peritonitis or significant abdominal tenderness, end organ failure, and failure to improve after 3 to 5 days of maximum medical treatment. So these are the main indications for surgery. So it is done as a subtotal colectomy plus residual stump, rectal stump plus terminal ileostomy. Subtotal colectomy, terminal ileostomy, and a residual rectal stump. So the last topic under this is fecal transplant. So the term microbiota refers to a community of microorganisms comprising of bacteria, viruses, and protozoa in a healthy human. So they influence GA motility, regular mucosal barrier function, epithelial cell turnover, influence immune responses, and suppress pathogen overgrowth. So dysbiosis can be seen due to artificial instrumentation of the upper airways and upper GA tract, host response to critical illness which can lead to ischemic perfusion injury of the GA tract, lack of luminal nutrients in the gut which can cause catabolic starvation of bacteria, and medication like opioids which can cause decrease in the intestinal motility, pH which can alter the pH in stomach and alter the microbiota environment. So the principle of FMT is a procedure. It is a procedure during which minimally processed feces from the healthy donors are transferred into the patient's gut. So the donor microbiota is then engrafted into the recipient, and that increases the microbiota diversity. So restoring the normal bowel function in patients with dysbiosis associated diseases such as Clostridium difficile, IBD, and metabolic syndrome. So these are the three areas where FMT has been studied. So the indications, proven indication is in C. diff and potential role in inflammatory bowel disease, metabolic syndrome, and MODS in critically ill patients. So contraindications are known case of hepatitis B, C, or HIV, known exposure to HIV or hepatitis B in the last 12 months, antimicrobials in the preceding 3 months, major immunosuppression therapy, history of major GA surgery like gastric bypass or partial colectomy, underlying GA malignancy, history of IBD, connective tissue disorder, or metabolic syndrome. So the donor screening investigations are you need to look for CMV or Epstein-Barr, hepatitis A, B, C, E, LFT, syphilis workup, HIV 1 and 2, complete blood count with the differentials, inflammatory markers like CRP and ESR, albumin, urea, creatinine, and electrolytes. In the stool, you need to do a C. diff toxin PCR, fecal microscopy and culture and sensitivity to rule out pathogens, fecal cryptosporidium pathogen, norovirus or rotavirus PCR, and fecal occult blood testing. So the fecal preparation, fresh fecal material should be processed within 6 hours of donor production and stored at room temperature. About 50 grams of fecal matter is mixed with 150 ml of sterile sodium chloride via a blender. So it is filtered by a filter or gauze to clear the large particulate matter which may obstruct the endoscopic channel. Finally, the filtrate is infused into 60 ml syringes, generally 4 to 5 tubes, and then infused into the patient's GA tract. That is the recipient's GA tract. So this is the basic preparation process. So patient preparation and delivery, patient should not be administered any form of antibiotics 12 to 48 hours before the fecal infusion. Bowel should be free of contaminated fecal material prior to donor feces infusion to ensure healthy graft. So the delivery methods, upper GI, you can go with the OGD scopy or nasogastric or nasojejunal tube, and lower gastrointestinal either via colonoscopy or retention enemas. So the side effects are you have serious, minor, and potential. Serious are bleeding, complications of endoscopy like bleeding or perforation, adverse effects related to sedation like aspiration, transmission of enteric pathogens, pneumonia, and IBD flares. Minor complications can be there like abdominal discomfort, bloating, flatulence, diarrhea, constipation, nausea, vomiting with transient fever. And potential complications is transmission of unrecognized infectious agents that cause infections years later. Thank you. So this is my talks for now.
Thank you, Srihari.
Yeah. Okay, ma'am.
Okay, so we'll continue with the sepsis topics now. So the first topic here, so I'll be discussing about 4 important topics. One is the PK/PD of antibiotics in critically ill patients, aerosoled or inhaled antibiotics, fungal biomarkers, and how to manage invasive fungal infections. Okay, so first is PK/PD of antibiotics in critically ill. So in this, which is only relevant for the critically ill and for your exams, I have discussed, because this topic is actually a huge topics. Okay, it will take around 1.5 hours, 2 hours. Okay, because if I have to go in detail about what is absorption, what is elimination, so what drugs are time dependent, concentration dependent, I'm not going to discuss any of these. Okay, these are very basics. So knowing that you people know about it, I'm just discussing some important relevant things which you need to write in your exam. Okay, so coming to the introduction. So the treatment of critically ill patients, it poses unique challenges, particularly during the management of infections. And antibiotics play a pivotal role in combating infections and improving the patient outcomes. However, the pharmacokinetics and the pharmacodynamics of antibiotics in these critically ill patients, they differ significantly from those in the general population. Why it differs? Because there is an altered organ function in critically ill patients. There are changes in tissue perfusion. There is variations in fluid balances. All these can affect your pharmacokinetics, especially your drug absorption, distribution, metabolism, and the elimination. Hence, traditional dosing regimes may therefore achieve inadequate therapeutic drug concentrations in critically ill patients. So basic concept, yes, what is pharmacokinetics? What the body does to the drug. And pharmacodynamics is opposite, what the drug does to the body. And the four important pharmacokinetic processes are absorption, distribution, metabolism, and your elimination. Okay. Now, this is the one which you need to write in your exams. What are the pathophysiological alterations that are seen in ICU patients, which is actually causing inadequate drug dosage in the ICU? Okay, so the first important pathophysiological change is changes in your volume of distribution. So volume of distribution is the thing that when you give a drug, how much amount of the drug is going into the tissues. So how much is it distributed? Okay, so what causes the changes in volume of distribution? The first thing is your sepsis. Okay, in sepsis, there is increased vascular permeability and edema, which leads to substantial transfer of fluids from the intravascular compartment to your interstitial space. So when this occurs, your volume of distribution increases. That is the first cause. Second, most of the ICU patients have presence of any pleural effusions, ascites, and some surgical drains, all of which may also cause increase in your volume of distribution. Second and most important cause is your hypoalbuminemia. So what happens in hypoalbuminemia? There is increased fraction of the unbound drug in the blood. So when there is increased fraction of the unbound drug, it gets freely distributed to the tissues. So this also increases the volume of distribution. Now, why I am so worried about the increase in volume of distribution? Because this increased volume of distribution causes decrease in the maximum plasma or serum drug concentration. That is, there is a decrease in your Cmax and the total drug concentrations over the. So this may lead to potential underdosing, and it usually provides subtherapeutic concentrations. So in such cases, an increase in the dose may be necessary during the initial phase of treatment, and adjustments need to be made based on the unbound drug levels. Okay, so first is increase in volume of distribution and what are its effects. Okay, now second, drug clearance. Okay, what causes the changes in the drug clearance? First, because of the sepsis, there is impaired perfusion of the peripheral organs, especially your GI tract and your kidneys, hindering your drug absorption as well as elimination. Second, there is also reduction in the hepatic blood flow, which may lead to decrease in the drug metabolism. Okay, so when the drug metabolism is decreased, clearance also will be decreased. Third important thing, in the early stages of your sepsis, the most important concept, your augmented renal clearance. So in such cases, if you give a normal dose of antibiotics, that would not be sufficient for this patient. Okay, so augmented renal clearance is one of the factor. Third, if the patient has underlying acute kidney injury or chronic kidney disease, then the drug clearance will be hampered. And the fifth one is your extracorporeal therapy. So what happens in extracorporeal therapies, I will discuss in the coming slides. So why is the altered drug clearance we are worried about? Because it is a key determinant of your maintenance dose adjustments in critically ill patients. So accordingly, depending upon the clearance of the drug, you are going to adjust your maintenance doses. Okay, so this is the second one. Third, changes in drug absorption. Okay, so drug absorption changes, usually this occurs if you're giving the drugs, antibiotics orally. So your oral antibiotics will be affected here. So critical illnesses may affect the GIT and lead to decrease in intestinal peristalsis, mucosal impairment, and altered drug metabolism. So enteric drug absorption and availability are very difficult to predict in such cases. because there will be a lot of fluctuations in your gastric pH, loss of enteric architecture, and decreased enzymatic activity. In addition, all of the septic patients have delay in gastric emptying. Okay, so this may affect the oral antibiotics which we give in the ICU. Example includes your oral ciprofloxacin. Now, fourth is the change in tissue penetration. So the transport of antibiotics to the tissues and subsequently within the tissues, it depends on factors such as the characteristic of the drug, the patient characteristics, what is the disease severity, and what is the target tissue that you need to attack or the drug need to attack. So, but what happens in sepsis? Sepsis, there is significant impairment in your microcirculatory blood flow because there is a lot of endothelial dysfunction, there is presence of microthrombi. So when this occurs, it decreases the tissue perfusion. So whenever you give a drug and your tissue perfusion is reduced, so what happens? There will be a suboptimal antibiotic exposure at the site of infection, the target site. So there will be a potential therapeutic failure, emergence of resistance, and higher morbidity. Okay, so this is the fourth change. Now, what happens in the extracorporeal therapies? Changes. Okay, so the ECMO circuit can sequester the drugs, can alter the apparent volume of distribution, and can affect the drug clearance. How does it do? We'll see. So first, as I told, sequestration of the drugs. So the degree of drug sequestration in the ECMO circuit, it mainly depends on the physiochemical properties of the drug, and the important thing is the circuit factors. Okay, so it depends upon the membrane surface area, the type of tubing which you are using, what is the oxygenator which you are using, and the priming solution. Now, as I told, it will alter the volume of distribution. So the changes in the volume of distributions are influenced by your drug sequestration and the hemodilution from the priming solution. So both of it will cause increased volume of distribution. Then drug clearance. It is usually decreased in ECMO because of reduced renal as well as hepatic perfusion. And almost 50% of those patients who are receiving ECMO will also require RRT. So presence of two extracorporeal circuits further adds to the complexity of the drug's pharmacokinetics. Okay, so these are the 5 important pathophysiological alterations which are seen in ICU patients. Now, how to deal with this is very important. So, the applying PKPD approaches to optimize the antimicrobial therapy. Okay, so PKPD targets can be expressed as, I think everyone knows about this, the Cmax by MIC, time above MIC, or the area under the curve, depending upon whether the antibiotic is dose dependent, time dependent, or AUC dependent killing. Okay, so everyone knows this graph. Try to put this graph, and if possible, try to mention the drugs which are time dependent, concentration dependent, or AUC dependent killing. Now, as I told, how to approach to optimize the antimicrobial therapy. The first approach is try to increase your loading doses. Okay, as I told, most of the antibiotics causes increased volume of the volume of distribution is increased in sepsis, right? So as the volume of distribution of antibiotics is often increased in sepsis, a higher loading doses are needed for hydrophilic antimicrobials. Which are these? Your beta-lactams, vancomycin, aminoglycosides, and colistin, to achieve a similar and adequate therapeutic concentrations. Okay, so they have tried some new regimes. Okay, so some new optimal beta-lactam loading doses have been suggested. Like for Piptas, the loading dose is 8 grams in 3 hours. For ceftazidime, 4 gram in 3 hours. Ceftazidime and cefepime. For meropenem, it is 2 gram in half an hour. Okay, which is based on population PK analysis and Monte Carlo simulations. Okay, but these are just suggested, it's not been followed yet. Okay, so they have done a lot of analysis in this pharmacokinetics, and they have proposed that for septic patients, try to give high loading dose. And the loading dose should not be altered in patients with renal impairment or those receiving RRT. We all know we give the full dose of antibiotic loading dose in AKI, CKD or RRT patients. Now, optimal mode of administration of antibiotics. So in that, the first is your continuous infusion mode. So a lot of debate is been going on whether antibiotics, especially your beta-lactam, to be given as an intermittent dose or a continuous infusion. So most of the studies have shown that continuous infusion mode has improved outcomes, including a higher rate of PK/PD target achievement, higher clinical remission rates, and superior microbiological eradication. So especially this has been tried with beta-lactam antibiotics. Previously, some meta-analysis have demonstrated no superiority by giving a continuous beta-lactam antibiotics in terms of survival. So recently you have your Blink trial. So Blink 3 trial is important for you all. So here they compared outcomes between continuous and intermittent infusions of beta-lactam antibiotics in 7,000 patients. Okay, so a very huge number, but they found there is no statistical difference in all-cause mortality at 90 days. So if you see here, so this is your Blink 3 trial. So 7,000, nearly 7,000 patients, 3,500 in continuous infusion and the remaining 3,000 in intermittent infusion. This continuous infusion was given over 24 hours of either peptaz or meropenem, whereas in intermittent over 30 minutes. Okay, and the primary outcome was all-cause mortality within 90 days after randomization. And if you see, there is no statistical difference between the two groups. But this was a primary outcome. But when you come to the secondary outcome, if you see the clinical cure rate at day 14, okay, it is statistical significant. So it is better with continuous infusions. Okay, so this is about the Blink 3 trial. Now, they've also tried continuous infusions for non-beta-lactam antibiotics, especially linezolid. Okay, these are only observational studies, and this showed that continuous infusion of linezolid was associated with improved alveolar diffusion and better clinical outcomes in terms of clinical improvement and mortality. But still, RCTs are lacking. So whether to give still continuous infusion or intermittent infusion is still in doubt. But if you want a better antibiotic delivery, then continuous infusions are a better option. Now that was the first mode. The second is your inhaled antibiotics. Okay, so inhaled antibiotics have emerged as a potential means of treating your pulmonary infections with limiting the emergence of MDR strains. So a lot of meta-analysis has been done on this, and they have shown that there is significant higher rates of clinical recovery, which is statistically significant. Okay, when you're giving inhaled antibiotics, and the microbiological eradication was also statistically significant, with no difference in terms of mortality or risk of nephrotoxicity. So as such, there is no mortality benefit, but clinical recovery and microbiological eradication are better when you give IV plus inhaled antibiotics. Okay, there are two recent RCTs. These two RCTs you need to remember. I have already, next I'll be discussing about inhaled antibiotics. So there I have told about your inhale trial. So inhale and vaporized trials. So they assess the efficacy of your inhaled antibiotics, aminoglycosides and fosfomycin as an adjuvant therapy, and they failed to demonstrate any benefit of the inhaled route over the standard of care IV administration in the treatment of gram-negative bacteria-related VAP. Okay, so initially there was a huge use of inhaled antibiotics, but now recent trials are showing that as an adjunct therapy they use this. So whether if they used as a standard therapy, whether it will help or what, we need to see. Now, third measure for an appropriate antibiotic dosing and to prevent side effect is your therapeutic drug monitoring and dosing software. Okay, so dosing normograms and therapeutic drug monitoring had initially been introduced as pioneering solutions for optimizing drug dosages. Okay, so first we'll discuss about therapeutic drug monitoring, and second we will discuss about this normograms or the use of AI here. Okay, so therapeutic drug monitoring is the process of measuring a drug's concentration in a patient's blood to optimize the dosing. So it is most beneficial for those drugs which have a narrow therapeutic window, high pharmacokinetic variability, and for which a clear relationship between blood concentration and clinical effect exists. Examples for which therapeutic drug monitoring has to be done are your beta-lactam antibiotics like piptaz, meropenem, vancomycin, aminoglycosides, and in antifungals, the voriconazole. The other drugs where therapeutic drug monitoring are required are your immunosuppressants, your tacrolimus, and your anti-seizure medications. The second one, which I was talking about, dosing normograms. So a new or an innovative approach has been introduced now, that is nothing but the MIPD, that is model informed precision dosing. Okay, so what is this model informed precision dosing? It is a strategy in personalized medicine which uses mathematical models to determine the optimal drug dosage for an individual patient. So unlike a standard one-size-fits-all approach, this MIDP, it accounts for each patient's specific characteristics to maximize treatment effectiveness while minimizing the side effects. So basically here your AI comes into play. So what does this MIPD do? So it takes into account the clinical characteristics, the dosing history, the labs and biomarkers, and then it makes a model. Okay, model-based Bayesian forecasting has been done. And then it determines, and it also understands for that particular patient, if suppose there is a renal disease, suppose if there is a liver disease, so it will understand the individual PK/PD of the patient, and then it will determine the optimal dosing regimens. Okay, so this is about the MIPD. Okay. Now, finally, this is the last slides which tells about the pharmacokinetics. Basically, you should tell the pathophysiology and what are the measures to prevent or what are the measures that are implemented for optimal drug dosing. So the first measure would be your increased loading doses. Second, the mode of drug delivery, where you have your continuous mode and your inhalational mode. And the third one is your MIPD and your therapeutic drug monitoring. Okay, so these are the solutions. Okay. So this is the last slide, which just gives the gist of the class. So in the early initial phase of the sepsis, that is 0 to 24 hours, if you're using the hydrophilic antibiotics, you need to increase the loading doses for both concentration dependent as well as your time dependent antibiotics. Suppose if you are using any lipophilic drugs, then weight-based loading doses has to be done for obese patients. Okay. Next, in the next 24 to 48 hours, which is known as early maintenance phase, you need to consider continuous or prolonged infusions for time-dependent drugs. And you need to adjust drug dosing to renal function, especially for your hydrophilic drugs. So use measured creatinine clearance, use higher dosing in ARC, and use extended dosing intervals for concentration-dependent drugs. Suppose if it is a lipophilic drug, you need to adjust the drug dosing to hepatic function and consider reduced dosing in cases of severe cirrhosis. And for all the other drugs, wherever possible, use your TDMs or your dosing normograms. Now, late maintenance phase, which is more than 48 hours, same for the hydrophilic drugs, you need to adjust the drug dosing according to your renal function. And suppose if the patient is on CRRT, then try to adjust the dose according to your effluent rate. For the lipophilic drugs, it is same. Adjust for the hepatic function, and if suppose the patient is on ECMO, then you need to adjust the doses accordingly. Okay, so this is nothing but this one. If you put it in the exam, the examiner will be happy. Okay, so this completes your PK/PD of antibiotics. So next comes your inhaled or the aerosolized antibiotics. So we all know that lower respiratory tract infections are a leading cause of morbidity and mortality, and antibiotic resistance complicates the treatment. So why we require inhaled antibiotics? What are the challenges in the current treatment with this IV antibiotics? So high dose IV antibiotics are needed to treat any severe infections, especially your MDR infections. But all these drugs have a limited lung penetration. As I told, tissue penetration is low in sepsis, right? That is first. Second, so in LRTIs, most of the bacteria, or if the patient is intubated, especially in a VAP, there is formation of the biofilm. So this biofilm formation, it makes bacteria up to more than 1,000 times resistant to the IV antibiotics which we give. Third, the risk of systemic toxicity, liver toxicity, renal toxicity. So that is more with IV antibiotics, and limited success with existing antibiotics. So a lot of resistance has been developed to lots of IV antibiotics. So these are the challenges which we are facing now. So what are the advantages if you give a inhaled antibiotic? The first is, a very important one is, delivery of high doses of antibiotics directly to the lung, as local antibiotic concentrations are many-fold higher than your minimum inhibitory concentration of the causative pathogen. So local concentration of the antibiotic is high. Second, there is limited emergence of MDR bacteria when you give it locally. Okay, that has been proved in your IASIS trial. Third, limits nephrotoxicity of aminoglycosides and colistin. It doesn't avoid completely, but it limits the side effects. Fourth, when used as an adjuvant therapy, it decreases the duration of systemic therapy. Okay, so in other words, it has a role in antibiotic stewardship. And if used as a prophylaxis, it may reduce antibiotic selection pressure for MDR organisms. So these are the advantages of your inhaled antibiotics. Now coming to the indications. So as I told, it can be used prophylactically in those patients who are at risk for developing your MDR organisms. Second, it can be used as a salvage therapy in cases of failed systemic treatment. Okay, so that there is eradication of colonization, and in those who are at risk of developing AKI where you can't give your systemic antibiotics, you can try inhaled antibiotics. Third, in a documented infection, when there is a failed IV antibiotics, then you can try inhaled antibiotics. Okay, and in severe CAP or nosocomial infections, and especially in immunocompromised patients, if there is any severe degree of bacterial pneumonia, if the patient has an underlying bronchiectasis, bronchitis, PCP pneumonia, or TB, you can try your inhaled antibiotics. Okay. No, it's not easy for all the drugs to be given in the aerosol form, right? So what are the ideal properties of the antibiotics for aerosol therapy? So the first thing is, the agent should be soluble in the solution, right? It should be mixed solution, and it should be able to be delivered as an aerosol. Second, it should kill bacteria in a concentration dependent fashion. It should remain active in the lung and not be degraded by any of the delivery processes. And it can penetrate into sputum and lung secretions or the biofilms that are present. It should have minimal systemic absorption, so thus minimizing some of the toxicity that occurs with systemic administration. And importantly, it should not be injurious to the airway surface. And ideally, it is an antibiotic that does not ordinarily reach high levels in the lung with systemic administration. It should be preservative free, and the particle size should be 3 to 5 microns. So these are the ideal properties. Okay. Now, what are the patient factors which will influence the delivery? That is also very important. Not only the drug, patient is also important. So, what is the degree of the baseline underlying airway and parenchymal lung disease which the patient has? Second, what is the type of pneumonia? Whether it is consolidated versus bronchopneumonia. And important, how do you deliver it? So the tidal volume used and the mode of mechanical ventilation and ventilator settings, especially if the patients are, you're treating it for the VAP. Okay. So in short, this is the best diagram to see what will influence your drug delivery in aerosol antibiotics. So one is ventilator settings are important for us. Okay. Drug characteristics and the loaded dose, ventilator patient interface, what is the type of nebulizer that you are using and where is its position, what is the droplet size, what is the targeted lung concentration, and your heat and humidification. So all these matters. Now, as I told about the nebulizer here. So what type of nebulizer has to be used and where it has to be placed. This is very, very important. Okay. So there are three types of nebulizers. So you will not be able to achieve a proper drug concentration if you are using a normal nebulizer which is present in your ICU. So you need some specialized nebulizers like your ultrasonic nebulizer, jet nebulizer, or the vibrating mesh. Among these three, which is the best one? It is the vibrating mesh. Why vibrating mesh? Because here the particle size is less than 5 micron. And when you give a drug through this, around 60% reaches the patient. There is no heating of solution during administration, which is usually seen with the other two. And it leaves the least amount of residual volume. So nearly 80 to 90% of the volume will be taken into the patient. That's why vibrating mesh is a better nebulizer to give an inhaled antibiotic. Okay, so these are the other things, your ventilatory settings. What should be your ventilator setting? That is also very, very important. So your tidal volume should be maximum 8 ml when you're giving. Okay, your respiratory rate should be 12. Inspiratory flow should be less than 30 and ends expiratory pause of around 20%. This is the ideal settings, but I think most of them might not follow this. And next is about the position. Where to place the nebulizer is a very important thing. Okay. So one important thing is when you are giving nebulizations, when you're using a heat and HME filter, you need to remove it. Okay. Otherwise, all your drug will go to this. Okay. So nothing will go to the patient here. So you need to remove and then give the nebulization. And once you finish the nebulization, reconnect it back. Okay. Now, they're told that three important positions can be used. If you see here, A, B, and C. So this is the ventilator. So here you will be having one of your filter, HME filter in the expiratory limb, and in the inspiratory limb, you will be having a heated humidifier. Okay, so three positions. So position A is in the inspiratory limb at the Y piece. So this is the Y piece. So at the inspiratory limb near the Y piece is the first position. Second position is, this is the ideal position, which is 20 to 40 centimeters from the Y piece. Okay, so from the Y piece, 20 to 40 centimeters away in the inspiratory limb. And third is the C position. This is also same in the inspiratory limb, but at the ventilator outlet. So this is the ventilator at the ventilator outlet. So ideal position is your B1. Okay, but what happens is this position is impractical on a standard commercial circuits. Okay, placing this is not so practical. So you can either consider your A or C. If you're considering the C, if a heated humidifier is used, you need to keep it on during the nebulization. Okay, so this is a position and what has to be done. Remove your HME filter. If there is a heated humidifier, keep it on and it should be placed in A, B, C in the inspiratory limb. Okay. Now, what are the drugs that can be given in the inhaled form? Okay, so if you see, there are a list of drugs. A lot of drugs can be given. A lot of antibiotics, not drugs, sorry, antibiotics. A lot of antibiotics can be given. So the indications will vary. For cystic, this is for cystic fibrosis. This is non-cystic fibrosis bronchiectasis. And for us as an intensivist, this is important for VAP. So for VAP, what are the drugs that can be used? So in the aminoglycosides, gentamicin and amikacin. Okay. Then polymyxin, colistin, most common. So what we use is amikacin and colistin most commonly. Okay. Vancomycin can be used and ceftazidime can be used. Okay. So these are the drugs that can be used for VAP. Now coming to the doses, I will tell you in the last. So what are the side effects? Okay. So these inhaled antibiotics also have some side effects. Like as I told, it can limit the nephrotoxicity or systemic toxicity, but cannot prevent it. So some amount of systemic absorption happens. So a chance of nephrotoxicity is present when you use your aminoglycosides and your colistin. Coming to the local effects. So there could be some airway irritation or inflammation more with colistin, and if the patient is spontaneous ventilation, cough could be present, bronchospasm, wheezing, desaturation and hypoxemia, obstruction of the ventilator circuit, hypersensitivity pneumonitis, and in some cases, rarely even hemoptysis. And why this desaturation or hypoxemia happens? Because of the repeated disconnection from the ventilator, which leads to derecruitment in ARDS patients. Also, there is some amount of infection that is associated with these inhaled antibiotics when you give it. Okay. So now coming to evidence. So what are the guidelines telling whether we can use inhaled antibiotics or not? Okay, so your IDSA ATS guidelines 2016 has a weak recommendation and a very low quality of evidence for the use of inhaled antibiotics. So what did they tell? So for patients with VAP due to GNB that are susceptible to only aminoglycosides or polymyxins, we suggest both inhaled as well as systemic antibiotics rather than systemic antibiotics alone, but it is a weak recommendation. Now coming to the European guidelines. So 2017 European guidelines tell that better to avoid the use of nebulized antibiotics as either adjunctive or substitution therapy, or in infection with either resistor or sensitive organisms. Anywhere they are telling just avoid nebulized antibiotics. Okay, so this is one of the other way of representing the indications. So healthcare associated lower respiratory tract infection. What we have discussed was about the VAP and all. Now what is about the healthcare associated, any healthcare associated lower respiratory tract infection? So how does it progress? First, no bacterial colonization, then tracheobronchial colonization, tracheobronchitis, then VAP, that is the first episode of VAP, and failure of the first line of IV therapy. Now for the initial three categories, so preventive inhaled antibiotics to avoid VAP occurrence can be given. So the green color indicates, yes, you can give. The first episode of VAP, before giving your IV antibiotics, there is no indication. But VAP or ventilated HAP after failure of your first line intravenous therapy, adjunctive or standalone rescue inhaled antibiotics may be considered in selected patient, but their use is not supported by high level evidence. That's why it is orange. Okay. Now I told there are some trials, right? So I have discussed about the inhale and vapor trial. So inhale trial, as I told, there is no difference in mortality. There are some other trials which have done on amikacin, fosfomycin. Here it is amikacin. Okay. So important is your inhale trial where it showed no difference in mortality. And what is the dose? What is the dose of amikacin that has to be given as aerosol therapy and colistin? For amikacin, it is 400 mg BD. Okay. Whereas for colistin, they actually give it in mg. So 75 mg BD, that nearly comes up to 1 million units BD. Okay. So 1 million unit is equal to 80 mg. Okay. So 75 mg means nearly it is 1 million unit. So 1 million unit BD is the dose for inhaled antibiotics and inhaled colistin. Okay. So this completes your second topic. Now coming to the third topic, fungal biomarkers. Okay. So invasive fungal infections are a major cause of morbidity and mortality. Hence, early diagnosis is very crucial to have a better patient outcomes. So biomarkers, they provide rapid and non-culture based diagnostic tools. We all know that fungus takes a lot of time to be cultured. So biomarkers will help for an earlier diagnosis of the invasive fungal infections. So why biomarkers? Because your traditional culture methods are slow and insensitive, imaging often is non-specific, and your biomarkers will actually aid in early and accurate detection. That is the reason biomarkers are important in diagnosing the invasive fungal infections. So what are the key biomarkers? One is your galactomannan assay. Second, your 1,3-beta-D-glucan. Third, mannan antigen and anti-mannan antibodies. PCR-based assays, and your CRAG, cryptococcal antigen. Okay, so we'll discuss one by one. So first, at least you should know in detail about your galactomannan and beta-D-glucan. So galactomannan, so it is a heat-stable polysaccharide that is a component of the cell wall of your Aspergillus species. So it is released during active fungal growth and tissue invasion. Small amounts may also be released by Penicillium and some other molds, but it is most clinically relevant for invasive aspergillosis. So what is the principle of assay? It is based on your ELISA method. So whatever the galactomannan assay is, it is a ELISA method. Okay. So what are the samples that can be sent? So most common is your serum, which is minimally invasive. But if the patient has a pulmonary infections, then BAL fluid can be sent, and it has a higher sensitivity in pulmonary aspergillosis. And if you're suspecting a CNS aspergillosis, you can also send your CSF. So galactomannan can be done in serum, BAL, and CSF. Okay. Now coming to the interpretation. Okay. So usually the results are expressed as ODI, that is optical density index. Okay. So when your serum galactomannan assay, if the value comes more than or equal to 0.5, that is considered positive. It varies according to the guidelines. It's not fixed. Similarly, BAL, if it is more than or equal to 1, that is considered positive. But these values should be interpreted in context with your clinical findings and imaging. Okay. Now, what is the clinical utility? So it helps in diagnosis, it helps in monitoring of the disease, and also helpful in epidemiology purposes. So diagnosis, so helps in early detection of invasive aspergillosis, especially in high-risk patients, like your hematological malignancy, stem cell transplant, solid organ transplant, or prolonged neutropenic patients. Because if you delay treatment in these patients, they may land up in complications. Monitoring. So galactomannan assay levels may decrease with effective antifungal therapy. So in order to see whether the patient is improving or not, you can do your galactomannan assay. And it's used epidemiologically in clinical trials and surveillance. Now coming to the sensitivity and specificity. So sensitivity is around 70 to 90%, but for BAL, the sensitivity is still higher. Specificity is around 80 to 90%, and the performance, it depends on the site of infection, the host immune status, and the type of sample that you send. What are the limitations with galactomannan assay? So we all know there are lots of false positive and false negative results with galactomannan. So what are the false positive? So certain antibiotics like earlier use of piptaz, amoxiclav can result in a positive galactomannan assay. Okay. Otherwise, the second is a cross reactivity with either fungus like Penicillium, Histoplasma, Fusarium. Okay. And this can usually happen from contamination from the foods. Third is any cotton contamination can also result in positive galactomannan assay, and a prior treatment with cyclophosphamide. In some case reports, they showed that your galactomannan assay is positive. This is about the false positive results. Now coming to the false negative results. So suppose if you're sending it in the early infection with a very low antigen burden, or if the patient is already on antifungal prophylaxis or therapy, or if the infection is a localized infection without a bloodstream dissemination and presence of any anti-aspergillus antibodies. In all these conditions, you will get a false negative results. Now, what does the guideline recommend about the use of your galactomannan? Your IDSA and your EORTC, it includes galactomannan as a mycological criterion for probable invasive aspergillosis. What is this? I'm going to discuss in your next topic. And it is recommended as a part of diagnostic workup in high-risk population, especially your hematology or oncology patients. Now that was about your galactomannan. Now comes your 1,3-beta-D-glucan. So this is a polysaccharide cell wall component of many fungi. So that is only for Aspergillus galactomannan, but this 1,3-beta-D-glucan can be present in most of the fungi. So it is released into the bloodstream during invasive fungal infections, and it is present in, as I told, many fungus, Candida, Aspergillus, Fusarium, Pneumocystis, and other molds. But it is absent in your Cryptococcus and your Mucor. Okay, so 1,3-beta-D-glucan will not be positive in your Cryptococcal infections nor your Mucor. Okay. So samples most commonly you're going to send serum. The cutoffs, so if it is more than or equal to 80 picogram per ml, then it is positive. 60 to 79 intermediate, and if it is less than 60, it is a negative result. And results are quantitative, giving fungal load estimation. So how severe is the fungal load, we will be able to know with this. Okay. Now what is the clinical utility? So broad spectrum screening test for all the types of invasive fungal infections, and especially used in immunocompromised patients. Like your hematology already I've discussed, and ICU patient at risk of candidemia or aspergillosis, and also in the diagnosis of PCP pneumonia, you can use this because that forms the cell wall component in PCP also. Now, sensitivity and specificity varies according to the fungus that is present. So I don't want to discuss in detail. So, but it has a very high sensitivity for your PCP pneumonia. It is better when used serially rather than a single test. Now, what are the limitations and the false results with this? So the false positives are usually seen with hemodialysis patients because it contains some cellulose membranes. So it might come as a positive results. If the patient has a recent IV immunoglobulin therapy, certain antibiotics, severe bacterial sepsis. Okay, because gram-positive and gram-negative bacteria release your BDG-like polysaccharides. So severe infections may cause false positive results and any gauze contamination. Okay, so all these cause false positive results. False negative, Cryptococcus and your Mucorales, which I have already told, and early infection or any localized disease. So this is also recognized by your EORTC MSG criteria as a mycological criterion for the diagnosis of invasive fungal infections. It is recommended as an adjunct tool, but not as a standalone tool. And it is best used in combination with your galactomannan and or a PCR for a higher diagnostic accuracy because it is positive in most of the fungus. So you use it either with a galactomannan so that you can diagnose aspergillus, and if a PCR is present, use along with that, but not as a standalone diagnostic test. Now third comes your mannan antigen and anti-mannan antibodies. So mannan is also a component of the cell wall of your Candida species, and it is very specific for your invasive candidiasis. And this anti-mannan antibodies are produced by the immune system in response to fungal mannan. So the presence and levels of these antibodies indicate the host's immune response to the fungal infection. So sensitivity is improved when you do both mannan antigen and anti-monan antibodies. And if both are present, then your sensitivity is improved for diagnosing your invasive candidiasis. Now next comes your PCR-based assays. So usually these PCR-based assays, they detect the fungal DNA in blood, ball and tissue rapidly and more sensitively compared to your traditional methods like cultures. So you have two types, pan-fungal assays and species-specific assays. Okay, and the advantages are, so you can identify difficult to culture fungi. It detects, one more thing is, additionally it detects antifungal resistant genes also. And it guides antifungal therapy in high-risk patient. Disadvantages are inefficient DNA extraction, human DNA inhibition, and a lack of standardized protocols hinder widespread clinical adoption. Now, the last one is your cryptococcal antigen crack. So most commonly we do it in a HIV positive patients. So this detects the capsular polysaccharide of Cryptococcus species. So it is basically a point of care test. So CRAG you will get the results within minutes because it's a point of care test, and the method is your lateral flow assay, which provides results in minutes for diagnosing your cryptococcal infections. And if you come to the sensitivity and specificity, it is very specific and sensitive, 92 to 98%. And you can do this test in both serum and CSF, and it is a preferred test for cryptococcal meningitis. Now, biomarkers by pathogen. So, if it is an aspergillus, so what biomarkers can be used? One is your galactomannan, your beta-D-glucan, and the PCRs. Suppose if it is a candida, you can't use galactomannan because it's only specific to aspergillus. So, you can use your beta-D-glucan. As I told, mannan and anti-mannan are very specific for invasive candidiasis, and your PCR. If it is a cryptococcus, only CRAG, and for pneumocystis, you can use your BDG and the PCR. What are the limitations of biomarkers? So we have seen limitations, a lot of false positive and false negative results are present, and it's not universally available. Some of the hospitals still don't do this galactomannan assay, or it is outsourced. So it's not universally available and best used in combination with clinical and imaging findings. So standalone test for diagnosing it would be a difficult task. So sensitivity I've already discussed. So the future directions for the biomarkers. So there is something known as multiplex biomarker panel. So 2 to 3 biomarkers together in one panel, or it is integrated with next generation sequencing, point of care diagnostics like CRAG, if any other new thing for the diagnosis of your aspergillus or candida, and personalized antifungal therapies. Okay, so this completes your fungal biomarkers. Now coming to the last topic. So invasive fungal infections. So the outline of the topic would be introduction. What are the risk factors in general for any fungal infection? Some definitions, and I'll be discussing about 3 important fungi: the Candida, Aspergillus, and your Mucorales, and just a mention about some important points of the IDSA 2016 guidelines. Okay. So why is fungal infections a problem? So fungi, they generally produce disease only when your immune system is compromised or when some mucosal or integumental barriers are disrupted. Fungal cultures, they lack sensitivity and specificity in some cases, and diagnosis is therefore based on a combination of factors. And the antifungals which you use to kill the fungi, they're actually more toxic to the host because of the similarity in the metabolic pathways. Okay, so basically, uh, uh, your cholesterol metabolism is the one that is there. So ergosterol in case of fungi. So basically the metabolic pathways are similar between your host as well as your fungi. And fungi form biofilms on a variety of indwelling devices, which makes the treatment more difficult. Now, what are the risk factors for all the fungal infections? So when they ask about the risk factors, you can mention this, and I've mentioned specific risk factors for the specific fungi also. So general risk factors are if the patient has an underlying diabetes mellitus, kidney injury plus or minus RRT, parenteral nutrition, acute severe pancreatitis, high Apache 2 scores, prolonged mechanical ventilation, if there is a presence of your CBC and your urinary catheters for a longer time, use of broad spectrum antibiotics for a longer time, prolonged ICU stay, any major surgery, and burns. So these are the general risk factors for any fungal infection. Okay. Now, what are the contributing factors? Vast majority of pathogens are present. A lot of immunocompromised hosts are increasing. Okay. Then longer time for culture results. So treatment becomes difficult. Identification becomes difficult. And upon that, a lot of steroid use is going on. And during the COVID time, it was still rampant. That's where your mucormycosis had become very popular that time. And emergence of a lot of MDR, Candida auris or Candida krusei, and the use of biomarkers are actually making the diagnosis more easier. Okay, so you're actually diagnosing fungal infections a lot nowadays because of the use of biomarkers. Now, coming to the definitions, very, very important, both in your theory, practical, and in your normal understanding. Okay, so what do you mean by prophylactic antifungal therapy, empirical antifungal therapy, and preemptive antifungal therapy? Okay, now coming to the first one, prophylactic antifungal therapy. So this can be of two types, primary prophylaxis or secondary prophylaxis. Primary prophylaxis is administration of antifungal agents to patients who have not had a prior episode of invasive fungal infection and are at a risk for developing one. So there is one of the risk factors, like the patient has an underlying diabetes, uncontrolled diabetes. Patient underwent a major surgery. Okay, but previously these patients have not been exposed to any infection, fungal infections. That is your primary prophylaxis. What is secondary prophylaxis? Here, there is a risk factors plus there is a prior exposure to a fungal infection. Okay, in such cases, that is known as a secondary prophylaxis. Now, coming to the empirical antifungal therapy. It is nothing but administration of antifungal therapy to febrile patients during the period of neutropenia. So, in neutropenic patients, when you administer antifungals when there is a fever prior to a confirmed diagnosis of an invasive fungal infections, that is known as empirical antifungal therapy. What is preemptive? Preemptive means you initiate the antifungal therapy only when you have either a clinical, radiological, or your biomarkers positive. Okay, at least one should be positive to start the antifungal therapy. That is known as your preemptive therapy. Okay, so I think you're clear with the definitions. Next, so we'll go with each of the fungi. So first we will be dealing with your candidiasis. So a lot of candida species are present. Okay, so the most common among them are your Candida tropicalis, Candida albicans, Parapsilosis, glabrata, and recently your Auris and your Krusei. Okay, so important thing you should remember is your Candida glabrata has a high fluconazole resistance. Okay, so hence it is most probably resistant to all the azoles also. Candida krusei is actually inherently resistant to fluconazole, but it is sensitive to oriconazole. So if you get a Candida glabrata, try to avoid any of the azoles. But if you get a Candida krusei, you can treat with voriconazole. Okay. Now coming to the predisposing factors, actually I've already discussed about the risk factors in general. Additionally, GI perforation patients are much more prone for your invasive candidiasis. Now coming to the syndromes or the presentations. Okay, so the most common presentation would be your candidemia leading to sepsis and septic shock, acute disseminated candidiasis where there will be a cutaneous manifestation, endovascular infection. So it can cause infective endocarditis or infections of your implantable cardioverter defibrillator, your ICDs. It might cause osteomyelitis or arthritis, endophthalmitis, and chronic disseminated candidiasis. Okay, so these are the syndromes by which a candida can present. So why is not your UTI nor your LRTI is included in this? Because it is actually a commensal over there, candida. So you can't tell that candida is causing your LRTI or UTI. So these are the manifestations, invasive manifestations of the candida infections. Now, how to diagnose it? Okay, so there are lots of ways to diagnose candida infections. So one is your candida colonization index. Okay, so how do you calculate your candida colonization index? It is a number of sites colonized by candida. Okay, so when you do the cultures, your blood is come positive divided by number of body sites surveyed. Okay, so if the score is more than or equal to 0.5, it is considered positive. Okay, so that is about your candida colonization index. So number of sites colonized by candida. So you think 2 sites you found that candida is positive in the urine and in your blood. Okay, and you have surveyed around 3. So it is around 0.5. So in such cases, you need to treat it. Now coming to the scoring systems. So you have a lot of scoring systems. You have the Lyon, you have the Ostrowski-Zeschner scoring system, the Shore, and your Nebraska. Okay, so important one in this is your Ostrowski-Zeschner scoring. What is it? I'll tell you in the next slide. Next, blood cultures. These are gold standard, but when you come to the sensitivity, it is only 50% sensitive. Then comes your beta-D glucan. So it's a pan-fungal marker with sensitivity and specificity around 80%. So you can add your mannan and anti-mannan antibodies also here. Okay. Then comes your PCR methods, your MALDI-TOF. Okay. And PNA fish, and sometimes to differentiate CNS candida, you can do a T2 candida based assays, which uses an MRI detection to differentiate between candida albicans and your candida glabrata. So this is how you diagnose your candida. So one more index which I forgot is your candida score. Okay. So candida score is abdominal surgery 1, sepsis septic shock 2, total parenteral nutrition 1, multifocal candida colonization 1. So if the score is more than 3, then it is 77% sensitive and 68% specific for your invasive candidemia. So Candida colonization index, I've already discussed. It is also known as the Pettit score. And as I told, there is one score, which is your Ostrowski-Zeschner score. So here, central venous catheter. So there should be a presence of central venous catheter plus more than 2. What are those? Total parenteral nutrition, patient on hemodialysis, patient has pancreatitis, patient on corticosteroids, or patient is immunosuppressed. Any of these 2 plus a central venous catheter in place, then 73%, 74% chances of having invasive candidiasis. Okay, so this is the one. Now, treatment of invasive candidiasis or invasive candidemia. So, the first line drugs are your echinocandins, especially used for moderate to severe illness. These echinocandins, they are sidle drugs preferred for critically ill or those patients who have a recent azole exposure. And the data shows improved survival with echinocandins compared to your triazoles. But it has poor penetration into eye, CNS, and urine. So if you have any infections in these areas, then echinocandins is not a good option. Okay. Now coming to the triazoles. So this can be used, your fluconazole can be used in mild to moderate cases. These are usually static drugs, and these are the drug of choice for your genitourinary candidiasis because it has an excellent urinary concentration. Okay, so here you can't use echinocandin, so you can use your triazoles. Coming to amphotericin B, it is an option to echinocandins in resource limited settings. And adjuvant therapy, suppose if the source control is very, very important. Any source, please remove it, like remover of CVC if possible. And look for any metastatic infections, especially your ophthalmic evaluation and 2D echo to rule out endophthalmitis and your infective endocarditis. Okay, now what is the duration of therapy? So it is 14 days of effective antifungal therapy following negative blood cultures and resolution of illness. Okay, so this is the duration of therapy for Candida. Now, a few words about your Candida auris and Candida krusei. Okay, so Candida auris, so it has become a serious threat to healthcare settings over the last decade, causing serious invasive fungal infections as well as nosocomial outbreaks. So it ranks a second among the critical pathogens in the WHO pathogen list. Now coming to the challenges. It is rapid and easy transmission, environmental contamination with resilience to heat and disinfection, potential for developing antifungal resistance rapidly, and it causes high morbidity and mortality, nearly 23 to 72%. So that dangerous is your Candida auris. And it is difficult to identify by the commonly used phenotypic methods, and it is difficult to manage due to resistance to azoles and a growing resistance to your polyenes. Okay, hence this is very difficult to treat. So how to diagnose this? PCR methods are the best methods to diagnose this, and the cultures. So prevention is better than cure in these cases. So proactive screening to be done, augmentation of your infection control policies to be done, and you need to educate them about this Candida auris. Now, suppose if there is an infection, how to manage it? So this management is divided into an invasive disease, if UTIs, and any colonization. So if there is an invasive disease, so if you find Candida in any of the invasive disease which I have mentioned before, or in the blood, then the drug of choice is your echinocandins. So in case of absence of clinical response and persistent candidemia for more than 5 days on echinocandins, then you need to start your liposomal amphotericin B. Azoles only if susceptibility is confirmed by testing. And what are the azoles that you use here? It is either posaconazole or isavuconazole, because both your vori and fluconazole are resistant to your Candida auris. Okay. Now coming to the UTIs, echinocandins except for micafungin. Means micafungin can be used if it is a UTI. As I told, echinocandins concentration in the urine is very less. But when you see among the echinocandins, micafungin has some of the better penetration into the urine. Okay, so better to use a combination of an echinocandins plus amphotericin B in case of UTIs. So mica plus amphotericin B. If it is a colonization, so CDC does not recommend treating C. auris colonization, that is isolation of C. auris from non-sterile body sites in absence of any invasive disease. So colonization, you need not to worry. Now coming to the next, the Candida krusei. So Candida krusei is basically an opportunistic pathogen. So it primarily affects the immunocompromised individuals, including patients with hematologic malignancies and those undergoing organ transplantation. So what are the predisposing factors? Prior fluconazole administration, neutropenia, and breakdowns in the GI mucosal barrier due to treatments like chemotherapy or radiation therapy. So it demonstrates several virulence factors. So resistance is very high with cruzi. So it forms biofilms and it secretes some aspartyl proteinases which contributes to its adaptation and infection capabilities within the host. Now, antifungal resistance and what is the treatment? So as I told, Candida krusei is intrinsically resistant to your fluconazole. So it can also develop resistance to other antifungals, including your azoles, the other azoles, amphotericin B and echinocandins. But the present treatment option which is available is your echinocandins, voriconazole, or you can use your amphotericin B. So the choice of antifungal, it depends on the patient specific factors, infection severity. If it is very severe infection, echinocandins. If you want to use voriconazole, you need to do a susceptibility testing on it. If it is susceptible, then you can use your voriconazole. Okay. So that is about your candida infections. Now next, coming to your aspergillosis. So what are the most common aspergillus species? Your Aspergillus fumigatus, your flavus, Aspergillus niger, and your Oreziae. Okay, so predisposing factors other than the one which I've mentioned before. So usually this is seen in immunocompromised hosts like prolonged or profound neutropenia, prolonged steroid use and immunosuppressant use, hematopoietic or solid organ transplant patients, primary immunodeficiency states, and emerging risk factors for aspergillosis now are COPD patients, liver cirrhosis, and critically ill patients, and those patients requiring more than 7 days of mechanical ventilation are the emerging risk factors for your aspergillosis. Now, what could be the presentations or the syndromes? So, most common is your pulmonary aspergillosis. It can cause acute rhinosinusitis if your NG tube is more than 2 weeks, tracheobronchitis in lung recipient patients or HIV patients, cerebral aspergillosis in case of diabetic patients, osteomyelitis, cutaneous aspergillosis, and rarely disseminated aspergillosis also. Now, how to diagnose aspergillosis? Very, very important. So, if you see, proven invasive aspergillosis can be told only if you have a positive or histopathology of a sterile sample obtained in a sterile manner. So any lymph node, any tissue, okay, which is obtained sterile form. So the histopathological diagnosis is a proven invasive aspergillosis. Otherwise, if you're using any of these codes, it is either probable or a possible infection. Okay. Now, you have a lot of criteria which are there for the diagnosis of aspergillosis. So, the first and the most important one, you need to remember this completely. The others, you can just remember the names. So your EORTC-MSG, what does it stand for? It is European Organization for Research and Treatment of Cancer, and your MSG stands for Mycosis Study Group. Okay, so this is the criteria given by them. So here you have 3 criterions. One is your host criterion, clinical criterion, and mycological criterion. So what is the host criterion? So what are the risk factors which I mentioned previously? Those are your host criterions. Clinical criterions is you should have a dense, well-circumscribed lesion with or without a halo, air crescent sign, cavity, or a wedge-shaped segmental or a lobar consolidation. So basically, your clinical criterion is nothing but your radiological criterion here. And mycological criterion. What does mycological criterion mean? Positive microscopy or culture from a respiratory sample, or it could be your biomarkers, okay, either GM or PCR positive in ball or blood. So if all the 3 criteria are met, okay, means patient is immunocompromised and patient is having radiological signs with your biomarkers positive, then it is a probable invasive aspergillosis. Okay. If two of the criteria are present, it is a possible invasive aspergillosis. Okay. So this is the your EORTC MSG criteria. The other criteria are your ASP-ICU criteria and BM ASP-ICU. BM is nothing but the biomarker here. Biomarker ASP-ICU criteria. Okay, so these are the recent ones, but this is the most standard one, and you need to remember the criteria here. Okay. I was talking about those halo sign, air crescent sign and all. So what is this halo sign? Halo sign is nothing but you see a pulmonary nodule, and around the pulmonary nodule you see some ground glass opacities. And what is your crescent sign? So you have a small air here, okay, between the mass or the nodule and the cavity wall. So between this, if you have, this is a air crescent sign. All of this indicates invasive disease. Okay. Next comes your galactomannan assay. Same as I discussed there in the biomarkers. So you can just write about the galactomannan assay. So serum 0.5 and BAL 1.0. Okay. Limitations I've already discussed there. Now coming to the treatment. So what is the drug of choice for your aspergillosis? It is voriconazole. So voriconazole 6 mg per kg IV BD for day 1, which is followed by 4 mg per kg IV BD. Please remember the doses. Doses are very important. Now alternative drugs includes your liposomal amphotericin B 3 to 5 mg per kg. Coming to echinocandins. Echinocandins are actually not cidal for aspergillus. They are cidal only for your candida. So it has only a role in salvage therapy or intolerance to amphotericin, or if there is a prior voriconazole prophylaxis which has been taken. Okay. The other drug which can be used are, a last option is your isavuconazole. And the duration of treatment here, if you see, it is 6 to 12 weeks. Okay. So that completes about your aspergillosis. Now comes the third, your mucormycosis. So that has been asked previously in your exams about the mucormycosis. So what are the clinical syndromes which are associated with specific risk factors? So I'm covering the risk factors plus the syndromes here only. So in poorly controlled diabetic, we all have seen during the COVID time, steroids, sugars high. So you have your rhinocerebellar, sinoorbital, or your cutaneous mucormycosis. Okay. In those patients who have immunocompromised state like hematological malignancies, transplants, solid or hematopoietic transplants, pulmonary, sinoorbital, cutaneous and disseminated mucormycosis is common. Penetrating trauma, burns, chelation therapy with desferoxamine, all these are risk factors for mucormycosis. IV drug uses, malnutrition, especially in premature infants, there you will see GI mucormycosis. Nosocomial acquisition, which is linked to contaminated dressings, splints for IV cannulation, etc., may cause cutaneous mucormycosis. And we don't know the etiology. Sometimes you can see even isolated renal mucormycosis. Very rare. These are only some case studies which are present. Okay. So this is how the mucormycosis present. So important for us is your rhinoorbital cerebral mucormycosis. So that is the most common presentation of your mucormycosis, and this is caused by Rhizopus aureus. So how does it occur? It occurs due to inhalation of the spores into your paranasal sinuses of a susceptible host. Hyperglycemia, usually with an associated metabolic acidosis, is the most common underlying condition. That is nothing but your DKA. Okay. So what are the clinical features? So usually patient presents as acute sinusitis. That is fever, nasal congestion, purulent nasal discharge, headache and sinus pain. And when you examine, all the sinuses becomes involved and it spread to your contagious structures. So what are the hallmarks of spread beyond the sinuses? You can see tissue necrosis of the palate, palatal eschars, destruction of turbinates, perinasal swelling, erythema and cyanosis of the facial skin overlying the involved sinuses and or orbit. So when you see all these things, so when you do nasal endoscopy, when you see all these things, this indicates that this might have spread beyond the sinuses and most probably it's going into your brain. So what are the signs of orbital involvement? There is periorbital edema, proptosis, and blindness. And facial numbness is usually frequent in these patients due to infarction of the sensory branch of your cranial nerve 5. Now, how to diagnose this? So, direct microscopy. So, what is the stains which we use for diagnosis of your mucor? It is calcofluor white and methenamine silver. So cultures, it is very difficult to isolate. Histopathology, to differentiate mucor from other molds and to document the evidence of angioinvasion. And radiology, okay, if you have a pulmonary mucormycosis, you will be seeing more than 10 nodular infiltrates, the reverse halo sign, and pleural effusions. So what is reverse halo sign? That is the opposite. So ground glassing in the center, which is surrounded by a dense consolidation. Okay, so if you see here, this is the ground glassing and this is the dense consolidation that is present. This is seen in mucormycosis, pulmonary mucormycosis. So diagnosis of rhinoorbital cerebral infections. So how? One is you have a high risk patient. So you have a DKA patient plus patient has sinusitis, altered sensorium, infarcted tissue in nose or palate. If that is there, yes, this patient is having ROC, your rhinoorbital cerebral mucormycosis. So as I told, endoscopic evaluation of the sinuses, you need to look for tissue necrosis and obtain specimens and send for your KOH stain. Imaging to gauge sinus involvement and evaluate the contiguous structures like eye and brain. So CT is more better than doing an MRI. Now treatment. So important treatment is, other than your medical management, your surgical debridement plus antifungal therapy, both has to be started as soon as possible. Okay, you start the antifungal and please plan for the surgery as soon as possible. Elimination or treatment of predisposing factors like DKA, please treat the DKA. And what are the antifungal drugs for mucormycosis? So the drug of choice is your amphotericin, liposomal amphotericin B, 5 mg per kg OD, maximum you can go for 10 mg per kg per day. Alternatives, posaconazole only as salvage therapy, and it requires 7 to 8 days to achieve therapeutic concentration. And posacanazole's absorption is maximized when taken with high fat food. So these points have to be remembered before starting posaconazole. Adjuvant therapy includes desferoxamine, hyperbaric oxygen, GCSF, and interferon gamma, depending upon the risk factors that are present. Okay. What is the duration of treatment? So until near normalization of radiographic imaging, negative biopsy specimens or cultures from the affected site, and recovery from immunosuppressions. All these 3 criteria has to be met. So there is no fixed duration of treatment for mucormycosis. Although echinocandins have no in vitro activity for the mucorales, the Rhizopus orzae, which causes your rhinoorbital cerebral mucormycosis, it expresses the target enzyme for echinocandins. So suggesting that these agents may have clinical utility only when this is isolated. Your voriconazole, fluconazole, and flucytosine are not effective against mucorales. The biomarkers also we have discussed. So the common biomarkers which are used, they also can't be used for the diagnosis of your mucorales. So now coming to the last part, what does the guideline tells about your treatment of invasive fungal infections? So next 5 to 10 minutes. So if you have a candidemia in non-neutropenic patients, okay, so candidemia means it is echinocandins. Okay, invasive candidiasis or candidemia means better to use echinocandins. Okay, so echinocandins is recommended as the initial therapy, but if it is a non-neutropenic patient, You can use fluconazole when the patient is not critically ill and when you have done a susceptibility testing, it is susceptible to fluconazole. Then only you can use fluconazole in case of candidemia in non-neutropenic patients. Okay. And they tell that the guidelines tell testing for azole susceptibility is recommended for all bloodstream and other clinically relevant candida isolates. So other than your urine and lung, wherever your candida is there, you need to do a azole susceptibility testing. But echinocandin susceptibility testing is not required as a routine. Okay. So only in cases of Candida glabrata or Candida parapsilosis, you need to do the echinocandin susceptibility testing. Now, as a reasonable alternative, you can use lipid amphotericin B. Okay, when there is some intolerance or limited availability or resistance to other antifungal agents. Voriconazole offer little advantage over fluconazole, and this can be used voriconazole only if there is evidence of your Candida krusei. Okay, and guidelines suggest, very important point, follow-up blood cultures should be performed every day or every other day, alternate day. I don't know whether it is really feasible or not, to establish the time point at which candidemia has been cleared. It has a strong recommendation. And the duration of therapy, I've already told it, 2 weeks after documented clearance of candida from either bloodstream and resolution of symptoms which are attributable to candidemia. It has a strong recommendation. Now coming to candidemia in neutropenic patients, it is only drug, it is your echinocandins. And your GCSF can be considered in cases of persistent candidemia with anticipated protracted neutropenia. It has a weak recommendation. Okay. And as we all know, growth of candida from respiratory secretions usually indicate colonization and rarely requires treatment with antifungal therapy. Strong recommendation. Now coming to the UTIs, asymptomatic candiduria. So elimination of predisposing factors such as an indwelling bladder catheter is recommended whenever feasible, which has a strong recommendation, and treatment with antifungal agent is not recommended unless the patient belongs to some high-risk group. What are those high-risk groups? One is neutropenic patients. Second, this is in infants, very low birth weight infants, and patients who will undergo urological manipulations. So you're planning for some urological procedures. In such patients, if you see in urine there is some candida, then treat that candida. Okay. So symptomatic candida cystitis. So as I told, your azoles are the better drugs for your UTIs. So either fluconazole or oriconazole can be used. Suppose if there is any fluconazole resistance that is present, you can use even amphotericin deoxycholate, not liposomal amphotericin B, because it need to pass into your renal system. So the better would be your amphotericin deoxycholate. And if you find krusei, then the drug of choice for symptomatic krusei cystitis is your amphotericin B deoxycholate. Any indwelling catheter, try to remove that catheter. It has a strong recommendation. And there is some weak recommendation for bladder irrigation with your amphotericin B deoxycholate. Okay, so that is one of the things that they can try. So coming to aspergillosis, so how should galactomannan and 1,3-beta-D-glucan be used for the diagnosis of aspergillosis? Yes, serum and galactomannan assay is recommended in certain patient subpopulations. Okay, like your hematological malignancy or your hematopoietic stem cell transplantation, which has a strong recommendation. And galactomannan assay is not recommended for routine blood screening in patients receiving mold active antifungal therapy or prophylaxis, but can be applied to bronchoscopy specimen from those patients. It has a strong recommendation. Now, the role of bronchoscopy in the diagnosis of invasive pulmonary aspergillosis, it has a strong recommendation. So you need to perform a BAL. Now, antifungal agents for the treatment and prophylaxis of invasive aspergillosis. So, for invasive aspergillosis, the drug of choice is voriconazole. The alternative would be your amphotericin B. Echinocandins are used for salvage therapy. Okay, so this completes your invasive fungal infections. Thank you. If any doubts, please put it in the chat box. We will discuss there.
Yeah, is the screen visible?
Visible, Srihari.
Okay. Okay. So now next I'll be covering a very important topic, that's infection control in the ICU. So under infection control, these will be the main areas that I will be covering: designing, classification of infections, then standard precautions, isolation precautions, surveillance, bundle care, surveillance cultures, then antimicrobial stewardship. So coming to introduction and designing of ICU, the risk of transmission of pathogens and subsequent infection in healthcare facilities is significantly high. So pathogens may be transmitted from other patients via hospital personnel and or hospital environment. So the risk is variable and it depends on the patient's immune status, the local prevalence of various pathogens, infection control practices, and antimicrobial stewardship utilized during the hospitalization. So coming to the microbiology of infections in ICU, over the years there is a shift towards more resistant strains like MRSA, VRE, ASBL, CRE, CRAB, azole resistant Candida. So these pathogens play a major role in hospital-acquired infections and it is associated with increased morbidity and mortality. And it is associated with increased financial burden. So major factors contributing to this resistant strains developing are, the most important is antibiotic pressure. So selective pressure due to prolonged antibiotic exposure constituting an independent risk factor which determines colonization and infection status of MDR organisms in ICU. Example, antibiotic prophylaxis more than 48 hours is not associated with decreased risk of surgical site infections, but it actually increases the risk of colonization with multi-drug resistant organisms. Then severity of illness. Higher the severity, increased is the risk of multi-drug resistant organisms. Interruption of normal defense mechanisms like intubation and mechanical ventilation and malnutrition. Most clinically significant infections in ICU are VAP, CRBSA, and COTI. So the focus in ICU setting for infection control are hand hygiene, ICU isolation precautions, environmental cleaning, prevalence of device-related infections, active surveillance, and monitoring of infections in the ICU. So this will help in curbing the prevalence of MDROs, thereby decreasing infection rate. So coming to the classification of ICU infections, the infections in ICU are always crucial and need to be classified for any surveillance program. So the traditional approach was the cutoff of 48 hours has generally been accepted for differentiating community-acquired and hospital-acquired infections. But this concept has been challenged in the recent days because of this concept of carrier state. So condition of harboring an infective organism without manifesting symptoms of infection like HIV, TB, typhoid, Epstein-Barr virus. So hospital-acquired infections have been classified on the basis of carrier status of potential pathogenic microorganisms and diagnostic cultures. So you can classify them into three classes: primary endogenous infections, secondary endogenous infections, and exogenous infections. So here the microbial flora composition are both normal and abnormal pathogenic or potential pathogenic organisms like Streptococcus pneumonia. Whereas in secondary endogenous infections, it is aerobic MDR gram-positive cocci and gram-negative bacilli like MRSA and VRE. Whereas exogenous infections are mostly MDR nosocomial pathogens like Acinetobacter. So primary endogenous infections are usually the commonest with a frequency of 50 to 80%, whereas secondary endogenous infections contribute to 30% and exogenous infections contribute to 15%. So the mechanism of occurrence of primary endogenous infections is by imported uh, infections in the ICU during admission of the patient. Whereas secondary endogenous infections are colonization on skin, oropharynx, stomach, and intestine. Exogenous infections is hand of healthcare workers or contact with inanimate surface. So the time of occurrence is usually during the first week of ICU stay. Secondary endogenous infections is after 1 week of ICU, and exogenous infection is anytime during the patient's stay in the hospital. So coming to the designing of the ICU, appropriate designing of the ICUs lay the foundation for good infection control practices. So it includes the following requirements. You can classify it into three parts: engineering, environmental, and provision of isolation rooms. So ideal design for setting up an ICU for unit of 6 to 12 beds is as follows. So it has to be at least 100 square feet. There should be additional space for ICU storage, nursing station, and doctor's room. Oxygen and vacuum outlets, there should be two per bed, and a compressed air outlet, it should be one per bed. Then environmental requirements, requirement for appropriate heating, ventilation, and air conditioning should be met. Minimal of 6 total air changes per room per hour, with 2 air changes per hour composed of outside air. So that should be the amount of air changes that should be there. And provision of isolation rooms. So you have negative pressure isolation room and positive pressure isolation room. So negative pressure isolation room is recommended for patients suspected to be infected with organisms which spread via airborne or droplet infections. So the direction of flow is from outside to inside. So these rooms have greater exhaust and supply more than 12 air exchanges per hour with a negative pressure of more less or of greater than or equal to minus 2.5 pascals. All right. Positive pressure isolation rooms are recommended for patients with highest risk of infection, that are neutropenic and post-transplant. So the direction of flow is from inside to outside. So these rooms have greater exhaust and supply more than 12 air exchanges per hour with a negative pressure of more than or equal to plus 2.5 pascals. Here the HEPA filter is a must. So HEPA filter is a nothing but high efficiency particulate filter. All right. So the recent updates that have come in the last 2 years, that is 2024 and 25. So with regard to the ICU room types, single rooms are preferred. It helps to reduce hospital-acquired infections. And these kind of single rooms should be in a format where it can be convertible for isolation rooms. Then air handling, that is heating, ventilation, and air conditioning. ICU patient rooms typically should have 6 total air changes per hour with 2 outside air changes per hour. The ICU room temperature should be between 21 to 24 degrees and the humidity should be 30 to 60% relative humidity. So infection control risk assessment, use facility level infection control risk assessment to decide airborne or isolation capacity designed for aerosol generating procedures. So water management, dedicated hand hygiene sinks, anti-splash placement, plumbing supports, Legionella monitoring, and water safety plan is required. And surface and materials, non-porous, seamless, easy to clean finishes, and should be avoided dust collecting ledges. So coming to the standard precautions, it should be followed for the care of all patients, even when the presence of infectious agents is not apparent or minimal. So the paramount of these is hand hygiene. So it is the single most measure to reduce transmission of microorganisms from one person to another. So refers to hand washing with soap or water or use of alcohol-based disinfection. So soap and water need to be done in cases with Clostridium difficile infection or norovirus infections. So the 5 moments of hand hygiene must be remembered from an exam perspective. Before touching a patient, before clean or aseptic procedures, after body fluid exposure or risk, after touching the patient, after touching patient surroundings. So these are the 5 moments of hand hygiene. So the agents that can be used. So from all the reference I got, I have just compiled it so that it's helpful for last minute revision. So you have chlorhexidine in that you have 70% ethanol or isopropyl alcohol with chlorhexidine. So the chlorhexidine percentage that is usually preferred is 2%, though 0.5 is also acceptable. So the main key ICU indications are for line insertion, surgical prep, or device site care. Then you have aqueous chlorhexidine gluconate solutions. So that comes in a concentration of 2 to 4% and it's mainly used as surgical hand scrub. Then you have povidone iodine, and you have two compositions of that. That is povidone iodine in alcohol and povidone iodine in aqueous form. Povidone alcohol in alcohol, povidone iodine in alcohol comes in a concentration between 5 to 10%, and it is indicated as a surgical site preparation when chlorhexidine is contraindicated. When chlorhexidine and alcoholic variant of povidone iodine is contraindicated, then you can go with povidone iodine in aqueous state. That is comes as 7.5 to 10%. So it can be used for skin preparation, wounds, and mucosa when used when both alcohol-based povidone iodine and chlorhexidine gluconate is contraindicated. So these are the 4 solutions that are commonly used. So you have chlorhexidine and alcohol and aqueous solution. If chlorhexidine is contraindicated, you can go with alcohol-based povidone iodine solution. If both chlorhexidine and alcohol-based povidone iodine is contraindicated, then you can go ahead with aqueous-based povidone iodine solution. Next is personal protective equipment, such PPE. So that is use of gloves should be worn in situations where exposure to blood and body secretions is possible. Also important part of contact isolation because it helps in reducing the likelihood of colonization with organisms from a patient who is colonized or infected with pathogenic organisms. Then masks. It must be used in settings where patients with respiratory secretions are there and patients undergoing sterile procedures. So gown, eye contact, and face shield should be used if the risk of contact or splash with blood or body fluids is anticipated. So coming to sharp safety, sharps and needles with safety device should be used. Used needles should not be recapped, bent, or used in any way. It has to be discarded in a leak-proof and puncture-proof container. Overfilling should be avoided. Once 2/3 of it are filled, they should be immediately discarded. So then coming to cleaning of the ICUs, ICUs should be cleaned thoroughly once a week by scrubbing with soap and water and daily with EPA registered detergents like ethyl isopropyl alcohol, quaternary ammonium germicide detergents like benzalkonium chloride and sodium hypochlorite. Please remember these 3 chemical agents which are used for disinfection of the ICU. So the recent recommendations that came from CDC in regard to hand hygiene was what I had discussed. Clean with soap and water or alcohol-based scrub. Then PP use based on exposure risk. Injection and safety, medication safety. This is something that is new. Nowadays, the newer ICUs that are being developed are having a designated uh, area for handling drugs, that is loading drug infusions. Then minimizing exposure, early screening and management of potential infectious patients, sharp safety and handle equipments, what we had discussed, cleaning and disinfection, routine environment and equipment hygiene. Then safe injection practices. So sterile in technique for injections, single-use vials whenever possible. Waste and lineal handling, dispose of infectious waste, manage livenants to avoid spread, and patient placement. Cohorting or private rooms has risk details. Apply transmission-based precautions whenever needed. So coming to the isolation precautions. So the three important precautions scenarios are contact precautions, droplet precautions, and airborne precautions. So for contact precautions, direct or indirect contact via hand services or equipments. So keeping them in a single room if possible, gloves and gown on entry, dedicated or disinfect equipments, and daily environmental cleaning. So this is mainly done for MRSA, VRE, ESBL, CRE, Candida auris, large draining wounds or uncontrolled diarrhea. So combined with spore contact plus whenever C. diff infection is there. That meaning to say you will have to go with hand hygiene practices very stringently, like washing with soap and water. Droplet infection, the rationale for it is the large respiratory droplets to the mucous membranes within a short range can spread. So here the key actions in ICU is mask on entry. So surgical mask itself is acceptable unless performing procedures. Then eye protection if splash risk is there, limit transport. So make sure if the patient needs to be transported, the patient wears a mask. So this is for influenza, respiratory syncytial virus, Neisseria meningitis, pertussis, Haemophilus, Mycoplasma, Group A streptococcus, rubella, adenovirus, parvovirus, and mumps. So here if you can see, other than Neisseria, pertussis, and Haemophilus, Mycoplasma, most of them are all viruses. Then airborne precautions. Small particles remain suspended and travel via air currents. So the patient needs to be placed in a airborne infection isolation room. N95 respirator is needed on entry with the doors closed, and transport limitation is needed. If at all they need to go, patient needs to wear a mask. And you need to use closed suction and minimize aerosol generating procedures like suction, open suctioning. So this is mainly in cases of pulmonary TB, measles, varicella, COVID-19, disseminated zoster. So coming to surveillance of monitoring of infections in the ICU. So surveillance is defined as a continuous systematic collection, analysis, interpretation, and dissemination of data. So about the occurrence of healthcare associated infections in a specific defined population. So the most important component of an effective infection control program is surveillance of monitoring of infections in the ICU. So the various infections that are monitored in the ICU are CORTI, CRBSA, VAP, and surgical site infections. So we have CORTI rate, VAP rate, CRBSA, CLABSI rate, and surgical site infection rate. So the first three we had discussed under quality indicators. This one is for added information. So SSI rate is the number of SSIs after a given procedure divided by the total number of procedures performed into 100. So next is the bundle care. So you have the CLABSI bundle. So the key elements are hand hygiene. Then you have maximal sterile barrier, that is cap, mask, gown, gloves, drape, skin antisepsis with more than 5% chlorhexidine gluconate in alcohol. Optimal site is to go with subclavian more than IJV, more than femoral, and daily review of the catheter site and prompt removal. Then you have CORTI bundle, that is insert only for valid indication. Then aseptic insertion by trained staff, closed drainage system, drainage bag above the flow and below the level of the bladder, daily review and nurse-driven removal protocols, and do not treat asymptomatic bacteria. Then you have VAP or ventilator associated event bundles, that is head end of elevation 30 to 45 degrees, daily SAT SBT trial, SBTs, avoid circuit changes unless soiled, subglottic secretion drainage ETTs, early mobility and early enteral nutrition, oral care with toothbrushing, avoid routine chlorhexidine mouthwash. So the 2024 meta-analysis showed that toothbrushing is safe and helpful. Routine oral chlorhexidine in general ICU is not recommended because it has a neutral or harm signal. Then surgical site bundle, appropriate antimicrobial prophylaxis, age and dose timing, stop within 24 hours, skin prep with alcohol-based antibiotic, then maintain normothermia, perioperative glycemic control, and avoid shaving, clip if needed. So these are the surgical site infection bundles. Then coming to the other important aspect, it is about surveillance cultures. So surveillance cultures is defined as microbiological sampling from patients without signs of active infection at predetermined intervals, usually weekly, to detect colonization by multi-drug resistant organisms. So that is what surveillance cultures mean. So the purpose is to identify carriers early, guide empirical therapy, and strengthen infection control. So the rationale is ICU patients are at high antibiotic pressure, have high antibiotic pressure, they have invasive devices, and usually associated with prolonged stay. All these are really significant risk factors for increased multi-drug resistant organism colonization and infection risk. So colonization usually precedes infection. So the data helps in targeting empirical antibiotics, avoiding overuse, isolation or cohorting policies, and outbreak control. Example, MRSA or CRE. So the common sites and organisms. So usually from the nasal swab, organisms sought are MRSA. So the usefulness is to predict MRSA infection and guide decolonization, usually with mupirocin or chlorhexidine. Then for rectal and perianal swab, it's used to assess VREs, CREs, or ESBLs. So the GI reservoir usually predicts bloodstream and urinary infections. Endotracheal aspirate is for assessment of MDR gram negatives. It has a high predictive value for possibility of VAP. Urine for MDR Enterobacteriaceae and Candida. It has a low yield, but it is useful for assessment in long-term catheterized patients. So wound or drain sites for any MDR organism, it is very, very important in the background of burns, transplant, or surgical ICUs. So the approach in ICU, baseline admission screen in high-risk ICUs like burns, transplant, or hematology, weekly surveillance cultures like rectal, nasal, and tracheal, trigger-based screening only during outbreaks or if the prevalence is more than 10 to 15%. Then integration with stewardship. Narrow empiric antibiotics if colonization is absent. Escalate empirical therapy if colonization with high-risk MDR is present. So the utility, the predictive value, the concordance between colonization and infection is moderate to high, better for gram negatives than gram positives. So infection control, it allows preemptive isolation and cohorting to prevent cross transmission. Then stewardship, it provides colonization antibiogram guiding empirical therapy and epidemiology. It tracks MDRO prevalence, helps in outbreak investigation. So the limitations of surveillance culture is usually colonization is not equal to infections. So it may lead to overtreatment. It is costly and labor intensive, and it has limited utility in low prevalence setting. So there's another problem. There is a lot of guideline variability with regard to surveillance cultures. So the IDSA key recommendation was no universal surveillance. Use targeted screening in outbreak or high MDRO burden ICUs. With regard to ESM, ECMID 2022, no routine screening for CRE, VRE, or MRSA can be done in high risk units. And with regard to CEDC in 2023, it is risk-based, not universal. You need to integrate it with infection control strategies. So these are the current recommendations in relation to surveillance cultures. So practical ICU use cases where it is useful is in high endemicity ICUs like Asia, Southern Europe, and India. Outbreak settings, especially if outbreaks of MRSA, VRE, or CRE is there, immunocompromised or transplant ICUs. Where surveillance cultures are not useful or in low prevalence settings, less than 5%, or as a standalone diagnostic tool. So the evidence from trials, so selective digestive decontamination based on surveillance cultures decreased mortality in ICU infections but raised concerns of resistance. So the recent systematic reviews had a mixed benefit. The best use for surveillance cultures was in the high prevalence settings. So that is what you need to keep in mind. So surveillance cultures are most valuable in high risk or high prevalence ICUs as part of integrated infection control and stewardship programs, but routine use in all ICUs is not recommended. So other clinical infection control issues, so special considerations in immunocompromised patients. So protective environmental room, so you need to use positive pressure single room with HEPA filtration. Do not, so with more than 12 air exchanges per hour. So this is what we had already discussed. So you need to monitor the pressure daily. So with regard to room contents and cleaning, important no flowers or potted plants in the protective environmental room, daily wet dusting, then HEPA equipped vacuums, and you need to avoid carpeting or upholsters furniture because the risk of dust, all that can have microorganisms which can be harmful to the patient. With regard to water safety, maintain a healthcare water management program, monitor temperature and disinfection, and respond to Legionella detections. With regard to diet and food safety, use safe food handling education. Routine neutropenic diets do not reduce infections. Reserve restrictive diets for specific indications for local policy. So these are the few things you need to keep in mind when you are managing immunocompromised patients. So the most important of them all is one, no flowers or potted plants. Healthcare water management program should be well implemented, and food handling should be very, very meticulously done. Then other clinical infection control issues is patients bathing with chlorhexidine in 2% impregnated wipes reduce the rate of hospital-acquired infections and the risk of colonization of the drug-resistant organisms. And single patient rooms are ideally preferred because it helps in separating infected patients from non-infected patients to prevent transmission. So then coming to the last part of the infection control, which is one among the most important, is antimicrobial stewardship. So antimicrobial stewardship refers to a systematic assessment of coordinated interventions that is designed to promote optimal use of antimicrobials by advocating selection of appropriate antimicrobial drug regimens. So adverse events of antimicrobial use is almost seen in 1/3 of patients. So it leads to emergence of antimicrobial resistance. So administration of an antibiotic course to a patient exposes approximately 10 to the power 12 bacteria in that patient to selective pressure, which may alter the intestinal microbiota for as long as a year, plus decrease the number of antibiotics available. It increases the risk of C. diff infection or colonization. So usually C. diff infection is considered as a surrogate of antimicrobial misuse, and it can lead to drug toxicity. So the goals of antimicrobial stewardship is to decrease antimicrobial resistance, decrease healthcare costs, and improve patient safety, patient outcomes, and patient safety. So these are the main goals of antimicrobial stewardship. So when all these are adequately implemented, it helps to reduce the length of hospital stay, reduce mortality, and reduce the need for mechanical ventilation. All these were possible when antibiotics were used appropriately. And also, there was a decrease in, when there is decreased antibiotic use, there is a decrease in C. diff colonization, and there is no increased mortality and no readmissions to the ICU. So antimicrobial stewardship program for ICU setting has two parts. One is optimization of the antimicrobial therapy, and the second one is avoidance of unnecessary antibiotic administration. So coming to the first part, optimization of antimicrobial therapy. Step 1, making a diagnosis. First, see if it is an infection. Then rule out non-infectious mimics, rule out colonization or contaminants. Take appropriate specimen cultures to be able to make a eventual diagnosis and determine whether to start an antibiotic empirically or, if possible, wait till definitive diagnosis is made. So this is about the first part of it. Second, empirical antimicrobial therapy. The important considerations are the severity of illness. If the severity of illness is very high, then you go with broad spectrum antibiotic coverage. Likely pathogens and their anatomical source, with consideration of source control based on rapid diagnostic testing and gram stain as appropriate. The likelihood of drug resistance, like known colonization by resistant pathogens, recent antimicrobial use, exposure to healthcare facilities, and local resistance patterns. Then host factors, whether they're immunocompromised, needing wide spectrum of coverage, renal or liver dysfunction, where there can be increased risk of toxicities and allergies, which will preclude a list of a certain particular class of antimicrobial agents. Then determining the appropriate dose and the route. Intravenous route is the standard in all critical ill patients in the initial phase of the disease. Then initiating antimicrobial therapy as early as possible and as promptly as possible. That is one among the most important determinants of outcome. And adequate dosing and PKPD considerations. So maximize tolerable dose and use of prolonged infusions whenever possible. Identify the presence of augmented renal clearance and identify increased volume of distribution like hypoalbuminemia, large volume crystalloid administration. So all these are the important considerations you need to keep in mind when you consider empirical antimicrobial therapy. Then tailoring antimicrobial therapy, that is the antimicrobial timeout. So in patients receiving empirical therapy, the regimen should be re-evaluated on a continuous basis as the clinical condition evolves and the microbial results and when the microbial results become available, usually within 2 to 3 days. So this is called the antimicrobial timeout. So at this time, the microbiological results are reviewed and the antimicrobial therapy is adjusted from an empirical to a definitive antimicrobial therapy. Then fourth step is therapeutic drug monitoring. Now it is currently confined to vancomycin, aminoglycosides, and voriconazole. So its use has been associated with the reduced nephrotoxicity, reduced length of stay, and reduced mortality. Then coming to the second part of the stewardship program, avoidance of unnecessary antibiotic administration. So this concept is mainly about antimicrobial de-escalation. So it is a clinical approach to empirical antimicrobial therapy of serious infections that attempts to balance the need for an appropriate initial therapy with the need to limit unnecessary antimicrobial exposure to curtail the emergence of resistance. So avoidance of unnecessary antibiotic administration, it can be done by use of antimicrobial resistance prediction tools based on risk factors. Biomarker guidance of antimicrobial therapy with use of CRP or procalcitonin helps in guiding decisions regarding antimicrobial therapy. Use of rapid microbiologic diagnostics. So use of molecular platforms currently exist for rapid identification of pathogens and antibiotic susceptibility. So it includes MALDI-TOF, then multiplex PCRs and immunochromatography. So it aids in faster diagnosis and de-escalating of antibiotics within 24 hours itself. So this is in comparison to conventional microbiological procedures. Then you have a stewardship team. So you have a physician leader with ID training, should report activities and outcomes regularly to senior executives and hospital board. Correlate with the pharmacist leader with ID training, then clinicians and head of departments, hospital epidemiologists who monitor, audit, analyze, and report facility-wide data, quality management staff to investigate medical quality and patient safety issues, then microbiology lab, antimyograms to provide empirical therapy is the main role, then IT staff to integrate stewardship protocols to the existing workflow, and nurses to ensure cultures are taken before starting antibiotics. So, like quality indicators, matrices, metrics for stewardship program also, we have various indices. So measuring antibiotic use may be estimated by the days of therapy. So the formula is the aggregated sum of days for which any amount of a specific antibiotic is given to a particular patient by a standardized denominator, usually 7 to 14 days. Then we have something called the daily defined dose. That is the aggregate total number of grams of antibiotic administered during a period of time divided by the standardized defined daily dose regimen designated by WHO. So these are the two indices that can be used to assess the antibiotic usage. Then you have process measures. So excessive days of therapy, that is unnecessary days of therapy based on acceptable targets and benchmarks, duration of treatment, proportion of facilities compliant with facility-based guideline and treatment algorithms. Especially this is very, very important in ward-based management, because many a times patients in the ward are given empirical antibiotics which may not be compliant with the hospital antibiogram. Then proportion of patients with revision of antibiotics based on microbiological data and proportion of patients converted to oral therapy. So all these can be assessed and audited. Then outcome measures. Hospital length of stay, 30-day mortality, unplanned hospital admission within 30 days, proportion of patients diagnosed with C. difficile infection attributed to antibiotic treatment, and proportion of patients with clinical failure, that is need to broaden treatment or recurrence of infection. So these are the outcome measures. So here you have 5 process measures and 5 outcome measures and 2 measures to assess antimicrobial usage. So just an overview revision of antimicrobial stewardship. So suspected infection in ICU patients, you obtain microbiological sample for culture and special stains, biomarker assessment like CRP or procalcitonin, and rapid diagnostic testing like PCR or MALDI-TOF or immunochromatography. Then prescribe empirical antibiotics, employing a combination of an agent targeting like MD or O based on local epidemiology and patient risk factors. Then monitor the clinical response to treatment. Then microbial identification of pathogens and antimicrobial susceptibility, that this need to be done at 48 to 72 hours, which is the antimicrobial timeout. If there is identification of a microbial agent and if there is significant improvement after 48 to 96 hours of treatment, and you can classify it as if there is no microbial identification with significant improvement after 48 to 96 hours of treatment. So if there is no microbiological identification and there is significant treatment after 2 to 4 days of treatment, then you consider discontinuing the antibiotic or limiting the course of therapy to 7 days or within 7 days. Whereas if you have a significant improvement after 2 to 4 days of treatment and microbiological identification of a pathogen is present, then you de-escalate empirical antimicrobials based on the microbiology result and discontinue antibiotics after 7 to 10 days based on the site of infection and the pathogen present. Whereas if there is no clinical improvement in either of the situation, then review dosing of antibiotics to optimize drug levels, reculture for possible superinfections, consider non-infectious cause of fever and inflammation, and examine for abscess formation. So this is the generalized approach of going about infections in the ICU patients. So this is my last talk for this crash course. So all the best to all of you. Definitely, I'm sure that all of you would pass. Just be confident and give your hard work as much as possible. Thank you.
Thank you, Shriyari.
Thanks, Sachin.
I hope I'll start my session again. I hope it doesn't crash. That's it. I don't know. It's jinxed, I guess, this time. Each time I start 2 talks and then it goes off. Okay, continuing with further topics in sepsis, I will try and do as much as possible till 10 o'clock. The two talks that is on end of life care and breaking bad news, I've already recorded it. It will be available at the earliest so that we don't waste time on that because we lost time because of a technical glitch. That is already recorded and it is available very soon, probably tomorrow or day after it will be given to you. So continuing with sepsis, I'll be continuing till 10 o'clock in the night. I'll see if I can squeeze in two more topics. Okay. So is my slide visible?
Yes, sir.
Yeah, okay, great.
Not
So
yet, sir. Sorry, not yet. Visible.
not yet visible, is it? Okay.
So please share your screen.
Sure. Is it visible now?
Yes. Yes.
Okay, good. Okay, thank you. So coming to the topic on new onset fever in ICU, this is one of the commonest questions that they ask you in the ICU. If they ask this, I think so you should feel very happy. Okay, you can write most of it. The only thing that they are looking at is how structured you are while writing this particular answer. Coming to definitions, fever, we all know core body temperature of usually more than or equal to 3.8 degrees Celsius as defined by the IDSA or the Society of Critical Care Medicine is defined as fever. Okay, usually up to 50% of fever in the ICU are non-infectious. Okay, that is again by O'Grady et al., which was given way back in 2008. Probably this ratio would have changed the current scenario. But remember, majority of the cases still can be non-infective. Okay, the most important thing as an intensivist for us in an ICU is to differentiate whether the fever is infective or not first, and also to diagnose fever versus hypothermia. Okay, like I was discussing earlier yesterday. So usually we all know the normal body temperature is between 37.4 degrees Celsius, and definitions of fever, as mentioned earlier, 38 degrees and above, or oral, that is your core body temperature, or oral single temperature being more than 101 degree Fahrenheit or 38.3 degrees Celsius. Sorry, there's an error there in neutropenic patients. Okay. Fever in ICU is usually considered to be significant if the temperature is more than 101 degree Fahrenheit or 38.3 degree Celsius. So when we talk to you about neutropenic sepsis later on, we will be telling you what are the nitty-gritties associated with this. Okay. Dry and large, the classification of new onset fever, you can make it into two broad headings. Okay, the ones which are infectious, the other which is non-infectious. Infectious causes, okay, it can be ventilator associated pneumonia, CRBSI, COT, C. diff, surgical site infections, bed sores, sinusitis, okay, occult site of infection like prostatitis, okay, meningitis, suppurative thrombophlebitis, and so on. Non-infectious, the causes can range from drug fever, transfusion reactions, thyroid storm, adrenal crisis, acalculous cholecystitis, DVT, neuromalagnant syndrome, serotonin syndrome, and thrombotic microangiopathies. So you need to remember the list, at least remember 5 from each group so that you can give this as an example when you're categorizing the approach to new onset fever in ICU. Most importantly, how do you approach? So first you have categorized, you're looking at infectious versus non-infectious. For all of this to come to the diagnosis and to categorize them into infectious and non-infectious, we need to do a clinical examination. So how does it start? Usually the head-to-toe examination has to be done. Firstly, we look at the vital signs, assess what is the current scenario with the hemodynamic status, and then we do head-to-toe examination. Okay. Two things have to be looked at. One is patient related due to organ dysfunctions, and the other one is physician related. Okay, whenever we are talking about physician related, it might be one of our instruments like ventilators, lines and catheters, tubes, etc. Okay, so these are the ones that we need to look. When we are talking patient related per se, it is the primary disease process. It can be infections like cellulitis, abscesses, pneumonia, peritonitis, meningitis, ventriculitis, so on and so forth. When you have ruled out both the aspects, always consider looking at the patient's treatment chart. Rule out a drug fever, a rash caused by a drug, thrombophlebitis because of an old line, presence or absence of DVT because of immobilization, transfusion reactions. So if you go through the treatment charts and then you can correlate that particular timeline, you will be able to narrow down the possibility of infectious versus non-infectious cause of fever in ICU. What is the role of POCUS in new onset fever in ICU? So you have a lot of differential diagnosis at hand. You have done your clinical examination. How can you come to a definitive diagnosis? So that will be usually based on you using your adjunctive tools. So what are the adjunctive tools that you have? One is your POCUS. It has become our friend, like the STETH has been already replaced by POCUS, right? So what do we do? The best advantage of POCUS is it's a rapid bedside tool, which is non-invasive. It can help in repeated examination, and majorly it avoids transporting the patient, especially when they are very unstable. Lung ultrasound, you can rule out pneumonia, VAP, especially presence of effusion and empyema. Okay, so the sensitivity we all know is much better than a chest X-ray. Cardiac examination, even though transesophageal echo is superior to detect vegetations for endocarditis, you can always use this as a screening tool. That is your transthoracic echo. Rule out tamponade, pericardial effusion. Okay, all of this. Along with this, you can also do your ultrasound of the abdomen and pelvis to rule out plausibility of pyelonephritis, liver abscess, cholecystitis. Okay, so all of this will help you narrow down towards a possibility of one infection. So if you see, I've started from head to toe. I've covered lung, cardia, abdomen. Then I'm going at vascular lesions. Okay, so vascular lesions, the first and foremost thing that we need to rule out is a non-infective cause of fever, that is your deep venous thrombosis. Okay, so do your compression ultrasound. Four-point ultrasound is what we are usually supposed to do. Okay, then you can also ask in for an official DVT scan from the radiologist. After having done all of that, look at your lines and devices. If at all this patient has a recent device insertion, look at that site, whether there is some sort of skin excoriation, erythema, etc., or any pus discharge. If you put a CVC, ICD, etc., look whether there are leakages around it. Okay, they can be the harbinger for infection at that particular site. Okay, all of this have to be evaluated as a possibility for new onset sepsis in the ICU. The only limitation for POCUS is in places where their infections are obscure or they are hiding. Okay, usually places like prostate, it's really difficult to pick up on, especially for non-trainers like us. Okay, and the other big issue is neuroinfections. So these two is one of the drawbacks for POCUS. Okay, and then again, there's a lot of inter-observer variability when we are using POCUS as well. So if you have good training and if you have seen it quite often, the probability of picking up changes would be higher. So this is the role of POCUS in new onset fever. Okay, coming to investigations, routinely, if there is any new onset fever, just rule out whether it is infective and non-infective. And when you are not able to find out, probably might have to start with your complete hemogram. You have to repeat your cultures. Okay, check, get an X-ray, look at what is the requirement of FiO2. Okay, whether the saturation has changed, all of this. Okay, because as of now, even in new onset fever, IDSA suggests that before you change the antibiotics or start any new antibiotic, always obtain a culture and then go ahead and change the antibiotics. Okay, so like the previous speaker, they were talking to you about cultures, right? Especially in CLABSI, COTI, etc. Whenever you're thinking of line-related sepsis, probably send the culture tip as it was mentioned earlier, but you should always be worried. Was the most important thing is whether it is a colonizer or a pathogen. So you have to analyze it very appropriately, look for differential time to positivity, so on and so forth. Okay, if at all you have found out a site of sepsis, okay, the first thing that we need to do is treatment directed towards source control. Okay, whether it is abdomen, CNS, or skin and soft tissue. Your other tools, whenever it is present, there'll be just an adjunctive tools like your procalcitonin, CRP, or neutrophil lymphocyte ratio. None of them have been proven to be gold standard for the diagnosis of sepsis, okay, or infective cause as compared to other. But on the other thing, they can tell you alternate causes. Okay, so for example, if chlorcalcitonin is low, probably if you have ruled out all the other possibilities, One, you can think of a non-infective cause. Two, you can think about a fungal infection. So these are the pointers which procalcitonin will give you, but never escalate antibiotics just based on procalcitonin. Remember, procalcitonin, as of now, the role is only for de-escalation. Coming to pneumonic, to remember, the infection sources in the ICU. You can remember from head to toe, that is more than enough. But remember just the 5 WINDs with ICU specific causes. Okay, wind, water, 5 Ws with ICU specific causes. Wind, that is pneumonia. VAP, that is your lung related. UTI, okay, whether it is pyelonephritis new onset or catheter associated urinary tract infection, surgical site sepsis. Okay, usually they will be very notorious, especially in your neurosurgical patients, wherein they would have put an EVD and come out. The EVD drain tract site itself would have developed into a new onset sepsis. So you have to think about neurosurgical meningitis, so on and so forth. Okay, so look for other causes. Okay, especially sites which are not routinely thought about. Example, a long-standing nasogastric tube would cause the patient to develop sinusitis. Antibiotic therapy itself would have caused the patient to develop C. diff colitis. New onset devices like probably a pacemaker incision. All of this should give us an doubt that these might be the probable source of new onset sepsis or new onset fever in the ICU. What are the management strategies? Primarily start with supportive treatment unless you get the diagnosis. Antipyretics, okay, is the pillar of treatment along with source control. Source control is the key, like in any case of sepsis, if it is there. Okay, so if at all it's an abscess, etc., it has to be drained at the earliest. Empirical antibiotic therapy, as I told you earlier, is not routinely indicated. Only if you find that the patient is having hemodynamic instability, there is requirement of increased FiO2, etc. Only after you have ruled out all the alternate causes, and if the patient is immunocompromised, then you can start an antibiotic based on the local antibiogram, especially considering the risk of multi-drug resistant organisms. So earlier on, when we were talking about antimicrobial stewardship, we were talking to about how to go about escalation, right? So this is what we need to think about. Okay, so if you have a good local antibiogram, you know this patient is in the ICU for a couple of days, you will know what might be the causative organism. So based on that, you can choose your antibiotic. But routinely, otherwise, there is no need to start it. But if you have to start it, it's only because of hemodynamic instability, etc., trace these cultures as early as possible. Okay, reassess the patient within a period of 48 hours to 72 hours, and once you get the cultures, you have to de-escalate. This carries a strong evidence from the SSD guidelines of 2021. After having said the septic causes or the infectious causes, we have to delve into the non-infectious causes. We need to treat them appropriately, especially with anticoagulation strategies for DVT. If it is drug fever, remove the inciting culprit. Okay, and patients with transfusion reactions, etc., it's all short-lived, so they would get corrected on its own. Okay, so just have to give it some time. Treatment, especially when it is related to endocrine issues, we need to sort out what is causing the endocrine issue. Probably it's a drug interaction. So drug interactions have to be checked. If drug interactions are the one which is causing, that have to be addressed. So once you have done all of this, you have to do a reassessment, especially after a 48 to 72 hour period, just to see what is the clinical response to your approach of management. If things are becoming better, then you have identified the source and treated it appropriately. If not, you might have to rethink your strategy and look again towards all causes. Okay, so it is not mandatory that you need to wait for 48 hours for the clinical response. If at all you started treatment and you do not see any response and the patient starts deteriorating, probably you might have misdiagnosed this patient and you have to look in very closely. Okay, so in summary, in a new onset fever in an ICU, you should have a structured evaluation. Primarily stabilize the patient. Okay, so if a patient is spiking fever, treat the fever. Okay, that is a symptomatic treatment. After giving the symptomatic treatment, do a bedside assessment. First your clinical examination, then your focused examination head to toe. Use your adjunctive tools like your POCUS. If you feel that there is a septic probability more than the non-septic probability, probably send in cultures, then start antibiotic based on your AMSP principles, and then get imaging. If you find that things are not appropriate and you're not able to localize, if at all you can, and is feasible, get other imaging like a CT scan or MRI if at all it is required to rule out other infections, especially your CNS infections and deep-seated infections. Okay, so once you have done this, follow the antibiotic stewardship principles, and if at all you have localized a source control should be the primary treatment option. Okay, so this is in general about how to approach a case of new onset fever in the ICU. Okay, thank you. So that this is very straightforward. Anyone can answer this. Okay, the only thing is how you approach it is what matters. Okay, so if you write a systematic approach, you will be able to fill in the blanks. Okay, because you will know this in general. Okay. Coming to the next topic, that is antimicrobial resistance. Okay, so this might be one of the last topics that I'll be covering today. Okay, the rest of the things I will be giving a class tomorrow. Okay, if possible, I'll update it on the group. Coming to antimicrobial resistance, so this is one thing that most of us are worried about, and questions can be asked. Okay, last year there was one question on persister cells, if I'm not wrong. Okay, so if you've understood your antimicrobial resistance, then you'll be able to answer it. And to understand antimicrobial resistance, firstly you need to understand how do antibiotics act on a bacterial cell. Okay, so we know gram positive, gram negative, etc., and there's a lot of drugs which are already available in the last 60 to 70 years. Okay, and once they were once penicillin was invented or discovered, after that very soon itself resistance also came into existence. So we need to know even resistance is very old. Okay, so to understand that, primarily let's start understanding what are the mechanism of action of each drug. So we know there are cell wall inhibitors like penicillins, vancomycin, cefamycin, cephalosporins, mRNA synthesis inhibitors like rifampicin, metabolic pathway inhibitors like your trimethoprim sulfamethoxazole or your Septran, your protein synthesis inhibitors, especially which act on the ribosomes. The 30S subunit acted upon by aminoglycosides and tetracycline, that is at 30. And the other 50S subunits, it's acted upon by lincosamines, chloramphenicol, and macrolides. The cell membrane inhibitors are colistin, polymyxins, and daptomycin. Okay, DNA topoisomerase inhibitors, again, you have your quinolones, your DNA gyrase 4 or topoisomerase 4. Okay, the other one is DNA inhibitors, is again metronidazole. So whenever we're talking about resistance, please try and remember the classification of antibiotics and mechanism of action of each antibiotic. Okay, remember where you can use cell membrane inhibitors, remember where you can not use cell membrane inhibitors. Okay, the basic thing is gram negative versus gram positive. Okay, so remember polymyxin, there's no role for gram positives. Okay, so coming to how bacteria can resist antibiotics. So that is the whole understanding for antimicrobial resistance. So majorly there are two pathways. Okay, one, it is to stop the antibiotic from reaching its target in the bacteria at enough concentration to kill the bacteria. Secondly, it can modify or bypass the targets that the antibiotic intends to act on. Okay, so these are the two major ways that the bacteria can dodge getting killed. Okay, so one, stop the antibiotic from reaching its target. Secondly, it will modify or bypass the target. Okay, so these are the two major ways how bacterial resistance can happen. Okay, this is the simplest way to understand it, but how does it do it is what we will be looking into. Okay, so when do we call an organism as a resistant strain? A bacterial isolate is considered to be non-susceptible or resistant or intermediate to one of the agents based on clinical breakpoints. Okay, so clinical breakpoint is a test which will help us understand which particular concentration of the antibiotic has had a area of clearance on the disk. Okay, so this is a microbiological terminology, that is your clinical breakpoint, and it will usually be given to us by two major societies. Okay, what we all follow is the UCAST or the CLSI guidelines. So based on this clinical breakpoint, we can categorize an organism's susceptibility as susceptible, intermediate, or resistant. Okay, and based on this itself, we will also get the minimum inhibitory concentration. Okay, so remember, clinical breakpoint is based on an antibiotic's effect to kill the organism in vivo. Okay. So based on this, all of this data, what we get is from two major societies, that is your CLSI and the UCAST. Okay. So based on resistance, we can broadly categorize bacteria into multi-drug resistant, extremely drug resistant, pan-drug resistant. Okay. So when do we call the bacteria as MDR? Whenever a bacteria is resistant to three or more antimicrobial classes, it gets categorized as MDR. Okay. We call it as XDR bacteria when the bacterial isolate remains susceptible to only one or two categories. Okay. So when we talk about MDR, you should have three or more antibiotic classes which are resistant. In XDR, it is susceptible to one or less. Okay. So this is about MDR and XDR, and PDR is very straightforward. We do not have any agents which has tested to be susceptible to that particular organism. So this is by and large about MDR, XDR, and PDR. So coming to types of resistance, majorly you can remember it as natural resistance or acquired resistance. Natural resistance is innate resistance or mediated or induced type of a resistance. And acquired resistance is by one of these mechanisms, either by translation, conjugation, transposition, or mutation of chromosomal DNA. Okay, there are other mechanisms which can be acquired as well, but these are few that you can remember. It's natural or acquired. Natural, you have innate and mediated or induced. In acquired, you have translation, conjugation, transposition, and mutation of chromosomal DNA. So how does it happen? Okay, so initially I told you either it will prevent or it will modify things, right? So how can it prevent or modify? It is by these four major ways. Okay, so how does it do? It can limit the uptake of the drug itself. It can spit out the drug, that is called as drug efflux, or it can deactivate the drug, that is your drug inactivation, or it can mutate and change the target. Okay, so that is called as drug target modification. These are the four ways in which the bacteria can develop resistance. One, remember, efflux pump, it spits out the antibiotic, just remember it like that. Okay, another one is it develops inactivating enzymes. Okay, so drug enters the bacterial cell wall, but then it will be inactivated. In simplest example, remember it as carbaphenemases. Okay, then you have target site alterations, especially for your protein synthesis or DNA synthesis. Okay, so such drugs, especially drugs like your chloramphenicol, aminoglycosides, tetracyclines, okay, and fluoroquinolones, all of this will have target site modifications. That is how they develop drug resistance. And primarily, the bacteria can have inherent activity to prevent the drug from entering the cell itself. Okay, so it causes decreased uptake. Okay, so these are the ways that you can develop antibiotic resistance: drug limitation of uptake, drug efflux, drug target site modification, and drug inactivation. So, coming to genetic basis of antimicrobial resistance, there are two ways. We have gene mutation and acquisition of foreign DNA by horizontal gene transfer. Okay, so these are the two ways in which a bacteria can develop mutations or genetic basis or antimicrobial resistance. If someone asks you this, these are the two ways that we need to understand. So, before understanding genetic basis, let us understand what are the ways that we need to classify these things. Okay, firstly we talked about natural and acquired, correct? So when we're talking about natural and acquired, we need to think about what are the natural ways also, right? Acquired probably is because of genetic mutations. Okay, so when we're talking about natural, what are the things? You have something called as phenotypic resistance, acquired resistance, and intrinsic resistomes. Okay, so coming to phenotypic resistance, as the word itself says, it is the physical type of resistance which is acquired by the bacteria, inherently present in the bacteria to avoid killing of the bacteria. So it's a self-defense mechanism which the bacteria has. So what are the phenotypic resistance which is present? It can be persister cells, biofilms, or swarming. Okay, so swarming and biofilm is accumulation of a lot of bacteria together, wherein the effective delivery of the antibiotic inside the bacterial cell wall would be reduced. Biofilm is having a thin layer of a substance around the bacteria, which prevents the drug from reaching the target site. Okay, that is again a physical way. The other way is development of persister cells. Okay, so what is persister cells? By definition, persister cells are small subpopulation of phenotypic variants of bacteria that survive the lethal antibiotic exposure without having genetic resistance. They are not mutants, but they are dormant, okay, or metabolically inactive cells, which allows them to tolerate antibiotics. Okay, so they go into something like a state of hibernation. So they wait for the storm to pass. Okay, so in true sense, here they are waiting for the antibiotic to reduce its concentration. Okay, so they just have a physical ability to withstand this antibiotic till the lethal dose of the antibiotic wears off. Okay, and once the lethal dose or the uh, therapeutic dose of the antibiotic comes down, then this bacteria can regrow and repopulate. Okay, so these are physical cells which are present in the bacterial cell wall. Okay, so these help to prevent the delivery of the drug into the bacterial cell wall. One, they put the cell into a state of hibernation. They withstand the antibiotic exposure. They do not multiply at that time, but once the antimicrobial agent or your antibiotic levels come down, they start to regrow and repopulate. Okay, so usually persister cells are phenotypic tolerance. Okay, they do not have any genetic resistance. Remember, this is not something that will be passed on from one cell to the other. Okay, it is only for that particular group of bacteria. Okay, so usually the presence of these will be very low, thankfully. Okay, and usually the only flip side of this is these bacteria have the probability of reverting back to normal, and they can also get converted into a susceptible phenotype and get killed by an antibiotic later on. Okay, so the newer modalities of treatment for bacteria with persister cells is this. It's they're looking at modification of giving a killing antibiotic and then adding on one more. Okay, so it's like a sacrificial agent. Okay, so usually you see in both in biofilms and planktonic in animals. So coming to mechanisms, firstly metabolic dormancy, like I told you earlier. Okay, usually these cells become invisible to the drugs. Okay, they just become like stones. Okay, they hibernate. So they regulate bacterial persistence by inducing growth arrest, and they you do undergo stress induced adaptation leading to slowed metabolism. Okay, they do not wear off completely, only they reduce the metabolic pathways, and they still try to uh, tide over the crisis, that is your delivery of antibiotics. What are the group of organisms? Have patients coming back with recurrent infections of the same organisms, especially patients with tuberculosis, pseudomonas, okay, staph aureus infections, etc. We need to think that this bacteria probably has a persister cell, and because of presence of persister cell, your treatment failure has occurred. Okay, so this is how we need to understand. Whenever we have patients coming back with the same group of organisms again and again, it's not the resistance because of genetic variation. Probably it is because of a phenotypic variant, and probably one of the reasons is persister cells. Okay, so this is one thing that I want you to remember. So categorizing between persister cells and resistant cells. Okay, so in persistent cells, they are non-heritable. Okay, they are phenotypic. They tolerate antibiotics temporarily, but over a period of time, they can get susceptible. They survive, but they do not replicate under drug pressure. They revert back to normal after the removal of drug. In resistant cells, they do have genetic mutation and they can get acquired. Okay, usually it can be transmitted from mother to daughter cells. Okay, they grow despite antibiotics, they replicate under drug pressure, and these are really difficult to treat organisms. Okay, so this is the major difference between persister cells and resistant cells. Coming to the genetic aspect right now. So we finished about the phenotypic aspect. Now we are going to the genetic aspect. Okay. So coming to genetic basis of antimicrobial resistance, the first thing is chromosomal gene mutations. So there are three different genes which are encoding. Okay. So one genes for the target of the antibiotic, two genes for the transporter, three genes for the regulators. Okay, so remember target, transporter, and regulators. So these are the three areas where gene mutations can change and make the bacteria develop antimicrobial resistance. So whenever the chromosome helps the bacteria develop such chromosomal mutations, it can be transferred from one bacteria to the other bacteria of the same generation. So that is called as horizontal gene transfer. Okay. So if at all a daughter cell has acquired this, it will give it to its sister cells. Okay. So this is about chromosomal gene mutations in antimicrobial resistance. So gene mutations can be intrinsic, it can be acquired, or it can be adapted. Okay. Coming to intrinsic resistance. Okay. So intrinsic, when we talked about here, we were talking about gene mutations. Intrinsic resistance is bacteria's inherent natural capacity to show resistance to a certain class of antibiotics. Okay, so it can be present from birth. So it is as simple as that. Okay, it's the genetic milieu of that particular bacteria. Okay, so we should know some antibiotics where they are inherently intrinsically resistant to this group of antimicrobial agents. Okay, so bacteria will show inevitable resistance against certain antibiotics. Efflux pumps and reduced permeability are usually the involved ways for intrinsic resistance. Okay, so what does happen if you're given this drug to this bacteria? The way it will develop intrinsic resistance is to throw the antibiotic out. It just vomits it out. Okay, so coming to natural resistance. Okay, anaerobic bacteria usually or in natural or intrinsic resistance. Okay, anaerobic bacteria are usually resistant to aminoglycosides. These are the examples. Okay, gram-positive bacteria resistant to aztreonam, gram-negative bacteria resistant to vancomycin. Okay, so like similar to that. Okay, you can have aerobic bacteria resistant to metronidazole. Okay, enterococci resistant to aminoglycosides. Okay. Remember one of it, it's more than enough. Okay, so these are the examples that we need to take forward. So if you remember aerobic to metronidazole, I think so that's very straightforward that you can take home from this slide. Okay, coming to acquired resistance. We finished intrinsics. Now we are going to acquired. Remember phenotypic, genotypic, in genotypic, intrinsic, after intrinsic, acquired. In acquired, what are we looking at? Evolutionary process of exhibiting resistance by a previously sensitive bacteria due to acquisition of a chromosomal gene mutation or gaining an exogenous new gene material from horizontal gene transfer. Okay. Three major mechanisms are involved in horizontal gene transfer. It can be either transformation, transposition, or conjugation. The most common way of acquired resistance is plasmid mediated via conjugation. Okay, it can either be temporary or it can be permanent. So if you have to give an example for acquired resistance, you can use the escape group of organisms. Okay, so this is for acquired resistance. So remember, I told you about sister cells, daughter cells, etc., horizontal gene transfer, all of this, right? So we talked about innate earlier, then that is your natural resistance. Then we are talking about acquired, and in acquired, we are telling, transfer from same generation. So whenever there is transmission of resistance from the mother to daughter, it is called as vertical transmission. Okay. So usually how is it done? It is either by bacterial DNA, cell wall, or plasmid. Okay. So this is usually vertical transmission. If this resistance is usually given to the same generation of bacteria, this is called as HGT or horizontal gene transfer. Okay, so what are the methods of horizontal gene transfer? It is by transformation, transduction, or conjugation. Okay, so if someone asks how is transfer of resistance, the answer is vertical transmission and horizontal transmission. So how does horizontal transmission happen? There are three ways. Horizontal transmission can happen by conjugation, wherein two bacteria can pair up. Okay, so here if you can see the image below, conjugation, you see two bacteria combining. Okay, that is how conjugation happens, and then there will be transmission or delivery of the resistant gene to the other bacteria. In transduction, it is usually done by bacteriophages. Okay, there are viruses which eat the bacteria, right? So that is the virus which acts on the bacteria, and then this virus in turn delivers the mutated gene, which helps the bacteria develop resistance. The last way of HGT or horizontal gene transfer is transformation, wherein some bacteria can take up pieces just in the breakdown of bacteria. If it's in the environment or in the surrounding, it just picks up that, and that itself will develop resistance. So this is the way it can happen. Okay, so vertical, horizontal. Okay, vertical is mother to daughter, horizontal is the same group or same generation, and horizontal is by three types: transformation, transduction, conjugation. Transform is just by having two bacteria. Transduction is by bacteriophage. Okay, and transformation is taking up pieces of DNA, and the last way is integrons. Okay, in integrons they have open reading frames. Okay, these are newer ways of developing bacterial resistance. Okay, of lately a lot of research, and whenever you read about newer antibiotics, they are focused on these resistant mechanisms, that is ORF, especially in the MGC, that is your mobile gene cassettes. Okay, coming to the next part of it, you talked about innate resistance, and then we talked about acquired. Now we are talking about adaptive. Okay, so after acquired, we talk about adaptive resistance. What is adaptive? Earlier we spoke about phenotypic resistance. That can also be a type of an adaptive resistance. Okay, again here in adaptive phenotype, it is a phenotype wherein it develops resistance to a group of antimicrobial class, both in sub-inhibitory concentrations as well as therapeutic concentrations. Okay, it is one of the examples for persister cells, biofilms, etc. Okay, so coming to mechanism of resistance, uh, it- which is classified based on the bacteria. So by and large, whenever we look at AMR, we look at gram-negative sepsis, gram-positive sepsis, and gram-negative sepsis. You know, it's a little difficult to treat as compared to gram-positive sepsis, but they also have the similar issues. So, what are the ways of resistance in gram-negative sepsis? It can be decreased antibiotic entry due to porin channels, increased efflux pump, alteration of target site, and degradation of enzymes in gram negative. Okay, so whatever I spoke to you earlier about all the 4 to 5 types, you can just think about it and write in gram negative. In gram positive, majorly the way of resistance is enzymatic degradation and targeting antibiotic site. Okay, so these are the ways where the resistance can develop. What is the major difference between a gram negative organism and a gram positive organism? It's the structure of the bacteria, especially the cell wall. Okay, so what you can see here is the presence of outer membrane, which is present in a gram negative cell wall, which is absent in a gram positive cell wall. On the same side, the peptidoglycan layer is very large in gram positive bacteria, and it is very small in a gram negative bacteria. Along with this, there is something called as the periplasmic space, which is present in both the bacteria, but more so the clinical implications are present in gram negative bacteria. So why does it matter? Because most of these mechanisms develop based on the type of bacteria. Okay, so modification of antibiotic molecule, it can be how is it done? It can be either chemical, that is structural changes in the molecule itself, or destruction of the antibiotic molecule, which can be catalyzed by specific bacterial enzymes. Okay, so when we are talking about enzymatic degradation, okay, so how does it happen? phosphorylation, again aminoglycosides, you can remember. Phosphotransferases are the enzymes which are involved. And example here is gram-positive bacteria, that is your Staph aureus. Again, adenylation, remember aminoglycosides again. Okay, it's just remember affected antibiotics as this, but just write the other enzymes if they tell you. Okay, remember phosphorylation is majorly seen in gram-positive bacteria. Adenylation and acetylation is seen in gram-negative bacteria. Okay, so if you remember these, it's more than enough. Just for simplicity wise, remember one antibiotic, so because in the long run you'll not be able to recall. Okay, so enzymatic degradation classification is hydrolases, transferases, or redox enzymes. Okay, so this is the broad classification, and most of the things what we're looking at, like your beta lactamases, cephalosporinases, carbapenemases, all fall under the category of hydrolases. There are still a lot of other ways of enzymatic degradation which we don't usually look into, but they're always present. Okay, so that is where all this acetylation, phosphorylation, adenylation comes into picture. Coming to beta lactamases per se, so we all have to remember this. Take it from me that this is something that you need to read and remember. Okay, if you remember majority of what I said earlier or not, it doesn't matter, but this is one question they have been asking time and again. So remember, what is beta lactamases? Beta lactamase, firstly, it is a type of a hydrolase. It causes enzymatic degradation. And how do we classify them? Use the Ambler's classification. How are they classified? Ambler's class A, B, C, and D. Ambler's class A has penicillinases. What are the other categories which are present? That is Teminara, SHV, CTXM, KPC. Okay, all of them fall under Ambler's A. The organisms, you can broadly categorize them as ESBL group of organism, or KPC for Klebsiella pneumonia, etc. Okay, and Ambler's B, remember your New Delhi metalloproteinase. Other ones you can remember is Verona intermedia and imipenemase. That is a IMP. Okay. Ambler's classly, you have your AMC organism. Remember your space group of organisms. Okay, that is your example there. And Ambler's class B, any gram-negative MDR organism you can write. Ambler's class D, again, it is oxacillinases, majorly OXA 48 and 23. If at all you have to give, you can write about MDR crab organisms. Most of the times they have OXA 48. Okay, so this is majorly about Ambler's classification. Okay, so other way to remember is whether there are serine or metallo beta lactamases. Serine beta lactamases are A, D, and C. Metallo beta lactamases is class B, that is your New Delhi metalloproteinase. What is the metal present there? It is zinc. Okay, so this is usually what they ask you. Okay, one is to write it in alphabetical order as ABCD. Other one is to tell about metalloproteinases and non-metalloproteinases, non-metallo beta lactamase. Coming to spice group of organisms of space, I told you they fall under Ambler's class C. Okay, so they produce AMC, which is inducible. Okay, so if one bacteria gets this, the subsequent group of organisms also can develop this. So that is because it causes inducible and non-inducible types of resistance. It can be either chromosome mediated or plasmid mediated. Okay, so they are intrinsically resistant to chloramphenicol, ampicillin, penicillin, sometimes cephalosporin also. So you probably have to think about using a BLBLI, or probably you have to think about carbapenems. So which are the group of organisms? It is space group of organisms. That is your Serratia, Pseudomonas, Acinetobacter, and Providentia, Citrobacter, and Enterobacter. So usually when your culture sensitivity report comes and they tell you this, okay, that the patient has Serratia, Pseudomonas, Citrobacter, look at the resistance pattern. If you find that there is intrinsic resistance present and these patients fall under the spice group of organisms, beware that they are AMC producers, and then you have to choose your antibiotic policy. Okay, so after understanding all of this, enzymatic degradation, gene transfer, etc., the next thing that we need to look at is drug penetration and efflux. Okay, so we discussed about the cell wall earlier, right? What happens there? So in gram-negative bacteria, the targets are located in the cytoplasmic membrane, that is the inner membrane. Okay, and usually whenever the antibiotic has to enter the bacteria, it has to penetrate this layer, okay, and then only it will come inside. So as a defense mechanism, what happens is in the perispasmic space itself, there will be enzymes which are present, which usually deactivate the antibiotic. Okay, so this is one very smart way from the gram-negative bacteria to deactivate the antibiotic. Okay, so the presence of periplasmic space in a gram-negative bacteria usually contains enzymatic machinery, especially beta-lactamases, carbapinamases, etc., which inactivate the incoming antibiotic. Okay, that is one way of causing decreased penetration of antibiotics. Coming to efflux, okay, efflux can happen using efflux pump or pore-in channels. Okay, so pore-in channels are transmembrane proteins. Usually, they allow selective movement of molecules in and out of the cell. Molecules with a weight of more than 600 daltons cannot usually pass. Okay, that is one of the reasons why vancomycin and daptomycin cannot penetrate. Okay, so what are the types of pore-in channels that we are seeing? So it can be specific, especially to a particular bacteria. That is your OMPD. Remember that one. Okay, non-specific usually seen in all gram-negative bacteria. Okay. So it is your OMP-A, OMP-F, and OMP-C. Okay. And next, I told you about periplasmic space, right? So there is something called as antibiotic trapping. What is antibiotic trapping? It is a phenomenon wherein porin expression is low and beta lactamase expression is high, so that a carbapenem which enters the bacteria is trapped in the periplasmic space, and this is getting hydrolyzed by the beta lactamase. Okay, so there can be one particular type of beta lactamase, probably an imipenemase. Okay, so if that is present, then you'll have IRMS type of resistance, that is imipenem resistant, meropenem sensitive. Usually it is seen in Pseudomonas. Usually IRMS happens because of mutation in the pore-in channel, that is your OMPD, which is specific for imipenem. It is chromosomally located and it cannot be transferred horizontally. Okay. Coming to efflux pump, they usually produce complex bacterial machineries which help to remove the absorbed antibiotic out of the bacterial cell. So what happens is bacteria cell will be exposed to an antibiotic enters the bacteria, but this efflux pump will remove it out, okay, by spitting out. Just remember it like it spits it out, okay. So usually what happens because of this, there is reduction in the intracellular concentration of that particular antibiotic, and that is the reason that particular antibiotic will not reach its target site, and thereby it reduces its therapeutic effect and the bacteria will not get broken down. Okay, so this is one of the ways of action of efflux pump. There are 5 major families, just remember them as ABC superfamily, MFS, okay, MATE family, and SMR family. Just remember one of these names. ABC is the easiest that you can remember, ABC and SMR. So coming to the last type of resistance, that is modification of target site. In modification of target site, it can be mutational changes to the target genes, enzymatic alterations to the target sites, or target protection mechanisms. Okay, so mutational changes are seen in fluoroquinolones. Okay, especially because your DNA gyrase and topoisomerase 4s usually are coded by enzymes like gyrase A and PARC genes. Okay, the mutation in this gene itself will reduce the susceptibility for the fluoroquinolone. Again, coming to linezolid for protein synthesis, what happens is again your ribosomal machinery will get hampered. Okay, so that is again because of a mutation which is present in the 23S RNA. In rifampicin, the mutation is because of change in POB gene. Okay, so remember 3 drugs which have developed mutational changes. One is fluoroquinolones, second one is linezolid, third one is rifampicin. Coming to enzymatic alteration of target sites. Okay, so how do they happen? So usually enzymatic modification happens because of lysis of that particular antibiotic once it comes inside the bacteria. Okay, it can happen in the cell wall, it can happen in the cytoplasm. Okay, all of this will make the antibiotic useless. Okay, coming to the last part of this, that is target protection. What does it do? The resistant mechanism develops where the specific proteins, which are often encoded by genes, are located on mobile genetic elements. Okay, so similar to what we saw integrons, right? So this is similar to them. Okay, so they prevent the antibiotics from effectively binding to the bacterial targets. So they keep changing, they keep getting mutated, and the bacteria, the antibiotic will not be able to lock on to its target site. Okay, so usually this type of target protection is seen for antibiotics like tetracyclines, fluoroquinolones, and fusidic acid. Okay, sometimes there will be complete replacement or bypass of the target site itself. So where do we see the complete bypass of this thing? Usually seen in MRSAs. Okay, so methicillin resistant Staph aureus, especially the DHFR, that is the dihydrofolate reductase variant, especially develops trimethoprim resistance. Okay, in such MRSA patients, they develop total resistance, wherein they alter the target site itself. Okay, coming to the summary of all antimicrobial resistance. Broadly, remember, it is classified into gram-negative and gram-positive sites. Okay, if you remember the first slide wherein it showed about prevention of drug reaching the target site, efflux pump, change in targets, or hydrolysis of enzymes, that is more than enough. Along with its right about horizontal transfer and vertical transfer. Remember, horizontal transfer, it has three ways. Okay, vertical transfer, usually it is chromosomal plasmid mediated. Horizontal transfer usually depends on transduction, transformation, integrons. Okay, and transformation. So this is broadly where you can write. And if they ask about individual things, you write few examples for porin channels, few examples for enzymatic degradation. Okay, few examples for target site modification. Okay, so by and large, remember, in gram-negative bacteria, by modifying enzyme, the resistance is seen for aminoglycosides. Porin for carbapenemase, remember that is the easiest. Efflux pumps, remember fluoroquinolones, macrolides, or tetracyclines. Target site modification, remember it is polymyxins. In gram-positive, target site modification, vancomycin. Okay, remember what I told you earlier, right? The size itself is very high. Okay, so large, so it doesn't allow the vancomycin molecule to enter itself. Enzymatic degradation is your penicillinases, carbapenemases, etc. So again, remember your Ambler's classification. That is one question they can ask. In gram-positive, mutation of target site is seen for penicillins, fluoroquinolones, and rifampicin. Okay, so this is about antimicrobial resistance in general. Okay, I hope it is clear. If there's any doubt you have, please reach out to me. Okay, thank you. So there are two more classes which are due for today. That is fluid therapy in sepsis and management of MDR GNB. I'll be doing this class as a live session for whoever wants to join in. The timing of which will be, circulated to you guys tomorrow in the WhatsApp group. Class on breaking bad news and conflict resolution and end of life care is already recorded. It's ready. It will be shared to you as soon as possible. Okay. Thank you for staying with us till 10 in the night. Okay. And sorry for the technical glitches that had happened earlier. Is there any doubts that you guys need to ask?